A very warm good morning to all of you. On behalf of organizing committee, I welcome you all to this first session of second day Fertivision 2020. This is a poster presentation session where we have six beautiful presentations lined up. For judging the presentations, I invite our esteemed judges, Dr. Lata, Dr. Yogita, and Dr. Professor Poonam Singh. Dr. Lata, ma'am needs no introduction. Ma'am is professor and head of department, JIPMER, Pondicherry. Ma'am is faculty of medical education as well in JIPMER, Pondicherry. Ma'am was secretary of Obstetric Gynecology Society, Pondicherry, and ma'am is a resource person for PG training program at Kerala and Kappam. Ma'am has many national and international journal presentations, publications to her credit. I invite you, ma'am, to please join the session to judge the session. Welcome you, ma'am, here. Next, we have Dr. Yogita Dogra. Ma'am is PGI alumnus, and presently, ma'am is pursuing her reproductive medicine DM at AIMS, New Delhi. Ma'am is founder member and scientific secretary of Indian Fertility Society HP chapter. Ma'am is founder member and treasurer Indian Menopause Society Shimla chapter as well. We welcome you, ma'am, here.
Thank you so much.
Next judge is Dr. Professor Poonam Singh. Ma'am is stuck somewhere. In due course of time, ma'am will join us. By the time I request our MOC, Dr. Gitika, to please start the session. Dr. Gitika, you are not audible. No, you are not audible. You need to unmute yourself.
Is unmuted.
So let's start the session. Our first participant is Dr. Priyanka. She has her poster on recurrent H mole in 9 consecutive pregnancies, a rare case report. I request Dr. Priyanka to please start with your poster presentation.
Yes, ma'am. Am I audible?
Yes, you are audible.
Good afternoon, everyone. I'm Dr. Priyanka. My topic for today is recurrent H mole in 9 consecutive pregnancies, a rare case report. So to begin with, H mole is the most common form of gestational trophoblastic disease resulting in an abnormal conception. The incidence is about 1 in 160 pregnancies in India. But the recurrence of molar pregnancy is extremely rare with an incidence of 1 to 2%. And when encountered, it poses a great diagnostic as well as therapeutic challenge for the obstetrician. So we encountered one such case. She was a 31-year-old female, gravida 9, with history of previous 8 molar pregnancies. She was in a non-consanguineous marriage. She came to us at a period of 9 weeks of gestation with complaints of irregular vaginal bleeding. On ultrasound, it was a complete molar pregnancy for the 9th time. Karyotype of both the partners was normal. All her baseline investigations were normal. Her pre-evacuation beta HCG levels were around 83,000 milli-international units per ml. We offered the patient suction and evacuation. After that, whole of the sample specimen was sent for histopathological examination, and there was no evidence of choriocarcinoma, and it revealed complete molar pregnancy. After that, we followed the patient with serial beta HCG monitoring levels, which became negative by the 3rd week. Owing to her recurrent molar pregnancy, patient was advised genetic testing to rule out germline defects. However, she refused for the same due to financial constraints. So we advised the patient for adoption. Now, complete molar pregnancy, it can exist in 2 forms. In most of the cases, it occurs as, it exists as androgenetic complete moles, which are sporadic and which are diploid. Here the ovum is empty or inactivated, and there is fertilization by a single set of sperm haploid chromosomes, which then duplicates after meiosis. This process is known as androgenesis. For such patients, ICSI and pre-implantation genetic diagnosis are the reproductive options. The other type is biparental complete moles, which has been reported in only 30 families so far. It occurs due to autosomal recessive gene defect in the mother, namely NALP7 gene, and it is associated with recurrence and familial clustering. So such patients, they should be offered in vitro fertilization with donor egg or adoption. So to conclude, obstetricians, they should be aware of the possible association of recurrent molar pregnancy with germline defects, and thus there is importance of genetic testing so that they can attain favorable obstetric outcomes, especially in a low middle income country like India. Thank you.
Uh, Thank you, Priyanka. I just want to know, any questions from others? Yogita, you want to ask her something?
Ma'am, please, you may start, ma'am.
She has had 9 pregnancies. I'm quite surprised she has not developed persistent trophoblastic disease. What were her, how did her post-pregnancy follow-up was?
Ma'am, initially after evacuation, beta HCG was repeated within 48
Can
hours.
you come on screen, Priyanka?
Yes, ma'am. Yes, ma'am.
Yeah. Yeah, please go ahead.
Yes, ma'am. So immediately after the evacuation, we did her beta HCG levels, which was around 69,000 milli-international per unit per ml. So there was 15% fall. After that, it was repeated on day 7 and then weekly. And by third week, the levels were negative. After that, she was followed for 6 months. We did her beta HCG every month and they were negative.
No, I wanted to know because she has had recurrent. You think delays? She's been having pregnancies almost every 6 months. Looks like, I don't know. Would a delay in pregnancy would have prevented this condition? And it looks like
the interval between her previous pregnancies was around 1 to 2 years. So which we actually advised to the patient to avoid pregnancy for at least 1 year after molar pregnancy. So we were expecting some germline mutation. But we offered her genetic testing, but she refused for the same because she was very poor. So she could not afford it.
What about her semen analysis? Any morphologically abnormal sperms or anything?
No, ma'am, semen analysis was normal.
Was done. It's normal.
Yes, ma'am. Yes, ma'am.
Okay, let me ask Priyanka. It was a very nice case report. So you can just tell me when should ideally the genetic testing be offered? I mean, you said that the genetic testing should be offered, but after how many consecutive molar pregnancies it should be offered? Like in your case, it was after 9 molar pregnancies. But is there anything in the literature that after 2 or after 3? Because
yes,
I think, yeah. If you can,
yes, ma'am.
please.
Many of the studies, they say that the genetic testing should be offered after 2 or 3 molar pregnancies.
Okay. And if somehow we come to know about the genetic testing results also, would that change the management? Like
Yes,
if patient is having recurrent molar, even after 2 or 3, we can directly, without genetic testing, can we offer her the donor egg or adoption?
Yes, ma'am.
Rather than first, because it is adding to the cost, and
yes,
you said that in low resource countries, in genetic testing is also costly.
Yes, ma'am. Yes, ma'am. The test was around 30,000 rupees, ma'am. Actually, like without genetic testing, without telling the actual cost to the patient, it's very difficult to counsel the patient that straight away go for IVF. They go to some other obstetrician and then she tells the patient that no, you don't have to go for IVF. It's just 2 or 3 molar pregnancies. We can still try. So this is what happened with our patient. That is why we offered her IVF, but she refused for the IVF. So we offered her for a safer option, that is adoption.
But still, she may come back with her own.
Okay. Thank you, Priyanka.
Yes, ma'am. Yes, ma'am. Thank you, ma'am.
Okay. Thank you.
Thank you so much, ma'am.
Dr. Gitika, we can move to the next poster presentation.
Not audible.
No, you are yet not audible, Dr. Gitika. So let's move to the second presentation. For second presentation, we have Dr. Priyanka with Dr. Nimisha with us. She is presenting a poster on twin pregnancy with H-mole and coexistent live fetus and persistent gestational trophoblastic disease, a rare presentation. So I welcome you, Dr. Nimisha. You can please start presenting your poster.
Very good afternoon to this team. Am I audible? Very good afternoon.
Yes, you are clearly audible.
To the esteemed judges. I'm going to speak on twin pregnancy with hereditary form mole and coexistent live fetus with persistent gestational trophoblastic disease, a rare presentation. This case poses a diagnostic dilemma in the prenatal period. We had a 24-year-old who was a gravida 3 para 2 living to previous 2 normal deliveries who presented mid-trimester 19 weeks with hyperemesis since first trimester, and 1 episode of brisk vaginal bleeding at around 17 weeks along with weakness. And also her hematological examination showed anemia of around 6 gram hemoglobin, TSH around 0.02 showed thyrotoxicosis. And we did a transabdominal ultrasound for her. I mean, she had a tachycardia also at admission and a blood pressure of 140 by 90 mm of Hg, just to add on to it. Then we subjected her to a transabdominal ultrasound, which showed a live fetus, breech presentation, corresponding to gestational age, with a posteriorly located placenta. And along that, there was an anteriorly placed huge echogenic mass, which we had a fetal MRI for academic purposes. So the section, showed the same findings of a fetus more near the fundus with the normal attached placenta. And towards the lower part, the os, was the indeterminate echogenic mass. It was around 15 centimeters. Patient was thoroughly counseled and she wanted to continue with the pregnancy, but unfortunately had an intrauterine fetal death about a week of admission under close monitoring. So she was, the pregnancy had to be terminated. Induction with misoprostol was done. At the 5th hour of induction, she had an early placental abruption, and due to unsuccessful medical management of the same, we had to take her up for emergency laparotomy, and evacuation was done, hysterotomy with a bilateral tubal ligation. This patient had refused for a hysterectomy. I mean, though we had taken a consent for it, I mean, she was not very keen on that. The intraoperative pictures, as you can see, evacuate around 1 liters of vesicular molar tissue, and a normal fetus, morphologically normal looking fetus with a normally attached placenta to it, and also bilateral theca lutein cyst around 6 into 7 centimeters. And this picture shows the mounted same. And then obviously we had done a beta HCG for her at admission, which showed an initial hook effect. And thereafter, under dilution, it showed a very high value, around 22 lakhs 50,000. And then on the day 7, she was terminated in view of intrauterine fetal death for the fetus. And this histological pictures on the bottom, the 4 pictures show the hydropic villi, which are edematous, almost nil vascularity. And we had the facilities for IHC staining, and those subjected to for the IHC staining for P57, they were completely negative for the stain. The tissue from the vesicular mass, which showed that it was a complete molar pregnancy. Whereas the picture on the above, on the right hand side, shows a normal vascularized villi of the normal placental tissue. She was kept on post-molar surveillance initially, and the post-operative period was uneventful, except for a mild postpartum hemorrhage, which was managed medically successfully. And post-operatively, initially there was a declining trend. Like for the day 7, the day 14, beta HCG was showing a declining trend. Thereafter, there was a plateau on the day 21 and 35, and the values thereafter. And therefore, for the scoring system was done, and she was taken up. She was given chemotherapy, single agent, day 1357 methotrexate, in view of persistent gestation trophoblastic disease as the diagnosis. After 8 cycles of methotrexate, the values of the serum beta HCG declined to undetectable levels, and thereafter up to 6 months, it was normal. And at this case, like to focus on the clinical features the dilemma it poses to the clinician for the diagnosis, management, and also a very important outcome, apart from the other antenatal complications, is the post-molar surveillance is very essential to detect the persistence of the gestation trophoblastic disease, which happened here in this case. And so we detected it early, and now she is on post-molar surveillance, off till date. Thank you so much.
Nimisha, I have quite a few questions for you. First of all, it's at 20 weeks, right? The pregnancy was at 20 weeks. So you don't really comment on the presentation. It doesn't really matter. Okay, that is the least of the things it should be saying. Why did you people think of hysterectomy? I just couldn't understand. There was no role for hysterectomy in a young patient like this.
In view of
But why hysterectomy?
ma'am, just a consent for a hysterectomy in case peripartum, in case we are not able to do all the conservative procedures for controlling the APH and the.
For that, but not for molar pregnancy person.
Lady, Paris lady, that's what was the entire counseling, that 1 week of admission, because she was admitted for correcting her hematological parameters. She was anemic, and though there was a delay in the diagnosis, ma'am, because initially we were getting like very HCG. We were getting 590, 530. So day 3, day 4 value was, day 6 value was, day 6 of admission was 590. And then we discussed with our biochemistry colleagues, and they did it under dilution. And then just on day 6, we had a surprise. It was 22 lakhs 50,000. And so and that's done.
Okay. How much was that abruption? I mean, I still didn't understand, why did you have to do a hysterotomy for a molar pregnancy? I mean, you said abruption, but was it so much that she couldn't have delivered?
She had brisk
bleeding.
bleeding.
Expelled, not delivered, expelled, yeah.
She had brisk bleeding PV. We gave her first dose of mesoprostol, around 6 p.m. we had given. The next dose came around 10 p.m. and just 1 hour after the second dose, she had torrential bleeding with passage of grape-like vesicles, and clots were there. And only one finger, 1.5 centimeters cervical dilatation was noted at that time. Probably she was in early labor. But,
so the vesicular mole, whatever, was diagnosed only post hysterotomy. You didn't diagnose it earlier.
And we diagnosed by the fetal MRI, which we have for the academic purposes, they do. That showed the hyperintense area with the entire 15 into 15 centimeter mass.
I mean, I'm surprised how it wasn't detected on ultrasound, because the typical, the way the histopathology specimen was,
it was detected, ma'am. Around 1 liter was evacuated, but ultrasound showed a mass, ma'am. It was a huge mass on ultrasound, just because they had another fetal MRI, and maybe a project.
Maybe you people have missed because of so-called abruption or whatever clots. You missed it on ultrasound, but otherwise it's a straightforward diagnosis with so much of vesicular mole tissue. Should be a straightforward diagnosis on ultrasound. Anyway,
I mentioned in the ultrasound that we had a huge mass on.
The mass is different from the typical appearance of, what is the appearance you get on ultrasound?
The honeycomb, the typical honeycomb.
Snowstorm appearance, yeah, that cannot be missed with such a big mass. Anyway, it doesn't matter. For you, there was no dilemma because luckily it ended up in an IUD. Otherwise, I agree it could be a dilemma. But what I want to know is, suppose the fetus was alive, okay, there was no abruption. What would you have advised the patient?
Ma'am, close follow-up. The counseling should be very realistic. The antenatal complications she would land up in.
What is the risk of the fetus developing malformations, first of all, and other complications? So should you continue the pregnancy or should you terminate the pregnancy if it was a live fetus?
Ma'am, if it was a live fetus, after the karyotyping which has been done by the prenatal diagnostic testings, then we can offer her.
Remember, we have to be realistic. All cannot afford it. So forget about karyotyping and all those things. Just without all that, how will you consider? There are still a lot of patients who can't afford, right? So
we can offer her continuation of pregnancy under close.
That is something which you don't have to insist on termination. Yes.
Which show live birth, maybe preterm or little, around 34 weeks. There are many case reports. So it's a realistic approach. We can.
Of course, you can offer them for termination also, but it is not necessary. That's what I want people to, drive into you people. It's not necessary, and the risk is not that high as we think. The high of anomalies. But yes, she may develop preeclampsia. Those things are there. Eventually, she may end up in termination. Thank you, Nimisha.
Thank you so much.
Anyone else?
Hi, Nimisha. Nimisha, I could not see any review of literature on the management part. Actually, it should be there in your poster, because I think in this case you are managing a big complete mole with IUD. It is not a live fetus. Actually, you managed a IUD with a big complete mole at 18 weeks. So whatever management you did, was this actually the justified management for this patient, because your patient landed up actually ultimately in the hysterectomy. So is there any literature review on this, how people have managed earlier such type of cases, and if you could take any precautions prior to, managing such cases, just by taking the consent that if, okay, we might have to do hysterectomy, this does not, end up the problem. So could you find any literature review on this?
Yes, ma'am. There are many reports which, there's high risk of antepartum hemorrhage due to preeclampsia or otherwise because of over distension. And so the blood products have to be kept ready. And here we did like quite of blood transfusion.
Because the patient, when the patient has presented to you, she did not have any of these features. She just had live fetus with a big molar pregnancy along with it, coexistent. And after a week, you said it was IUFD. And before you induced that patient, she did not have any, APH, nothing she had. So I think prior management, prior making a plan of how to induce, what all to be kept ready, what all, because the patient landed up in hysterectomy for a molar pregnancy, which was a very big, which could easily have been diagnosed, and you have diagnosed it on ultrasound, you already said. So
actually, I think anticipate in the part of there was a detailed counseling. She had one episode of breast bleeding PV or mild bleeding PV at around 17 weeks. She was anemic, 6-gram hemoglobin. She was already at a high risk of hemorrhagic complications.
So you transfused blood prior to induction, because
we had a live fetus and she was involved for correcting the parameters basically. Because
okay, when IUFD was diagnosed, then
and it was till then, that was diagnosed on day 7 of the admission. And from day 1, I think almost 4 packs cells were transfused, and the latest hemoglobin at the time of laparotomy was 10-gram hemoglobin. And she had a mild increase in blood pressure also, 140/90 at admission. But all the pH investigations were almost normal for her, except for a TSH, which other TSH was low, hemoglobin was low, and the beta HCG was showing a little bit of a hope effect. That's what when I refer to the literature, because of the very high values, it was almost showing like 590 and all that. Apart from
I would like to say something, to cut short whatever. See, misoprostol is not the only method for induction, especially in second trimester.
Yes, ma'am. Yes, ma'am. That is what I wanted to say.
Police is a very good method. Extramnetic, of course, we don't have nowadays sitagliptin. Otherwise, it was very good. Prostatin is excellent. Misoprostol really doesn't, the ripening is not as much. We even have problems with term pregnancies. So you have to think of various methods, and always better. Police has
yes.
of dilating and also ripening. So your misoprostol add better, because for vesicular mole, hysterectomy is something which we should totally forget.
Yes, ma'am.
That is something you should take in. Okay.
Actually, at the midnight hour, she had a breast bleeding. So we had
no, that's fine. Even with abruption, I'm telling you, it's not you're replacing. Anyway, she had, until she bleeds profusely, I don't think she has bled that much that you had to do an emergency hysterectomy. That is, you should have put a Foley's, it would have dilated, and you can even give misoprostol along with it, so that it will hasten the delivery, especially 20 weeks.
Were deteriorating, ma'am. The vitals and all, they were deteriorating, and so we had to take, there was a senior obstetrician also called for it.
Yeah, I agree. Maybe something has missed before because she has deteriorated so much. If you're diagnosed earlier, maybe. Anyway, there are always this way, that way, nothing is perfect, but keep it in mind. Don't even think of only misoprostol. That's all. Thank you.
Yes. Thank you so much.
So, thank you, Dr. Nimisha, for this nice presentation. Let's move ahead fast to the next presentation, that is by Dr. Ashutosh, and the topic is biomarkers in PCOS. Welcome, Dr. Ashutosh.
Good afternoon. This e-poster is based on PCOS various biomarkers. And total number of cases were 131. Out of 131, phenotype A was the predominant group, 87. Phenotype B were, 23. phenotype C8 and phenotype D, 13 cases. And we tested for all available biomarkers, androgens, all kind of androgens like testosterone, dihydrotestosterone, androstenedione, dihydroepiandrosterone sulfate, FAI also, then LH, then we tested AMH, and many other inhibin B, leptin, everything we tested, whatever literature reported, and advanced glycation end products. And we analyzed our data with group wise, and there were 49 normal control women. And we statistical values were derived from Mann-Whitney U-test and ROC curve analysis. And also we did correlation between AMH with other parameters through Spearman rank correlation test. So we found that among all markers, AMH is the best. AMH was 10.05 nanogram per ml in study group, whereas in control around 2.69 nanogram, and it's highly significant. P-value is maximum. And if we take the cutoff, means mean plus 2 SD, 5.7 nanogram per ml, we can pick up 74% cases of total PCOS cases, but this figure is better with phenotype A, around 81%, and for phenotype D was around, I think, 78%. Then area under ROC curve, we got overall 0.9332, so good with better in phenotype A and phenotype D. Phenotype A means all three features of PCOS, means hyperandrogenism, then polycystic ovarian morphology, and ovulatory dysfunction. So there it's a very good, it was probably 9.96. And for phenotype D, where on no hyperandrogenism, rest two are present, we got 0.95. So ROC of 0.9 or above is a very good indicator and can be used as a diagnostic markers. So none other markers is very close to this AMH value. So we also looked difference between pubertal as well as post-pubertal groups of AMH and BMI, FGS score, age, many correlations, BPA. This correlation study, we found that AMH is not correlated with any other confounding factor. So it's a very good marker. Even high BMI, low BMI, no difference for AMH differences with BPA, with age, and everywhere. It's a very good marker. So we suggest that probably AMH should be taken as a diagnostic marker of disease.
Are you done with it? Are you done?
Yes, I have done.
Why did you do this study? Is there anything new which you found out in the study?
We found out that AMH see, literature, what you will get, they have AMH value in all PCOS. And PCOS in Western country mostly type phenotype A. Group-wise is not analyzed in most of the literature. And recently, they said that probably AMH can be a diagnostic marker for PCOS. It's not only a diagnostic marker, but probably in some subset of PCOS cases, maybe etiological factor also. So because of that, we took all the biomarkers available known to with PCOS, analyzed and compared, and we found that compared not only all the markers but phenotype wise. I agree that our maximum number of cases were phenotype A, phenotype D and C were very less, 8 and 13, it probably not going to alter the conclusion, may not be that significant, but phenotype A wise, it's
Another thing I want to know is whether you've done it in infertile couple or it's, women, or you have done in all age groups.
These are the presentations. We have taken infertility.
No, that's okay. I just want to know. You have not specifically done only for infertile women,
Yes,
right?
it's
for
not
everyone.
specific because
Okay.
around 20%, more than 20% were below 20 years old.
Okay, fine.
So it's hirsutism, hyperandrogenism was the major
No problem.
factors.
No problem.
So infertility is just maybe 50% is married. So
Hello, sir.
yes.
Sir, can you give any cutoff value based on your study? Like
Yes.
5.7 and 10. So can you give any cutoff from your side? Like from your side?
Our cutoff value by the mean plus 2SD was 5.7. And but through ROC, it's probably 5.3.
Okay, sir.
And sensitivity is for phenotype A is 81%, and specificity is it's only in control. 2 cases were positive, so it's 92% nearly.
Yes, sir.
So
yes.
it's a we can take as a diagnostic marker. So even literature search we did, we found that literature they have taken 5.3, 5.4, 5.5, or maybe in Japanese is over 10. Japanese and Korean over 10. So I think in North India the major group of PCOS are phenotype A, which my observation, but in the eastern part as well as western southern part, it's a phenotype D is the predominant, where their hyperandrogenism is not a common features. Polycystic ovarian morphology and ovarian dysfunction, these two are the major features, like in Mumbai and in Calcutta, even in South. So our features is very close to Caucasians pictures, and their cutoff is 5.4, 5.5, and we got 5.7. So I think consistent with the literature, what we found, and
still, sir, but still we can, yes, sir.
Yes.
So still we can say, like in your study, you have said like almost 81% could be diagnosed with these high AMH values as PCOS. But I think in IVF, in our infertility practice, we cannot just miss those 20% also based on AMH values. So although AMH, we can use it as a potential marker, but still I think in the clinical practice, we need to correlate this AMH with the clinical features as well.
Yes, yes. So, see,
yes, sir.
When you will ask for AMH, first is a syndrome. Yes. You need either 2 of the 3 features. Then AMH comes high. Then you can confirm, have a confidence that yes, we are.
We can only say that AMH.
Another thing I would like to say that in secondary PCOS CAH, we have many cases of phenotype B, which are tend to be CH, and their AMH will be lower, just normal one. So it's distinguish your CH cases also. And phenotype B has a maximum CH case.
CH cases, yes, sir.
Okay, thank you.
Yes, sir.
So let's move fast. Thank you, sir. So let's move fast to the next presentation by Dr. Raj Lakshmi. I just want to emphasize here that we are running a bit short of time. So you please present your presentation, your poster in short, if you can.
Yes, ma'am. Good afternoon, yes, respected judges. I will be presenting my study on vitamin D supplementation in insulin-resistant polycystic ovarian syndrome women. It's a randomized control trial. Ma'am, as we already know that almost 67 to 85% of the PCOS women are vitamin D deficient. And evidence suggests that intake of vitamin D supplements might improve lipid profile and insulin resistance. In this study, we have taken vitamin D supplementation along with metformin. Metformin, as we know, that it is an insulin sensitizer and it's useful in PCOS women. So we combine metformin, which we used in both the groups, with vitamin D. Vitamin D doses was 1000 international unit in first group and 4000 international unit in the other group. This was actually the range. And the upper limit of vitamin D supplementation for adults in India is almost 4000 international units. So we chose this regimen. So this is a prospective randomized control trial. And we included women with PCOS in the reproductive age with HOMA-IR more than 2.5. Those were insulin-resistant women. And vitamin D levels less than 20 nanogram per ml and BMI less than 30 kg per meter square. The first group, that is the low-dose vitamin D group, received 500 milligram metformin twice daily with vitamin D3, 1000 international unit for 3 months. And the other group, the second group, the high-dose vitamin D, it received the same dose of metformin along with high dose of vitamin D. And we followed the patients, both the groups, at 3 months. So we had 110 patients with PCOS who were assessed for eligibility. And finally, we got 72 patients and randomized them into 2 groups, 36 in each group. It was seen that both the groups had similar baseline characteristics. And the mean vitamin D levels in group 1 was 14 plus minus 3.76 nanogram per ml. And in group 2, it was 12. Means all the patients were vitamin D in our study, low vitamin D in our study. And after intervention, it was seen that the low dose vitamin D supplementation group and high dose supplementation group, there was statistically significant improvement in levels of vitamin D, postprandial blood sugar levels, fasting insulin levels, HOMA-IR levels at baseline and at 3 months follow-up in both the groups. So both the groups had statistically significant improvement in these parameters. But when we compared what was the improvement level in both the groups, we saw that at 3 months follow-up, the group 2, means the high dose vitamin D group, had higher improvement, which was statistically significant in terms of mean Fertivision score, in terms of vitamin D levels, postprandial blood sugar levels, fasting insulin levels, and HOMA-IR levels. And so we've concluded that if we add vitamin D along with metformin in insulin-resistant PCOS women, it helps to improve the clinical parameters and the hormonal parameters and the metabolic parameters in these women. But because this was just a single center study, we cannot say that these results can be generalized. So, and moreover, the levels of the optimal doses of vitamin D is still not clear because it is a big range, 1000 to 4000 international per day. So more RCTs are required to confirm the efficacy of both upper and lower limits of vitamin D supplementation in such women.
Thank you, Rajlakshmi. My query was, you've added, for both of them, you gave metformin and then you've added vitamin D. My question is, have you tried, first of all, only metformin? How do you know that vitamin D has improved this? Because
yes, ma'am. Yes, ma'am. Because in the inclusion criteria, we had selected only those women who were vitamin D deficient.
No, that's fine. See, vitamin D deficiency, if you take university, all the women will have.
Yes, ma'am.
Thing is, why don't you think metformin itself would have helped? Why do you think the addition of vitamin D has helped in these people? Until given metformin, seen the levels, and then if they're not improved, adding vitamin D would have been a better study rather than directly putting them on both.
Yes, ma'am. Ma'am, actually, we are working on this PCOS women. We had initially done the study on metformin only.
No, I'm telling the same women. The same women whom you have given vitamin D, right?
No.
You have not given only metformin. How do you know it's not the effect of metformin and it's the effect of vitamin D? You give me vitamin D, my vitamin D levels also will go up. Okay.
Yes, ma'am.
So your study would have been better if you had chosen patients who have failed with metformin and then added vitamin D among these people rather than, and you have not seen that earlier, right?
No, ma'am, we have not seen. We just wanted to see the synergistic effect. Yes, ma'am. We have not seen the individual effect of both the drugs. Yes, ma'am.
And you have not looked at their consumption rates or anything like that. You've just seen whether even otherwise vitamin D levels would have gone up. You needn't have added
yes, ma'am. But the other parameters also improved, like the clinical global acne scoring, the mean Fertivision scoring.
What I'm saying is, even metformin would have done the same thing. We don't know in these women.
Yes, ma'am. We just wanted to say that the combined drugs have synergistic effect and it leads to improvements. Yes, ma'am. I'll just take into care that we can plan a study on that also.
Yeah, Yogita.
Hello, Raj Lakshmi.
Yes, ma'am.
I just want to ask you one thing, that how this study is adding anything new to the literature.
Yes, ma'am, that it's adding new to the literature, ma'am, because I think very few studies are there which combines both the vitamin D levels and to
But
see.
as said, ma'am is right in the sense that you should have actually one arm with metformin only. Then only you can say na, that this effect is because of vitamin D. When you added vitamin D, then this effect came at this low dose, then this high dose. In any case, vitamin D, you supplemented your patients with vitamin D, either low dose or high dose. In both the cases, there was improvement in all the parameters.
Yes, ma'am.
So ma'am is right that there should have been another third arm also, in which you would have given just the metformin to see the effect of vitamin D, because we cannot say that this effect is because of what. Vitamin D is deficient, even we will be vitamin D deficient.
Yes, ma'am. We are also deficient.
It will,
yes, ma'am.
And today's supplementation will lead to,
Yes, ma'am.
That you can do a before study, exactly like what I said, no? Same set.
Yes, ma'am. That can also be planned. It will be a more better study. Yes, ma'am.
Thank you.
Thank you, ma'am.
Thank you, Dr. Raj Lakshmi. Now we move to the fifth presentation, that is by Dr. Pujari. We welcome you, Dr. Pujari, for your presentation.
Hello.
Please keep it short as we are running short of time.
Yes,
please. Yes.
Good afternoon, everyone. I'm Kirtana from Kasturba Medical College, Manipal. I'm here to present my poster entitled Curcumin Nanocrystals Mitigate Cyclophosphamide-Induced Testicular Toxicity. Curcumin, a natural antioxidant, in its a nanocrystal formulation, it has improved bioavailability. In the present study, we synthesized nanocurcumin and characterized it using scanning electron microscope. We performed two sets of experiment in prepubertal animals to check if curcumin protects the testes from the cyclophosphamide-induced damage, and in adult mice to see if it protects the sperm functional competence. When the dose of nanocurcumin selected here is based upon our preliminary work, we observed that the lipid peroxidation level when nanocurcumin was given in combination was reduced significantly. So based upon those observations, we performed mRNA level expression for several antioxidant genes. So we saw that the antioxidant genes such as SOD, GPX, catalysis were significantly elevated in the combination group, which was downregulated in the CP alone group. We further looked into the DNA repair mechanism and apoptotic response, so such as P53 BAX, PCL2, cytochrome C, Cas3, and RAD51. The repair mechanism was also improved in the combination group compared to the CP alone treated group. To validate our findings with prepubertal animal, we used adult mice. In this, we used two sets of groups in combination. That is, one is single dose where nanocurcumin was injected 1 hour prior to cyclophosphamide, and the other group is multiple dose where nanocurcumin was injected every alternative days for 4 weeks until dissection. We assess the testicular weight, the sperm concentration, and progressive motility first. In all these parameters, the cyclophosphamide treated alone group had significant decline in all these parameters, which was improved in the combination group, both in single and multiple doses. And it was significantly improved in the sperm concentration. We further looked into the sperm chromatin maturity and the DNA, morphology by CMA3 assay and the short staining technique. The incidence of chromatin immaturity was significantly higher in the cyclophosphamide treated alone group, and it was significantly decreased in the combination groups. The same trend was observed even in the morphology group as well, where the abnormal morphology was reduced in the combination group. To conclude the results of the present data, administration of curcumin nanocrystals mitigated the cyclophosphamide-induced testicular damage. It improved the sperm parameters and chromatin maturity. The antioxidant property of nanocurcumin reduced the oxidative stress and DNA damage in the testes, altogether displaying the beneficial effect of nanocurcumin. These are my key references. Thank you.
Nice, your Pujari, right?
Yes.
Kirtana.
Yes.
It's looks like a good study, of course, but then how applicable will it be in humans?
Clinical
Uh,
application, yeah.
yes, we have to do further studies. I am not saying that we can imply that directly to human aspects, because our main aim was to use nanocurcumin as a chemoprotective agent. Because as we see, when any kind of chemotherapeutic agent is used, it targets all the dividing cells, including the non-target gonadal cells. So we first wanted to see if the combination treatment helps in avoiding the damage caused by this cyclophosphamide. So in future, we will be adding cancer cells and seeing how, if it will act, if the action is restricted to the target cells, but not like hindering the action against the anti-cancer drug.
So what I want
That
to
we
know
can
is,
imply.
yeah,
Yeah.
there are a lot of antioxidants. Did you compare that with, I mean, with this curcumin, that to nanoparticle, it must be very expensive. Do you think giving ordinary antioxidants available would be better? I mean, at least it will be cheaper for.
The reason why we chose curcumin is, as we know, in Indian spices and even in any kind of Indian cuisines, the common additive is
Yes.
curcumin. So that is the one of the reason why we used curcumin as the antioxidant. Yes, of course, we can compare with several other antioxidants that are available, which we will plan on in the future prospect.
Thank you.
And Kirtana, for how long you advise to give this natural antioxidant to have this effect? Like for how long, and the effect lasts how long? Like for if we can actually correlate this study in with humans, taking in view the humans, Hana. So
Yes.
for how long you advise to give this natural antioxidant?
This
For
natural,
usually we advise 3 months. Yeah.
since it's a dietary supplement, they can take it on daily use. But right now, we are exploring in the nano formulation perspective. So, as we know, like there are several literature, and it is proven that curcumin in its crude form, it gets the bioavailability is reduced. So, if they are taking as like a regular supplement, they might have to take little extra of curcumin. In case of nano formulation, if this works, we can give it in the form of a capsule maybe to improve the availability, bioavailability. Just like how we give a vitamin or other antioxidant supplements, even nanocurcumin supplements can be given as a treatment.
Majority
And
of
will it
this with
and
water.
will it affect if
Hmm.
yeah?
Sorry?
And will it have this so-called effect if even if we start prior to starting this chemotherapy?
Yes, that's why we have given 1 hour prior to the cyclophosphamide treatment here. The combination treatment here, we have given nanocurcumin 1 hour prior to cyclophosphamide. And overall, if you're asking if we can supplement nanocurcumin throughout, there are several literatures in the literatures which support that supplementation of oral consumption of curcumin has improved the antioxidant level, and in animal studies it has shown to improve even the sperm parameters. So probably it will have a positive impact. I cannot say definitively because further studies are required in that area.
And you'll have to
Thank
continue
you, Kirtana.
Thank you.
chemotherapy. Yeah.
Sorry, ma'am.
Till they finish chemotherapy, they may have to continue it. Yeah.
Yes, that's the idea of the study.
Thank you.
Thank you.
Thank you, Doctor. Next, we invite our last participant, Dr. Satish, for his presentation. Dr. Satish, are you there?
Yes, thank you all. Especially thank you, Lata Madam, Dr. Dr. Shiksha, and Dr. Kitika. My topic is the potential association between poor semen quality and cardiac autonomic dysfunction. In this study, we tried to find out whether any correlation between the male infertility and autonomic dysfunction. but in spite of taking all autonomic function test, we included only cardiac function test, only that is a heart rate variability, and we try to study the semen analysis and its correlation with the heart rate variability. So in our hospital AIMS Patna, we are running the andrology laboratory. Most of the patients are referred from various clinical departments for their infertility complaints. So few of the male partners are most of the male partners are infertile, and few are fertile and healthy. So we collected randomly all these semen samples and entered the data, and to it in this COVID era, we try to study this our data, and we found that this infertile males, and simultaneously we recorded the heart rate variability. Most of the patients visiting to our department, we have simultaneously nearby autonomic function lab, and for 5 minutes only we can record the heart rate variability. So we recorded the heart rate variability also, and uh, we tried to study the data. We found that this infertile patients had decreased heart rate variability parameters, and there is a decrease in parasympathetic component and increase in sympathetic component. So most of these patients of this infertile group are suffering from this stress. It indicates that most of the patients suffering from this infertile group are suffering from this stress, and vice versa. Those patients are also under stress. They may also have this poor quality of the semen. So this reduced heart rate variability, it is one of the early indicator uh, to find out the stress in today's era, and this semen analysis also very reflects the men's health. We can we can undergo immediately, we can advise, and patient can undergo the semen analysis at the very low cost, uh, and uh, this stressed people, they are having disturbed autonomic function test, and vice versa, the stressed people also are having uh, poor semen quality. That we tried to found out, and we got this result. Thank
Okay. And thank you, Satish. That was a good presentation. But I just want to know, did you take men with poor semen parameters, or you took all those men who were coming to your andrology lab? I'm not very clear about that.
No, madam. We took all patients and entered the data, and finally we studied it that HRV of the patients. We divided the two groups. All
No, no,
patients.
that I understood. I just wanted to know you had included both. I mean, anyone who was coming to your andrology lab to do the parameters. So this is a known fact, right? I mean, people who have poor semen parameters do have some kind of autonomic dysfunction. So anything you could have done better to improve your study quality, or you could do in further future to
Yes,
see
madam.
whether it is really because of that.
Yes, madam. We are still, the study is not yet complete. It is
Mhm.
going on, and
No, what I'm saying is, what can you add on to it so that you know there is definitely some association, or is it
yes,
poor
madam.
quality? Is these two are not really correlated. Stress is definitely there. So stress is leading to abnormal autonomic function and also abnormal parameters. How do you think whether these things are really correlated? What would you think prove your results better? Asking the patient to do something so that.
Yes, madam. We can intervene. We can intervene them, that we can remove the stress. We can advise them to avoid the stress, change in lifestyle,
Yoga,
yoga,
maybe that is one
Yoga,
suggestion
yes.
I can
yoga
think of.
also.
Yoga.
So, madam, that like that after intervention also we can check their semen quality, and we can check that whether the stress and relief from
No,
stress.
and another thing, semen parameters, they keep changing. It's not like once they're abnormal and with one, estimation of abnormal semen parameter, you can't really say they're poor quality. How many times did you assess the semen, do the semen analysis before you really
Yeah, yeah.
saw the
For
autonomic
azoospermia and
function?
poor oligospermia patients, we are checking their semen for at least 3 times before giving the this report. Those patients from this azoospermic samples, or those patients from severely oligospermic below 4 millions per
Okay.
million, that we are going to check another 2 times. Then we give the final report. So it is there. So advice of this change in lifestyle, yoga, and these things, we can plan that again recheck their semen quality after cycle of the this sperm cycle, that is after 70 days or
And yeah, numbers may not be much in the group which had normal semen parameters. So it's really difficult to say whether it's associated or not until unless you have huge numbers. This is okay, a preliminary study.
yeah, yeah, madam.
But, yeah.
Yes.
Sir, I want to ask one thing. Could this cardiac autonomic dysfunction be related to other underlying conditions as well, like underlying cardiac disease, hypertension, or diabetes, or some age-related? Because I think these factors are not taken into account, or somehow it is not there in your inclusion criteria. Because if the patient is already having these comorbidities, or if the patient is elderly, so probably this cardiac dysfunction might be because of that. And associated poor semen quality also. So can we
So we included
do you have taken these factors into account
yes,
in
yes.
your study?
We kept the exclusion criteria. We removed those patients when excluded those patients are suffering from hypertension, heart disease, and other chronic diseases. That's why we are getting very less sample at present. We got those patients
Okay.
also, but we are not included in our study. That's why this is one of the limitation. That's why we have very less number at present, but still the study is going on. We have excluded, madam, such patients. Those are suffering from chronic diseases and heart diseases, or those are taking antihypertensive and other drugs that may affect the autonomic functions.
Yes.
So
Yeah.
that
Thank you, sir.
so itself, madam, fertility itself is causing stress and mental trauma. If you see that
That's
patients
true.
visiting to our clinic, they are very much stressful because they are not getting children. Their wives are not getting conceived, and this fertility itself is a very much stressful. That we
Yeah.
want to say in our study that fertility is very much
Sorry for
stressful.
interrupting. We are running short of time. The next session is
Yeah,
about to be
Shikha,
started.
we are
We are
done.
done.
We are
We
done.
are done.
Thank you.
So we need to conclude the session. I want to thank our esteemed judges, Dr. Lata and Dr. Yogita, for sparing out their valuable time. And yes, I congratulate our esteemed participants for their wonderful presentations. So now it is the time to move to the next session, the session for oral presentation.
Hi everyone, I welcome you all for this oral paper presentation session for Fertivision 2020. And so I would, without wasting much time, I would want to invite and introduce our judges. Are you able to see my screen?
Yes. No.
Yeah, now?
No.
Now?
Yes. Yes, yes.
Just a second. Yeah, now?
No.
No.
We could see it earlier.
Okay, can you see now? Okay, anyway, the judges that we have for today are Dr. Leena Vadwa, Professor and IVF in charge, Department of Obs and Gynae, PGI MSR, West Sadarpur, New Delhi, Dr. Shilpi Sood, Director and Consultant, Safal Hospital and Diva Fertility Center, Consultant at Wokhard Hospital, Nagpur, and Dr. Vinita Jain, Professor of Department of Obs and Gynae, PGI Chandigarh, and she's a certified robotic surgeon. So I welcome all our esteemed judges, and now I invite our first presenter, Dr. Vani Malhotra. Her abstract number is 1, and with the title Awareness Amongst Adolescents Must for Timely Diagnosis and Management of PCOS. Over to Dr. Vani Malhotra.
My slides are visible, I think.
Yes, yes.
Okay, I'm starting my slideshow. Yeah. Good morning, everyone. Today, the topic of my presentation is awareness amongst adolescents.
Please be louder. Can't hear you.
Awareness among adolescents must for the timely diagnosis and management of polycystic ovarian disease. Is it? Am I audible, ma'am?
Yeah, better.
So, as we already know that polycystic ovarian disease is a common adolescent problem which we are facing, which is also known as teen Leventhal syndrome, and its incidence varies from 2.2 to 26%. It's a very embarrassing and frustrating condition, mainly for the young adolescents, as they present, and mostly the facial features, they are frustrating and embarrassing for these young adolescent girls. So the aim of our study was to assess the awareness about this disease, this deadly disease, and to see its association with the various demographic profile among the adolescent young college girls who are from the non-professional colleges. And once we assess the awareness among these girls, we spread, after assessing the awareness, we spread the awareness about the disease through the video assisted teachings to these girls so that they can early diagnose, we can prevent the disease, and they can be timely managed for these diseases. So we conducted this study on 150 college girls, which were BSc girls from both from medical and non-medical stream in the age group of 18 to 25 years, and we selected 3 colleges, and the students were selected randomly. After they gave the consent to be in the study group, the informed written consent was verbal as well as written consent was taken, but the anonymity and confidentiality of these women, these girls, young girls, were maintained, and they were provided with a self-structured knowledge questionnaire, which consisted of very simple questions. About 40 questions were put to these young girls, and they were regarding like what is the disease, which organ is it involved, what are the common symptoms, and where they have gathered the information, and what is the effect of what is the long term effect of this disorder on the other organs. So very simple questions were asked from these young girls in form of a self-structured questionnaire. We had a key with us, and these questions were assessed later on after collection of the data, and each correct answer was given 1 mark, and the incorrect answer was given 0 mark. And this questionnaire was assessed as poor, average, and good according to the scores the analysis of the scores. Poor was 0 to 13, average scores ranged from 14 to 27, and the good scores were 28 to 40. Along with the questionnaire, we collected the socio-demographic data of these women and the education details of the girls, whether they're from medical stream and which year they belong to. Later on, the statistic analysis was done by calculating the data, and the chi-square was applied to know the association of various socio-demographic variables with the awareness or the knowledge obtained from these data. So basically, this was a conceptual framework in which we provided the input to these patients in form of a questionnaire. We tried to assess the awareness through a self-structured questionnaire, and once we assess the questionnaire, once we assess the awareness through the self-structured questionnaire, we taught them. We taught them about the pathology of the disease. We taught them about the various signs and symptoms of the disease, and we taught them how to change their lifestyle modification. So basically, it is a community-based study to spread the awareness of the disease among these non-professional college attending girls. The observations which we observed were that majority of the female were in the age group of 22 to 25 years, and majority of the females, the young girls, they were unmarried, and most of them were from the rural background, as we have seen in our state of Haryana, and most of them were from the joint family, 60% from the joint family and 40% from the nuclear family. So the 52% of the girls, they were from the medical stream, and 48% of the females were from the non-medical stream, and almost equal distributions of the year of the study, because we have randomly selected the students. Majority of the female mothers, they were educated up to secondary education, up to +2, and the and most of them were the homemakers. When we assess the occupation of the mother, they were majority of them were homemakers. And the source of information they gathered about PCOS were, in majority of the patients, girls, they gathered the information from the friends, teachers, and relatives. In 43% of the patient, and in about 36% of the patient, they uh, they were aware of the disease from the mass media like newspapers or internet. So when we analyze the existing awareness of these girls, we found that the majority of the girls, that is 78% of the girls, they had only average intelligence, average awareness about the disease. Only 1% of the one girl had good awareness of the disease, and 32 girls, that is 21.3%, they had poor knowledge about the disease. So, and when we analyze the data, the mean score was around 16.52, and the median, and the most common figure out of 40. Out of the score, the most common score was 16 out of 40. We applied the chi-case test to analyze the association between the existing awareness and the selected demographic variables, and we found that there was a significant association between the awareness, between the existing awareness and the stream of the study, whether they were from, means that the medical students were more, they had more awareness and about the disease as compared to the non-medical streams, and if the mothers education good, the girls were more aware about the disease, and the rest of the demographic profiles, they had no significant association about
sorry, excuse me, sorry, Dr. Vani, your time has run out.
Okay, and then I'll take only half minute.
Yeah.
And they were told about all these videos. Then they were taught about the video assisted teachings about the various lifestyle modifications, like how to do the exercise, what is the nutrition for PCOS, what diet they should take, and how to maintain their diet. And I will conclude by saying that the improvement of education and the lifestyle patterns will prevent this deadly disease and will lead to early diagnosis and treatment of the disease. And we should do these community-based studies to enhance the awareness among the girls so that they can consult the doctors early and prevent this deadly disease. Thank you.
Yes, thank you. Over to the judges for questions.
Dr. Vani, your conclusion is that the awareness will lead to better diagnosis, but your results don't show that, because you have not shown any improvement in the awareness depending upon the intervention that you have done. After the intervention, you have not checked their awareness level to make the conclusion that you have made.
Ma'am, we did not, that was a one-time study only, and we
Okay.
have, then we are doing the studies on the other girls and the other college girls also, and that will be part of the second study.
I agree with that, but then you cannot come to this conclusion that intervention will make. Your conclusion said that the awareness will be improved by intervention, which you have not studied in this particular study.
In this study, I did not include the post-teaching awareness. I did not take up the post-teaching questionnaire.
Yes, Dr. Vani.
Yeah.
Yeah, that's a good community awareness study that you have taken up. And I agree with Dr. Vanita that it will be good if the second part is done and then the conclusion is made. And the one question which I want to know is that specific to PCOS, what questionnaire were included in your study? That detail hasn't come up.
Ma'am, because of time constraint, I did not include all the 40 questions. They were very simple questions like what PCOS is a disease of which organ, what are the main symptoms, and is hirsutism a part of PCOS, and other things like very simple questionnaires.
Yeah, but it would have been good that if you would have included it in your slides.
Ma'am, they were 40 questions.
Okay.
I could not complete my presentation in if I included that.
Okay, maybe it can be done. Dr. Shilpi.
Dr. Vani, Dr. Vani, did you include the duration of treatment all the girls have taken before taking up the questionnaire?
Ma'am, they were not the patients of PCOS. We just judged the awareness among the these girls whether they know about the disease or not. They were not already taking treatment. They were just judged for the awareness of the disease.
Okay.
So now I think there's time to it's time to move on to the next presenter. Yeah. So next we have Dr. Komal Preet. Her abstract number is 18 and her title is AMH and its correlation with glucose intolerance and metabolic syndrome in PCOS women. So over to Dr. Komal Preet. Please share your screen. Dr. Komal, have you unmuted yourself? We can't hear her. Hello, Dr. Komal. Shivam, is there some problem?
Maybe there is some problem with the mic. Can you forward so I can? We can go to Anupam Bahadur in the meantime.
Yeah, but she has shared her screen. I think I'll give her a call. Just a second. I'll call her up. Dr. Komal, are you there?
Dr. Sukriti, I will give her a call. You
okay.
Can, yeah.
Okay, then do we have Dr. Anupama here? The third presenter?
Yeah.
Yeah, Dr. Anupama, please share your screen. Dr. Anupama's abstract number is 24 and her topic is anxiety, depression and quality of life in infertile women, a study from a tertiary care center.
Thank you, respected chairpersons and dear friends. So we are going to present anxiety, depression and quality of life in infertile women, findings from a tertiary care center in India. We all have been discussing that infertility is a major healthcare and social problem, and it leads to depression, anxiety, social isolation, and sexual dysfunction. So its treatment represents a negative psychological burden to the affected couple who's already stressed out that they don't have children. Now, this was a cross-sectional study on 200 women between the age of 20 to 38 years, and they were recruited from January 2018 to June 2019 and divided into two groups. So we compared 100 women with primary or secondary infertility with 100 women who were parous and who already had one or two children. We evaluated the mental health status of these findings, and we used four tools. Four different tools were used, namely the BDI, that is Beck's Depression Inventory, which comprised of 21 multiple choice questions. The total range extended from 0 to 63, and the higher the score, more the level of depression. So if the score was over 40, it suggested extreme depression. Then we had the infertile woman's exposure to domestic violence scale, where we evaluated the domestic violence, and this had with either yes or no, on the basis of which 5 subscales were determined. It was domestic violence, social pressure, punishment, exposure to traditional practices and exclusion domain. So the other one was WHO quality of life and depression field trial version. This was based on 4 domains: physical health, psychological, social relationship, and environment, and had 26 questions ranging from 1 to 5. The fourth was the DAS scale, or the depression anxiety stress scale, which was designed to measure the negative emotional states of anxiety, stress, and depression. And it had 21 questions with 7 items per scale. When we looked at the baseline characteristics, there was no significant difference in baseline characteristics except the menstrual cycles, which we found was more irregular amongst the infertile women. Probably they were already stressed out of not having a child, so that could be one of the contributing factors. As far as the factors amongst infertile women were concerned, they were mainly tubal factor, followed by unexplained, then PCOS, endometriosis, endocrine factors, and fibroids as well. When we compared the depression between infertile and fertile women using BDI, we found that around 19 women were depressed in our infertile group, and 1 of them had severe depression. As far as the infertile woman's exposure to domestic violence was concerned, in our study, we had only 2 women who had faced domestic violence, and I will explain that later. Then social pressure, there were 2, punishment domain 3, exposure to traditional practices were 4. This just as a graphic explanation. As far as the quality of life was concerned, whether it was transformed physical domain or transformed psychological, social domain, or environmental domain, this was statistically significant between the 2 groups. And the levels of stress between the infertile and fertile women, obviously the ones in the infertile group, they were more stressed out, varying from mild, moderate to severe. We didn't have any with severe or extremely severe stress factors. Then we looked at the anxiety factors, and again, there were patients who had mild to moderate to severe anxiety levels, and 4 of them, that is 4%, were extremely severe. We looked at the depression levels in the infertile and fertile group. There were 32 with mild depression, 34 with moderate, and 1 with severe depression. So WHO, it estimates that around 60 to 80 million couples in the world, they are infertile, and lower quality of life affects their psychological, environmental, physical, social functioning of an individual. And higher levels of anxiety and depression are found among women compared to those compared to men during the infertility treatment. So infertility, basically it is a biopsychosocial health problem and manifests as either social distress, marital conflict, sexual dysfunction, or even psychological issues like depression, anxiety, and social isolation. So this infertility per se has a negative psychosocial and cultural consequences. And the woman is depressed, then there's a lot of anxieties there. She's socially isolated because if she attends parties or goes out, she feels people around her are having children, whereas she's a barren woman. And then it brings about a lot of marital instability. There's a lot of quarrel and fighting amongst couples. There is loss of self-esteem, loss of gender identity. Then 1 second. Feeling of blame and guilt and loss of control. So Su, Ziley et al., they concluded in their quality of life study that in comparison to fertile women, infertile had significantly lower overall and comprehensive quality of life scores, as well as higher anxiety scores, which is similar to our study. And Sharaki et al., they did a study from Egypt and found that primary infertility women, they suffered more from depression than those of secondary infertility.
Dr. Anupama, your time is over. Yeah, can you please just make it fast?
So the strength of our study is that we used 4 different stools, but it is of short duration. So we read larger multicentric studies, and there is a significant burden of mental health, including depression, anxiety, and stress in women. So they require psychological counseling and support from their family as well as society. Thank you.
Yeah, so thank you, Dr. Anupama. Over to the judges for questions.
Thank you, Dr. Anupama, for your study. I only was interested that most of the studies that you have quoted have the same results as you have shown. So which means that it is a known fact that they do suffer from mental illness. Would you think of something that could have added value addition to any information or management of infertility patients from your study?
Ma'am, they require counseling. So these are the women that, they need extensive counseling. They need to be told that just having a baby or just not having a baby is not actually the end of the world. They can probably get involved in some kind of occupation and involve themselves in other things, rather than just be depressed. And I think it's easier said than done, because depression, the one who goes through it only will understand what it's all about. Because we had one patient who came and she came up with that in their community. She's a Hindu, and they don't have a burial system. I mean, they don't have the Hindu pyre lighting when the woman dies. It is actually a burial system for a woman who is barren or who doesn't bear any children. So there was somebody who came up, who just broke down and said that her husband was going to get married to another woman if by the end of the year she doesn't produce a child. So these are and financially they are deprived. In some communities, the husband actually goes and gets married to a woman who is probably who would have born some children in her with her previous partner, if at all she's become a widow or something. So there are a whole gamut of emotions you see when you see these infertile women, and you can identify with the kind of emotions they go through, and some of them they are even at the
Yes, Dr. Anupma, you're right that with these infertile women, they have more of depression and emotional stress. Yes, Dr. Anupma, can you hear me?
Yes, I can, Dr. Leena.
Yeah, that's a known fact that these infertile women, they are more prone for depression, and it's a good study you have planned using this 4-tool scoring system. I just want to know whether any other similar study using this 4-tool system has been done, and any association or correlation between these 4-tool system has been tried to. They have tried to find out any correlation between in between these 4 tools.
There are plenty of studies, Dr. Leena, from I think if we look at across the world, be it Egypt, be it the African countries, or be it any European countries. So they have found a correlation between infertility as well as stress, depression, anxiety, and the other things that I have mentioned.
Okay, Dr.
Dr. Anupama, could you look into the factors which infertility patients are suffering, like working, non-working, duration of infertility, and the type of treatment? Are they affecting the depression over this condition?
Most of them, they were housewives, and most of the patients that we were getting were from, the hilly terrain of Uttarakhand. So most of them were housewives, or they were probably working in the fields and things like that. So they have little access to treatment as well. They have to come down to probably Dehradun, Haridwar, and Rishikesh for their treatment. So we did look into all those things as well, but I haven't mentioned it in this study.
Okay. Thank you, Dr. Anupma.
Thank you so much.
Thank you, Dr. Anupama. So now next we have Dr. Komal Preet. Dr. Komal, please share your screen. Dr. Komal. Dr. Komal, are you able to hear me?
She just left.
Yeah. So, okay, Dr. Geetha Krishna is there. Dr. Geetha? Do we have Dr. Geetha, or do we have Dr. Yeah, Dr. Geetha is here.
Geetha speaking. Good morning. Can you hear me?
Yeah. Yes, madam. We can hear you. So, abstract number 33, and the title is Comparative Evaluation of Hysterosalpingo Contrast Sonography with Laparoscopy for Determination of Tubal Patency in Infertility.
Yes, ma'am.
Yes, ma'am, please start. Yeah.
Comparative evaluation of hysterosalpingo contrast sonography with laparoscopy for determining the tubal patency in infertility.
Madam, we can't see your screen.
We can't even hear you. Please be louder.
Yeah.
Can you see the slides?
No, ma'am, we can't see your slides yet. We are running short of time. Can we have Dr. Alpana Singh first? Is Dr. Alpana here? Okay. Okay, ma'am, we can see you. We can see you, Dr. Geeta, but we can't see your screen. Like we could not see your slides.
Now?
Yeah, we can see your
Now?
slides now. Yeah, we can see. Yes.
So today's topic is, good morning everyone. Today's topic is comparative evaluation of histosalpingo or contrast sonography with laparoscopy for determination of pupil patterns in infertility. Fallopian tubes form the gateway for transfer of gamete and embryo in infertility. Embryo. Infertility is defined as a failure to conceive even after 1 year of unprotected intercourse. About 90% of the couple should conceive within 12 months of unprotected intercourse. Pubal factor is responsible for infertility and is found in one-third of the infertile women. The prevalence of pelvic inflammatory disease, genital tuberculosis, chronic infection is quite common in our country, and hence the incidence of pubal factor in infertile women is high. Conventional diagnostics available are radiograph, histosalpingography, and laparoscopy, which are all associated with several risks, including invasiveness and exposure to radiation. Histosalpingo contrast sonography was introduced in the early 1980s and is gaining wider acceptance since it combines the principles of saline infiltration sonography and histosalpingography. However, it was not used much in India as the dye sono used for this procedure was not available here till recent past. Laparoscopy with chromoperturbation was viewed as a gold standard test for tubal assessment in many infertility centers. The advantage being the ability to evaluate the abdominal cavity and other pelvic structures for an enhanced diagnostic evaluation of other possible etiology of subfertility and can be used for therapeutic purposes simultaneously. Adding hysteroscope to the procedure allows for simultaneous evaluation of intrauterine cavity and may identify congenital endometrial abnormalities. The aim of the study is to compare the evaluation of histosalpingo contrast sonography with laparoscopy for determination of pubal patterns in infertility. Inclusion criteria is women in reproductive group with infertility and women with infertility who have not undergone prior treatment. Exclusion criteria is history of previous abdominal surgery, history of galactoria, any history of alcoholism and smoking among couples, and male infertility. Materials and methods. It is a cross-sectional study done with 42 participants and study duration of 1 year. It was done in gynecology outpatient department, Medina Medical College and Hospital. After obtaining written and informed consent, detailed history of the patient was taken, clinical examination, and necessary investigations were done. Results. The current study was conducted among 42 patients attending outpatient department with complaints of primary and secondary infertility in the Department of Obstetrics and Gynecology, which is a tertiary care hospital. More than half of the study participants belong to age group 26 to 35. There exists no statistical significance in age distribution between the type of fertility. In the present study, hypothesis findings showed 3 false positive among abnormal findings and 2 false negative among normal findings of the uterine cavity by laparoscopy. In left tube finding, hypothesis ruled out 4 false positive in the normal finding and 4 false negative in the normal finding. Whereas in right tube, there were 2 false positive in abnormal finding and 2 false negative in normal finding with respect to histolaparoscopy technique. Hypothesis findings in the adnexal pathology showed for 12 false positive among the abnormal finding. All the findings showed excellent specificity, that is around 84 to 100%, and sensitivity ranged from 40 to 87%. Histosalpingo contrast sonography was more specific to rule out the uterine cavity finding. The sensitivity was 76 and 87% respectively to find out the left and right fallopian tube lesions, but it is more specific compared to sensitivity to find out tubal pathology. Histolaparoscopy has 100% sensitivity to rule out adnexal pathology of uterus. Here we are showing the tabular column, which is categorized age-wise. First tabular column shows with the primary infertility 31 and secondary infertility 11 patients. Histosalpingography of the uterine cavity finding shows Hypoxia finding shows 3 false positive among abnormal finding and 2 false negative among normal finding. Left tube finding of hypoxia ruled out 4 false positive in abnormal finding and 4 false negative in normal finding. Right tube 2 false positive in abnormal finding and 2 false negative in normal finding with respect to histolab. And hypoxia finding of adnexal pathology. Adnexal pathology showed 12 false positive among abnormal finding. And table 6 shows the validity of hypoxia with respect to histology, which where you can see the accuracy of histolab is 100% and it is comparatively less for hypoxia. The major cause of infertility includes ovulated dysfunction, that is around 20 to 40% fewer. 20 to 40%. Fewer and peritoneal pathology is 30 to 40%. Male factor is 30 to 40%. Uterine pathology and unexplained infertility are the other causes. The current study was undertaken to assess the comparative availability of contrast sonography and the laparoscopy for determining genetic infertility. Most early studies showed hypoxia is a very good technique to diagnose any uterine cavity lesions, giving the sensitivity ranging from 72% to 100%, the specificity of 90%, positive predictive value of 90%, more than 90%, and negative predictive value of more than 80%. In the present study, the sensitivity test has been a little bit low, that is around 75%, because hypoxia is an ultrasound-based procedure, so it fails to diagnose the cavity fibrosis and endometrial lining defects. The thickness of endometrial lining on ultrasound does not change till the late stages of the endometrial lining destructive disorders, so early change can be appreciated only by direct visualization of the cavity through an astroscope in the form of pale endometrial lining with decreased vascularity or pinpoint deep-seated osteoid in case of pericorneal fibrosis. However, while screening for uterine cavity defects, we suggest that in cases with normal hypoxia, we can even skip hysteroscopy for a while. Patients directly can be subjected to more sophisticated assisted reproductive techniques like IUA and IVF, can do laparoscopic endoscopic evaluation of the uterine cavity later if required, or if there is a recurrent pregnancy failure. Advanced methods using 3D hypoxia
sorry to interrupt, ma'am, but your time is over.
Yeah, ma'am. It's over. Just 2 minutes.
Okay.
Have been proposed which full contour of the uterine cavity can be detected in more than 96% of the cases when Mullen it can be studied with better clarity. Those studies of hypoxia had ranging from 80 to 90%. In the current study, we have like slightly lower sensitivity for hypoxia. The possible explanation is because it is very difficult to see the distal end of the tube. Next slide. Even after having such big armamentarium investigations available to diagnose uterine laparoscopy and hysteroscopy remains the gold standard, as it not only offers the advantage of being most accurate diagnostic procedure, but also therapeutic procedure can be done simultaneously. To conclude, in the present study, we can conclude that hysterosalpingo contrast sonography is good screening method for evaluating the uterine cavity lesions and tubal block in infertile women, which is more safe, sensitive, cost-effective, non-invasive procedure, giving additional information regarding ovarian, adnexal, and peritoneal pathology. Thank you.
Thank you, ma'am. Over to the judges, and I request the judges to make it quick, please.
Dr. Geeta, what was the interval between the sonohysterography and the laparoscopy in your patient study? And a second thing is that what were the conditions in which you got false positive results? And what was the comfort level of the patient when you did the sonohysterography?
Patient was very comfortable with sonosalpingography because we had done it in our OBG department, the ultrasound. So where the patient was very much comfortable. We just gave the procedure in detail to her earlier, and the interval between the hypoxia and laparoscopy was within 1 week we did.
Thank you.
So, Dr. Geeta, even if hypoxia was normal, because the patient was enrolled in the study, you went ahead with hysterolaparoscopy in all cases?
Yes, ma'am.
Okay. And in hypoxia, the sonoview, was it easily available at your institute?
Yes, ma'am. Actually, we did along with the postgraduate.
I think the voice.
And the cost of each vial was, it contains a freeze-dried powder along with the diluent. Cost of each pack was around 550 to 600.
Okay. Dr. Shilpi?
Dr. Geeta, did you study the complication of both the procedure and comparison of both?
No, I didn't get you.
Dr. Geeta, did you study the complication of both the procedure and comparison between them?
Yes, ma'am. Complications as on with diet is very less. The usual complications like nausea, vomiting, diarrhea. Very rarely anaphylactic shock can occur, but we didn't get into that kind of problem.
Okay, thank you, Dr. Geeta.
Thank you.
Thank you. You're not audible, Dr. Sukriti.
Yeah, so thank you. Now I request Dr. Geeta Rastogi to take over.
Thank you, Dr. Sukriti. Am I audible now?
Yes, ma'am.
Yes. Now, I think Dr. Komal Preet is ready with her presentation. Dr. Komal Preet, are you ready? Dr.
Yes, I'm ready. Yes,
Yeah.
I'm ready.
Her abstract number is 18 and her topic is AMH and its correlation with glucose intolerance and metabolic syndrome in PCS women. Welcome, Dr.
My topic is study of anti-Mullerian hormone levels with metabolic syndrome and glucose intolerance in polycystic ovarian syndrome women. Polycystic ovarian syndrome is a common endocrinopathy of reproductive age group associated with reproductive dysfunction and metabolic disorder with major health consequences across the lifespan. Research suggests that 5 to 10% of females of 18 to 40 making the most common endocrine abnormality among women of reproductive age group. And protein structure, it is secreted by the granulosa cells of small antral and pre-antral AMH minimal ability, whereas antral follicular count and ovarian morphology are best assessed during the follicular phase. It is mostly produced by granulosa cells of follicles from 2 to 9 mm diameter, precisely the one in the ultrasonography because it reflects pre-antral and small antral follicles which are not seen in the ultrasound. Therefore, it is a better marker for growing follicular pool than AFC. PCOS is closely linked to metabolic disorders. A large proportion of women with PCOS are obese and exhibit insulin resistance with anemia. Consistent with the increased prevalence of insulin resistance, metabolic syndrome is also more common in women with PCOS. Metabolic syndrome affects 33% of PCOS and has been less well researched than other features as such as infertility and study was from May 2018 to June 2020. All the patients were recruited from guidance in 2003. Recruited patients were enrolled on the basis of exclusion and inclusion criteria. Detailed history was taken and general physical examination of all patients. BMI was calculated. All baseline investigations were the ovarian volume and any other significant finding. 5 ml blood sample was withdrawn after venipuncture from the woman between day 2 to day 5 of menstrual cycle. Measurement of anti-ovarian was done after 2 hours of 75 gram duration, and as per WHO 75 gram OGTT, glucose intolerance was diagnosed by National Education Program and Development Panel 3 guidelines. The diagnosis of metabolic syndrome was made. Results and observation. According to age, patients were divided into 4 age groups. Out of them, age group 31 to 35 years, maximum 58 patients were there, 38.67% of the patients. Then patients were distributed on the basis of the menstrual cycle. Out of 150 patients had regular menstrual cycle, while 142 out of 150, that is 94.67% patients, had irregular cycles in the form of oligomenorrhea, prolonged cycles, and amenorrhea. of them, 7 patients were underweight. 44 out of 150 had normal weight. 63 patients came under the came in the overweight group, and 36 were in obese group. That is, 66% patients were overweight or obese. Then distribution of study population was done according to glucose intolerance. Out of total 150 patients, 68 patients were found to be glucose intolerant, that is 45.33%, and 82 out of 150 had normal glucose tolerance. Patients were distributed according to the presence of metabolic syndrome, and 57 out of 150 patients were found to have metabolic syndrome. The study population was also distributed according to the waist circumference. 94 patients out of 150 had waist circumference more than 88 centimeter. That is 62.67%. Then, when statistical analysis was done between the association of AMH values with age, the relationship was found to be statistically significant with a p-value of 0.029. With this table, it was interpreted that with increasing age, the mean value of AMH declines gradually. On analyzing the status of glucose intolerance in study population, there was a significant positive association of glucose intolerance with p-value of 0.04. In patients with the glucose intolerance, AMH was 8.738. It was the mean value. Intolerance, the mean value of AMH was less, that is 7.796. Then association of AMH with BMI was calculated, but the relationship was not found to be statistically significant with a p-value of 0.624. Association of AMH was also calculated with waist circumference. On statistical analysis, there was no significant relation. Then statistical and positive association with AMH levels with a p-value of 0.000. Then patients were distributed according to the presence of dyslipidemia. Levels of HDL was calculated. 75 patients were found to have HDL level less than equal to 50 milligram per deciliter. Similarly, 63 patients had triglycerides more than equal to 150. And statistical analysis was applied. The relationship between AMH values and triglycerides was found to be statistically significant, 0.000. The relationship between HDL was significantly, significant. It had a negative correlation with a p-value of 0.000, whereas the relationship between AMH and LDL was not statistically significant. Now, coming to the discussion part, in our study, we analyzed parameters like age, BMI, menstrual cycles, glucose intolerance, waist circumference, dyslipidemia, and prevalence of metabolic syndrome. When distribution according to BMI was done, 66% patients were found to be obese and overweight. Presence of obesity is a risk factor known to amplify the consequences of PCOS. The relationship was statistically non-significant with AMH, which were consistent with some studies such as Halaverty et al., Nardo, Overbeek, Scalba, and Bakir. However, there was one study conducted by Chrisman M. et al., where BMI had significant inverse correlation with PCOS. Study population was also evaluated for glucose intolerance, and its relation with AMH was found to be statistically significant, which were similar to the studies conducted by S. et al. and for Seska HP. Similarly, study population was analyzed for the presence of metabolic
Komalpreet, your
syndrome.
time
It was
is
found that metabolic syndrome had significant positive association with AMH. It was association was statistically significant, similar to the study conducted by Viveko B. On the presence of dyslipidemia, AMH had strong positive association with serum triglyceride and strong negative with HDL, similar to the studies conducted by Sukrede S. et al. Ultimately, it was concluded that with increasing age, AMH decreases probably due to shrinking pool of follicles. AMH had significant association with dyslipidemia, implying that increasing value of AMH, prevalence of dyslipidemia increases. AMH had also a significant positive association with metabolic syndrome and glucose intolerance in PCOS women. Therefore, it can be used as a surrogate marker for cardiometabolic diseases in women suffering from PCOS. AMH, being independent of hypothalamic pituitary axis, can be used for predicting dyslipidemia and cardiovascular diseases without being modified by other pathologies.
Okay.
Thank you.
Okay. Thank you, Dr. Komalpreet. Now, over to judges. Your comments, please.
To Dr. Komal, what is the clinical implication of your study? How are you going to use AMH in light of results that you have found?
AMH can be used as a surrogate marker for predicting the prevalence of metabolic syndrome and dyslipidemias and glucose intolerance in women suffering from PCOS, as well as it can be used as an additional diagnostic tool for the diagnosis of PCOS in women.
Thank you.
Okay, Dr. Komalpreet, can you tell when you were comparing BMI, what cutoffs did you use, the global cutoffs or the Asian cutoffs for our population?
No, I used global.
Okay, you could have used Asian.
I used global cutoffs for the.
And maybe you could have seen the different phenotypes and its correlation with AMH.
Yes, I missed that.
That was a good study. Okay, thank you, Dr. Komalpreet. Dr. Shilpi?
Dr. Komal, how did you measure the AMH levels? What was the method used to do the AMH level?
ELISA immunoassay was used for testing AMH. 5 ml blood was withdrawn from the patient and it was sent for and it was tested in samples. AMH ELISA kit was used for it, and it had a range up to 14 nanogram per ml.
Have you seen the standardization of method of AMH calculation and all?
The kit I used, it was pre-standardized.
It was done in your place, or it was the sample was sent to the other lab?
It was sent in our biochemistry department, but the kit that I had used, I had to purchase it myself, and it was pre-standardized. It was already standardized, and we had to use 6 controls for 40 samples.
Yeah.
Okay. I think I should invite another speaker.
Dr. Komalpreet.
Our next speaker is Dr. Kalpana Singh. Her abstract number is 149, and she will speak on effect of vitamin D supplementation on serum VEGF level in vitamin D deficiency PCOD patients. Welcome, Kalpana.
Good afternoon, respected judges. Myself, Dr. Alpna, I am going to present my study, Effect of Vitamin D Supplementation on Serum VEGF Levels in Vitamin D Deficient Polycystic Ovarian Syndrome patients. As all we know, PCOS is the most common
Share your screen, please.
Hello.
Share your screen, please. Dr. Alpna, your screen.
Just wait, ma'am, please. Ma'am, is it visible?
No.
No.
Just ma'am, I'm doing.
Yeah.
Ma'am, it's visible now?
Yes.
Yes.
Okay. Should I start, ma'am?
Yes.
Good afternoon, everyone. So, as the PCOS is the most common endocrinopathy, and it affects around 6 to 10% of the reproductive age group females, and vitamin D has a role in ovarian follicular development and luteinization via altering the MH signaling and FHS sensitivity. And when we look into the PCOS pathophysiology, there's an increased ovarian mass with a new vascular proliferation of stroma and theca. And because of the angiogenic factors, mainly VEGF have a role in neovascularization in ovarian stroma. And due to the further hypovitaminosis D leads to the inflammation and angiogenesis. So VEGF is one of the major regulator of angiogenesis and leads to the formation of polycystic ovaries. Vitamin D has a various activity, and it acts as an anti-proliferative, anti-inflammatory, and anti-cancerous agents. As per the recent study, 80% of reproductive women in India are the vitamin D deficient. Normal level of the vitamin D is 20 to 50 nanogram per ml. When levels are less than 20 and up to 10, it is called as mild to moderate deficiency. And when the levels are less than 10, it is considered as severe vitamin D deficiency. There's a gross positive literature about this concept. Only one published study has evaluated the effect of vitamin D on serum VEGF levels and clinical parameters in PCS women. Until date, there's no published Indian study available on this. So on this hypothesis, we planned the study with the aim of the study to estimate and compare the serum VEGF levels before and after vitamin D therapy in the vitamin D deficient PCS patients. Primary objective was comparison of VEGF level before and after vitamin D supplementation in vitamin D deficient PCS patients. Secondary objectives were to study the effect of vitamin D therapy on various clinical parameters and also on the insulin resistance and lipid profile. Material and method of the study was it was a prospective interventional study done in Department of Obs and Gynae in collaboration with Biochemistry and Dermatology Department of UCMS and GTB Hospital, Delhi, conducted from November 2017 to April 2019. 30 vitamin D deficient PCS women fulfilling the inclusion-exclusion criteria were selected for the study. Inclusion criteria for the study was all the women between 20 to 45 years diagnosed as vitamin D deficient PCS taken as a study population, and exclusion criteria were any patient, hormonal therapy in the last 3 months on vitamin D supplementation or known hypersensitivity to vitamin D or any chronic medication like metformin, lipid lowering drugs, or any chronic medical illness patients were evaluated, excluded from the study. Now, methodology of the study: 4 ml blood sample was taken after diagnosis of the PCS in 40 patients, and 2 ml blood was used for the vitamin D estimation, and 2 ml blood was stored for the VEGF estimation by ELISA kit. At end of the study, out of 40, 30 patients were diagnosed as a vitamin D deficient, and they were given 60,000 international unit once a weekly for the 2 months vitamin D therapy, followed by again the blood sample was taken. These patients were further followed for the 3 months, and at end of the 5 months, they were evaluated for the clinical assessment for the improvement in the PCS. And in the meanwhile, during the follow-up, 4 patients were lost to follow-up. So finally, we were evaluated only 26 patients for this study, and VEGF sample was again stored for the estimation at end of the study. The results of our study was, when we compare the clinical features pre and post vitamin D therapy, there was a significant changes found in the hyperandrogenic parameters, acne and the hirsutism, but we also witnessed the menstrual pattern was become regularized after the therapy. In frequent cycles become regular. Amenorrhea was corrected in the 3 patients, and cycle regulation occurred in the 7 patients. When we compare the biochemical parameters like serum total testosterone and DHS, there was a mean value fall was significant. Similarly, in the lipid profile, triglyceride was significantly fall, and HDL was improved from 46 to it was 50 after the therapy. When we studied for the insulin resistance parameters, postprandial blood sugar level was significantly lower after the therapy. Fasting insulin level was reduced, but not significant. QQ was more or less same, but HOMA-IR was reduced. And when we compare the vitamin D level before and after the therapy and VEGF level, we found out of 26, 15 patients had severe vitamin D deficiency and 11 patients had mild vitamin D deficiency. And mean value before the therapy of the vitamin D was 9.5 and post therapy was 32. It was very significant. And even in the severe category, 4 patients were not corrected or achieved the therapeutic level even after the 8 weeks, and they were further kept on the maintenance doses for the treatment. And when we see the VEGF levels, we found that there is a significant fall in the VEGF, 773 before the therapy picogram per ml, and after therapy was 639, and p-value was highly significant. In the severe and mild category also, there is the VEGF level was correlated with the vitamin D supplementation, and we found the negative correlation with the vitamin D and the VEGF level more in before the therapy and after the therapy. So levels were high, then VEGF were reduced in the after the therapy. On the thorough search of the literature, we found that various studies has been carried out on this concept of the vitamin D therapy in the PCOS, and they also witnessed a clinical and biochemical parameters improvement like our study. But in the recent years, only 2 studies, both were done by the same author, Irani et al. In 2015 and 17. They studied along with the clinical and biochemical parameters for the angiogenesis marker like the transforming growth factor beta-1 and VEGF, similar to our study, and they observed the significant fall in these angiogenic markers. So it helps in these study help in saying or understanding of the vitamin D functioning in the PCS. So strength of the study, our study was, it was a prospective study. Quantification of VEGF level before and after vitamin D supplementation was done. And also we correlate for the vitamin D levels with the VEGF level and clinical and biochemical parameters. And limitation of the study was, it was a small study population, financial constraint to the cost of VEGF ELISA kit. and carry-home message of our study was vitamin D supplementation reduces the neoangiogenesis in the PCS patient and manifested by decrease in the serum VEGF levels, and also it improves the clinical and biochemical parameters in the PCS women, and but better double randomized control trials to be done on the larger sample size in the multicenter setting to require further confirm our findings. And it is very well said by the Jora, research is a formalized curiosity. It is poking and prying with a purpose. Thank you.
Dr. Alpana, did you find, you said that hirsutism also improved?
Yes,
within
ma'am.
3 months is a very short time to see any change in hirsutism.
Ma'am, actually the follow-up period was 5 months. We measure the biochemical parameters at 8 weeks because we are taking the sample for the vitamin D along with the BCA, but for the clinical parameter, acne, hirsutism and menstrual cycle, further we followed these patients and kept on the maintenance doses of vitamin D till 3 months. So at end of the 5 months of enrollment, we observe for these clinical parameters.
Okay, thank you.
Dr. Vanita. Dr. Shilpi, want to ask any question?
Yeah. Actually, I missed the study. I was out of network. This thing. I'm okay.
Yeah, Dr. Alpana, can you tell the practical application of doing VEGF estimation?
Ma'am, actually vitamin D deficiency in India is a silent epidemic, and we just saying vitamin D study in the vitamin D is a very casual thing. It is going to be the most of the your patient will having the deficient. Like in our case, 40 out of 30 patient were deficient, 75%. But to better to prove our hypothesis, we try to see how the vitamin D acts in this PCS. So that's why we try to study the biochemical marker, angiogenic marker, and we prove or we found or we witnessed that it acts as an anti-inflammatory, which is the low-grade chronic inflammation. The PCS is the one of the cause of etiology on the PCS. So when the VEGF levels are after the therapy or fall, so we were in the better position to say, yeah, vitamin D has a definite role and that there's a definite way or the mechanism of action in the PCS. So the idea of that, because earlier study also has been done on the vitamin D, but when the Irani et al. Has done the study on the clinical biochemical marker, so after that it has been proven that how this anti-inflammatory treatment is going to help into the PCS. So our idea was that, and this is the probably first Indian study we have done on the biomolecular level.
Great, good, Dr. Kalpana.
Thank you.
Thank you.
Okay. Any other question? So I want to thank our esteemed judges and our speakers. Very good studies. I request you all to send your evaluation on the mail ID you have given. Okay. Thank you so much.
Thank you all the presenters.
So good evening to all dignitaries, guests and delegates. I feel privileged to extend my warm welcome to all present here for the 16th Fertivision 2020. Now, I humbly invite the session's chairpersons to come on to position. We need not say about the chairpersons, they work in their fields. Their work in their fields vibrates and echoes with their prominence. Dr. P.M. Gopinath is Director SRMS Hospital, Chennai. Dr. Ruma Satvik is Consultant Center of IVF and Human Reproduction, Sir Gangaram Hospital, New Delhi. And Dr. Devika Gunashila is the Director of Gunashila Assisted Reproduction Center and Gunashila Surgical and Maternity Hospital in Mysore and Bangalore. I would request Dr. P.M. Gopinath to start the session, but we have kept the question answer session at the end of the session. So please don't ask any questions yet. We'll take up the question and answers at the end of the session. So Sir, Dr. Gopinath, please. Dr. Gopinath, are you here? Are you there? We can hear you. Yeah, thank you, sir.
Good afternoon and welcome to this session. This is a very interesting and very informative session. We have with us, hello, can you hear me? Hello, can you hear me?
Yes, sir.
Yes.
Yeah. So good afternoon, everyone. We welcome you to this session B4 at between 3:30 and 5 p.m. We have three interesting international speakers. The first speaker, Christoph Venites, is from Greece, and then he is now at present in Australia. He is going to give us a lot of insight on the optimal GnRH antagonist. Over to you, Christoph.
Thank you, and thank you for the introduction. Let me start by sharing my presentation first. Can you see my presentation? Can you see my slides?
Yes, sir.
Thank you. So I would like to start by obviously thanking the Indian Fertility Society and the Scientific Committee for the warm invitation, which I was very happy to accept. It's really a pleasure being amongst distinguished colleagues in India. And I've been asked today to talk about the optimal antagonist protocol. So we have a lot of ground to cover. So I would like to start just by my disclosures that are not particularly relevant, but at the same time, it's important to be there. So dear colleagues, ovarian stimulation in 2020 is something that we think that we need to revisit. And we need to always look back and make sure that the way we're doing things actually is looking at 2 or 3 different aspects. Success obviously is the first thing, but success is translated to efficacy, to patient acceptability, and to safety. These are the 3 pillars under which or with which we should be evaluating any treatment protocol we offer to our patients. So obviously we should care about efficacy, and I won't stay in this slide because we're in the business of creating families. We want our patients to get pregnant, to have healthy babies. We want them to have that as soon as possible. That's what they want from us. But at the same time, we should care about patient experience. Why? There is now extensive literature where it suggests that if patients do not have a good experience, they're more likely to drop out. And dropping out eventually will lead to fewer of our patients getting pregnant. This is a study by Schroeder et al. Published in RBM Online almost 16 years ago, where it was clearly seen what would be the ideal cumulative live birth rate if patients were retained in a program of IVF versus what it ends up being just because patients give up in many cases early. So we need to make sure that we offer to our patients the best treatment protocols, the ones that are more patient friendly. What about safety? I think it's again one of those things that most fertility specialists do not need to be convinced on. I think I'm preaching to the converted. We do not want to see our patient in this condition. A patient coming to have a baby is not a life-threatening condition. We should not, due to our mismanagement, lead them to the ICU with a life-threatening condition. So we need to make sure that the protocols we apply are safe, are as safe as they can be. So imagine if ovarian stimulation was more patient-friendly, if its duration was shorter and with less injections, and if OHSS, which is one of the major iatrogenic complications of IVF and ovarian stimulation, was a thing of the past. So luckily, sometimes dreams come true. And in our case, the GnRH antagonist introduction in ovarian stimulation has almost addressed all these topics. And nowadays, in many countries of the world, including Australia, the GnRH antagonist protocol is considered the first-line protocol for ovarian stimulation in most patients. And this is something that I cannot emphasize enough. And I do know that there is a number of clinicians, very respectable clinicians, that have their doubts. And so it's always very important to look back at the evidence. Again, this is a self-explicable slide where you can see that in an agonist, we'll probably end up with around 30 injections and for a prolonged period of time. in an antagonist setting, probably we have an ovarian stimulation of 12 days, 10 to 12 days, so the injections are significantly less. And is that important for patients? This is a very interesting discrete choice experiment that has been performed by Van Wintergraad, where they essentially showed that a lower number of injections was preferable, and patients were willing to even sacrifice 6.2% increase in the risk of cycle cancellation for fewer injections, or 4.5 increase in the risk of OHSS for fewer injections. So it's very important. Injections are something that patients do not like, and we need to make sure we minimize the number of injections they have to have. So antagonists probably are something that can be used in those settings, but a major concern is, are antagonists as effective as agonists? This is the Cochrane review, the most recent one, which dates though back to 2016, where essentially it is said that there is moderate quality evidence that the use of generate antagonists compared with a long generate agonist leads to a substantial reduction of HSS without reducing the likelihood of achieving a live birth. And that means, essentially, you can see here the live birth rate per woman randomized from that Cochrane review, the odds ratio being 1, whereas the OHSS is 0.6, statistically significant in favor of the antagonist. And that has led the Cochrane library, which is one of the more objective pieces of sources of evidence, to suggest that generates antagonists are at least as effective and significantly safer than generates agonists. I know that many of you might have seen this systematic review, which was published in 2017, where the authors, and these are very, very prestigious and esteemed authors, by analyzing the data that were available up until this time, they concluded that something different, that generates antagonists are associated with a lower ongoing pregnancy rate when compared with long agonists, but also with lower HSS rates. And for that reason, these authors suggested that within this population, in the normal responders, antagonist treatment prevents 1 case of OHSS. And for that reason, the standard use of the long generate agonist treatment seems to be the protocol of choice. That is something, of course, that we had strong disagreements with, because as we know, meta-analysis is a wonderful tool, but it can lead to quite dubious conclusions. And for that reason, we wrote a letter where essentially we identified all the issues around that meta-analysis that invalidated or seriously questioned the validity of the results. The fact that they included studies with asymmetrical interventions, they had misclassified studies, but also they had compared all GnRH antagonist protocols with just one agonist protocol, which is the best one, the long agonist. And why is that important? Because do we really consider that all antagonist protocols are the same? I know many of us think so, but the truth of the matter is that we have so many variations, and those variations can be based on the timing of antagonist initiation, on the type of antagonist we use, and also on the various types of pretreatment that sometimes our colleagues use in order to facilitate programming of the cycle. But all these things essentially create a number of different protocols that might not be identical. And why do we say that? Because we do know, for example, that OCP pretreatment is something that should not be performed or should be performed while acknowledging that there are risks. And also there is some preliminary evidence suggesting that the fixed and the flexible protocol might not be equivalent. So let me show you what was already present there. In a study that we did with George Christiger back in 2010, which was a systematic review and meta-analysis of randomized trials, we showed very clearly that when you use oral contraceptive pill pretreatment, you lose about 20% relative in terms of the ongoing pregnancy rates. That's huge. And still many people tend to ignore that. And this is all randomized controlled trials, and it has not been, this finding it remains unchanged since then. The newer meta-analysis challenging these findings have not been published. What about the flexible protocol? I won't stay in this slide. We all know what a fixed protocol means. Usually it's day 5 or day 6 of initiation, whereas the flexible is when the leading follicle is about 12 or 14 millimeters, or when certain estrogen concentration has been achieved. So are these two the same? I would just like to draw your attention to the Lambert meta-analysis, where they actually performed a comparison between the fixed antagonist versus the long agonist, and the flexible antagonist versus the long agonist. And you can see here that in the flexible, the relative risk was 0.84, statistically significantly lower. In the fixed protocol, when the fixed was compared with a long agonist, and you can see that it had even more data, the fixed one, the relative risk was 0.94, significantly different than the flexible one, and it was no longer a significant difference. So this indirect evidence shows that we should not be accepting that a flexible protocol leads to the same efficacy as a flexible protocol, and that is crucial. So this is what motivated us, along obviously with clinical observations that we had performed, that we need to make sure that we find a solution, or we find an answer to what is the optimal antagonist protocol. And to do that, obviously, appraising the literature is the first thing you need to do, and doing a pairwise meta-analysis is the first thing. But at the same time, we wanted to to make sure we leverage the methodology, the modern methodology of network meta-analysis, which allows us to extract useful information from studies not directly comparing fixed versus flexible or OCP pretreatment versus no OCP pretreatment, but comparing these arms with a standard comparator, which in this case, we said it would be the long agonist protocol. So this is a well-established methodology, and it has very, very strong points and very important reasons why we should be using it. So we performed the systematic review and meta-analysis. And as I said, the goal was to identify the optimal antagonist protocol. And there are so many out there. So we wanted to essentially limit our question to comparing antagonist fixed day 5, day 6 versus flexible, to whether using cetrorelix or ganirelix would be lead to different results, and whether using some type of oral pretreatment would be beneficial compared to not using oral pretreatment, or between different types of oral pretreatments. And as I said, for the network part of our meta-analysis, we used a common comparator, and that was long agonist treatment. So this is the search strategy, and I won't bore you with the details. We excluded all the pseudo-randomized trials, the non-randomized trials, the trials with asymmetrical co-interventions, and of course, studies in which gonadotropins or agonists had not been used were also excluded. This was also performed according to the PRISMA guidelines. So the network meta-analysis used direct and indirect data, and in the absence of evidence suggesting otherwise from the pairwise direct comparisons, we included all the following interventions. So you can see we have included different types of generates antagonists, types of OSP pretreatment, different types of estradiol pretreatment. All these interventions were assumed to lead to a similar outcome. So the literature search started with around 7,000 studies, and we ended up eventually with 6 comparing directly flexible and fixed. These were randomized trials, 13 comparing different types of pretreatment with each other or with no pretreatment. Just 2 studies compared directly with ganirelix and cetrorelix. And we also had 52 studies comparing some form of generates antagonist with the long generates agonist. And these were included. So let me go straight to the results. I'll start with a pairwise meta-analysis where we directly compare all the studies that had provided direct evidence. So in regards to fixed versus flexible protocols, no study reported live birth. In regards to the ongoing pregnancy, which is a very powerful primary outcome, we had 5 randomized controlled trials with 700 patients. And what you can see in the forest plot on the right was that we saw that it was lower with a flexible, the ongoing pregnancy rate was significantly lower with a flexible antagonist protocol compared with a fixed antagonist protocol, and the relative risk was 0.74. That means if you use a flexible protocol instead of a fixed, you're essentially losing about 26% relatively of your ongoing pregnancy rates. And this is again huge. We also wanted to do a number of subpopulation analysis. So we looked at whether the criteria of flexible protocol, whether it used only, for example, ultrasound criteria, or whether it used only estrogen criteria made a difference, and it did not. We also wanted to look in the different types of population We had only enough data to assess this only in the normal responders, but again, the relative risk was very, very similar. So it did not actually make any difference. And also no differences were identified in terms of the different types of antagonists used. The second big question is, what about ganirelix versus heterorelix? Is that an issue? Only one study reporting on live birth rate showing no significance and no studies reporting on ongoing pregnancy rate. So therefore we could not exclude, we could not conclude, we could not perform a meta-analysis, and at the same time, we could not make any argument on whether there's a difference between ganirelix versus heterorelix. What about the oral contraceptive pill pretreatment versus no pretreatment? With live birth, we had only 2 studies, including in total 125 patients. And those 2 studies suggested no difference whatsoever. However, when you looked at the ongoing pregnancy rates, we had 4 studies having 10 times that population, more than 1,240 patients. And in that case, it was also very clear that using the OCP before the antagonist leads to, again, almost 20% reduction of the relative risk for ongoing pregnancy. And this is very, very, this agrees greatly with the study that we had performed, the meta-analysis we had performed with George Grisiger a few years back. We also performed the same types of subpopulation analysis. Again, no significant differences in terms of the criteria for the initiation or in terms of whether fixed or flexible protocol was used, in terms of what was the type of population and what was the type of antagonist used. In those cases, the effect sizes remained the same every single time, suggesting that OCP is not a good thing. So unfortunately, we had many studies, but we did not have enough studies to actually be able to perform direct comparisons for all these different types of comparisons, and therefore, meta-analysis was not feasible. So concluding now with a network meta-analysis, we had 68 RCTs, including more than 11,000 studies. I remind you that these include also the studies that compared any type of antagonist protocol that we wanted to, that we were interested in, with a long GnRH agonist protocol. And we had 68 RCTs reporting at least one pregnancy outcome, and we used the antagonist fixed no pretreatment protocol as the common comparator. What about live birth rate? In live birth rate, there was overall insufficient evidence of a difference between any of the protocols that we examined. However, it was clear from the SOCRA score, which is something that ranks the interventions on the probability of which one might be the most efficacious, that the antagonist fixed protocol is likely to be the GnRH antagonist protocol with a percentage of 69%. Also, it's interesting, if you see on the forest plot, the antagonist fixed no pretreatment protocol, when compared with a long agonist, the relative risk was 1, suggesting that essentially they're equivalent. With ongoing pregnancy rates, we had significantly more data. We had 41 randomized trials, more than 8,000 patients, and 2 things were actually very clear from this analysis. One, we had lower ongoing pregnancy rates with when we added the oral contraceptive pill. And also we have lower, although borderline significant, ongoing pregnancy rates when we compared the fixed no pretreatment protocol with the flexible no pretreatment protocol. So what we had observed in the direct meta-analysis was also confirmed in this network meta-analysis. And at the same time, using the same methodology, the SOCRA score suggested now that in terms of ongoing pregnancy rates, the fixed antagonist protocol using no pretreatment had 83% chance probability of being the optimal antagonist protocol. So to conclude, in terms of the pairwise meta-analysis, and when we compared fixed versus flexible, we saw that there is a lowering ongoing pregnancy rate with a flexible versus the fixed. So the fixed always performs better, and any subgroup analysis we performed did not modify that result. In terms of comparing ganirelix or cetrorelix, we had very limited evidence, but there was no indication that there is a difference there. In terms of the pretreatment versus no pretreatment, we have enough data only for the oral contraceptive pill pretreatment, and it was again clear that ongoing pregnancy rates are affected. Similarly, the subgroup analysis did not modify these conclusions. The network meta-analysis overall suggested and supported the findings from the pairwise meta-analysis, and in all cases, ongoing pregnancy rate, when the ongoing pregnancy rates seem to be optimized by using the generate antagonist protocol, the fixed one, using no pretreatment. So the final slide is why, and why would the flexible or a fixed would be better than flexible? We do know that flexible protocol is usually introduced to delay the generate antagonist initiation, and that unfortunately, that most of the times would lead to a later introduction of the antagonist. That means that there is a scenario that a late rises could happen, and this could compromise the oocytes or the endometrial receptivity. In regards to the oral contraceptive pill treatment, we know that they lead to profound suppression of LH and FSH, and that lower LH could lead to reduced oocyte competence or endometrial receptivity. And also the progestin that's part of the oral contraceptive pill could also be involved in a reduction in the endometrial receptivity, and there is some other evidence supporting that. Finally, my final slide, although the physiological explanation still remains elusive, and I want to be clear about that, the randomized evidence is clear and suggests that a fixed day 5, day 6 antagonist protocol without any pretreatment is the optimal antagonist protocol for normal responders or unselected patients. We need further targeted research in order to identify the physiological mechanism and explore the optimal antagonist protocols in other populations such as the poor or the high responders. And with that final slide, I would like to thank you all for your attention.
Thank you very much. Thank you very much, Christos, for excellent review of an extensive study and summarizing it, concluding it in a way. Thank you very much. We will wait for the questions, and then at the end of the session, we will take it. Can I request the next moderator to just introduce the next speaker?
Yes, thank you, Dr. Gopinath. This is Dr. Ruma. And I have the pleasure of inviting Dr. Sesh Kamal Sankara to present her talk on role of adjuvants in ovarian stimulation. Now, we do understand that live birth rates after one cycle of IVF are not what we would like them to be. In fact, the chances are low that she would conceive in one go. And no one better than Dr. Sankara to talk to us about what helps and what does not. Dr. Sesh Kamal is the Senior Clinical Lecturer in Reproductive Medicine, King's College, London. She is currently the Associate Editor of Human Reproduction Update, as well as many other journals. She's also a member of ESHRE Guideline Development Group as of now. Dr. Sankara, the screen and the stage is yours.
Thank you very much, Ruma, for the kind introduction, and hello to my fellow faculty and colleagues who are joining in this webinar. I think, Ruma, you've already given a good introduction to why we are into clinical adjuncts, but let me start. We all would agree that we would be better off as clinicians if we could give very high success rates to our patients. Unfortunately, IVF success rates remain low despite advancements in stimulation protocols and laboratory techniques. Adjuncts are add-ons aiming to improve IVF outcomes. So these are introduced, several of them, to go beyond the ceiling of what we can achieve with our success rates in IVF. But also add-ons add to costs. So let us look what the evidence of benefit is with add-ons and what these add-ons are. And in this lecture, I'm going to focus on ovarian stimulation. So adjuvants in ovarian stimulation protocols, the ones that are routinely used and topical, are growth hormone, DHEA, testosterone, metformin, pre-treatment therapies, the combined oral contraceptive pill. Christos has briefly touched on this in his previous lecture. Estradiol pre-treatment, progestogen pre-treatment, aspirin, indomethacin, and sildenafil. So growth hormone. What is the rationale for using growth hormone in ovarian stimulation protocols as a clinical adjunct? Growth hormone promotes preantral follicle growth and differentiation. It stimulates preantral follicles to gonadotrophin-dependent stage and also causes maturation of the oocytes, plays a role in maturation of the oocytes. So with this background, growth hormone has been introduced as a clinical adjunct during ovarian stimulation. But what is the evidence? Most of you who would be up to date with literature would know that there have been meta-analysis after meta-analysis after meta-analysis looking at growth hormone in the context of ovarian stimulation, most importantly in the context of poor ovarian response. And this is one of the latest meta-analysis, and it is looking at growth hormone versus no growth hormone in women with poor ovarian response or expected poor ovarian response, and the outcome is live birth rate. And as highlighted, you can see that the live birth rate seems to be higher with the use of growth hormone. But I just want to focus on the other things which are highlighted, which is the numbers. So the total number of women when combining all the studies who had the growth hormone is 277. So it's a small sample size. So since the meta-analysis in 2017, which was referred to in the ESHRE guideline on ovarian stimulation, there have been other randomized controlled trials. And these are two randomized controlled trials. One of them, most of us would be aware, this is the LIGHT study, which came from Australia. And what the study showed is that there are more oocytes, but no difference in live birth or ongoing pregnancy rates. So putting all this together, the ESHRE guideline has said that use of adjuvant growth hormone before and or during ovarian stimulation is probably not recommended for poor responders. And the justification is that despite the possible benefit, which I've shown in the meta-analysis that in the previous slide, in poor responders, the evidence is of too limited quality to recommend growth hormone routinely in clinical practice. I showed you the numbers are very small. So if you're going to take a study which included 277 poor responders and then apply it to all centers, all patients across the globe, then it is not right. And also the quality of the individual studies that were pooled together is also a little bit doubtful. So the studies were generally small, the definition of poor response was heterogeneous, and also there was heterogeneity in the growth hormone dosing schemes. So what is the ideal dose? How long should you give? So these are all questions unanswered, and most importantly, there is no long-term safety data available or no data on any adverse effects. So it's not only with regards to efficacy, when we are introducing any clinical adjunct, it is important to know if there are any adverse effects or any long-term safety concerns, and neither of them have been addressed. So that is the stance of the ESHRE guideline. You have the reference to the ESHRE guideline at the bottom. But then really recently, this year, there has been a meta-analysis that has been published in Fertility and Sterility. And what this meta-analysis showed is that using growth hormone versus no growth hormone in women with poor ovarian response showed no significant difference in live birth rates. As you can see that the diamond is touching the line of no significance. There is no significant difference in live birth rate. So the ESHRE guideline is justified in saying that it should not be recommended, and evidence after that has confirmed this as well. So that's growth hormone. So let's move on to androgen supplementation. Why have we started with androgen supplementation? This is because of the background knowledge and mostly studies in primates showing that androgens exert ovarian autocrine and paracrine effect. Androgens increase FSH receptors expressed in the granulosa cells, and therefore increase in FSH receptors in granulosa cells would enhance FSH responsiveness and follicular recruitment and the numbers of oocytes. So that's the rationale, and that's based on primate studies, and it was extrapolated into humans in clinically. So what is the evidence of using dehydroepiandrosterone in women with poor ovarian response as androgen supplementation or androgen supplementation? So this is a Cochrane review that was published in 2015. And here they looked at DHA versus no DHA, and they looked at the outcome of live birth rate, ongoing pregnancy. And what is shown here when putting all the studies together is that DHA improves ongoing pregnancy live birth rate. But I want you to focus on the sentence below, whereby previously I've alluded to saying that it's not just pooling the studies, we have to look at the quality of the studies and the robustness of the studies which were pooled together in the meta-analysis or a Cochrane meta-analysis. And here, when all the studies that had high risk of performance bias were removed, then there was no significant difference in ongoing pregnancy or live birth rate with using DHA or not using DHA. There have been subsequent studies since the Cochrane review, and these are the studies that randomized controlled trials that followed Cochrane review. And what it is if you see what is highlighted, they show conflicting results. One says DHA increases, but the other one says that DHA does not improve response to ovarian stimulation in women with poor ovarian response. So the ASHRAE guideline says that the use of DHA before and or during ovarian stimulation is not recommended for poor responders. And this is based on what I've shown, inconsistent evidence, conflicting evidence that adjuvant DHA improves outcomes in poor responders. Also, studies varied in the duration of DHA treatment, possibly contributing to the inconsistencies in observed results. And again, there is insufficient data on safety, adverse events, both in the immediate and long term. Moving on to testosterone. So is there evidence that testosterone could be beneficial? Again, I will start off with the Cochrane review, and there have been 4 randomized controlled trials, and pooling together, it shows that the testosterone improves ongoing pregnancy live birth rate. That's the figure above. Again, look at the numbers. There are only 4 studies. Each of the studies are very small. If you look at the numbers of women who had testosterone, it's only 203 women. Again, when studies that were removed, those which had high risk of bias, then there was no significant difference in live birth rate. So again, there have been more studies following the Cochrane review, which was back in 2015, and these studies again showed very conflicting results. Randomized controlled trials, you can see on the top, which says it increases, whereas the bottom, it does not increase. So putting this together, again, because of the inconsistent evidence, testosterone use before ovarian stimulation, testosterone pre-treatment is not recommended for poor responders. Again, the same issues as with growth hormone or DHA, insufficient data on what is the right dosage, what is the right duration, and any safety aspects in both immediate and long term. So let's move on to the next, another list among the adjuvants, metformin. So metformin has been used in women with PCOS and with the aim of reducing ovarian hyperstimulation syndrome. And this is the Cochrane review looking at that, metformin before and during ovarian stimulation in IVF in women with polycystic ovary syndrome. And the outcome here is ovarian hyperstimulation syndrome. So let's go through the results. On the top, we see the women having metformin versus no metformin having the long agonist protocol. And in these women, you find that there is a significant reduction in OHSS. If you look at the middle of the slide here, there is one study included in the Cochrane review, which is looking at metformin versus no metformin in women having the antagonist protocol. And this study involved total 40 women, so it's a small study, and there was no difference in OHSS. So, and overall, there was, when combining everything, there was a decrease in OHSS, but we should be focusing on the antagonist protocol, because I think we now know throughout the world, everywhere, every clinic, every center, that is, if a woman is at high risk of OHSS, PCOS women, high responders, we should be using the antagonist protocol and not the agonist protocol. So what about live birth rates? So the Cochrane review looked at live birth rates, and the live birth rates only were reported only in the studies which had the long agonist protocol. And there was no significant difference in the live birth rate if metformin was used with the agonist protocol. So with the long protocol, there's a reduction in OHSS, but no difference in live birth rates with the metformin use versus no metformin. But as we said, we should be using the antagonist protocol in women with PCOS. So let us look at that, the use of metformin in women having the antagonist protocol. This is a randomized controlled trial which came after the Cochrane review that I referred to in the previous two slides, and this is from the UK. And you can see this was specifically designed to address if there was a risk, if there was a difference in the risk of OHSS. So the title says, a short course of metformin does not reduce OHSS in a GnRH antagonist cycle for women with PCOS undergoing IVF. And let's focus on the table. So you can see at the very bottom is the OHSS. So there is no difference between placebo or metformin. So 12 in the placebo, 16 in the metformin. So no significant difference in OHSS. The main reason why metformin was given. But again, however, I want you to focus on the top three results, which look at clinical pregnancy and live birth rate. And what you can see is that in the antagonist protocol in this study, metformin was associated with significantly lower clinical pregnancy rate and significantly lower live birth rate compared to no use of metformin. And these were significant. And therefore, we've said in the ESHRE protocol, and this is a strong recommendation, that routine use of adjuvant metformin before and or during ovarian stimulation is not recommended with the GnRH antagonist protocol for women with PCOS. And let me just clarify, this is using metformin in the context as a clinical adjuvant to improve outcomes in terms of efficacy or safety of the IVF treatment cycle. So I'm not looking at women who need the medication because of their medical conditions. They should very well continue in the treatment cycle. So let's move on to other pre-treatment therapies. So why do we use pre-treatment therapies? We use pre-treatment therapies, we as clinicians use it to suppress or reduce LH and or FSH secretion prior to gonadotrophin stimulation, and with the thinking that pre-treatment therapies cause synchronization of follicular development, prevention of the occurrence of early large follicle, so you don't have an asynchronous cohort where one follicle or two follicles are running away, whereas the others are lagging behind, prevention of spontaneous LH surge, and reduction of cyst formation. And what is the evidence, or what is the current take on the use of pre-treatment therapies? So the combined oral contraceptive pill, this was referred to by Christos in the previous lecture. So the combined oral contraceptive pill in the context of the GnRH antagonist regimen. And I'm referring to the Cochrane review, which was considered in formulating the ESHRE guideline. And here, as shown in the slide, in the antagonist protocol, if the combined oral contraceptive was used as pre-treatment compared to the women who had the antagonist protocol without the combined oral contraceptive pill pre-treatment, use of COCP caused a significant reduction in the ongoing pregnancy and live birth rate. What about estrogen pre-treatment? This is again the Cochrane review, which was considered in the formulation of the ESHRE guideline, plus RCTs that were published later, but main weight was on the Cochrane review, which included most of the eligible studies. And here again, we are looking at estrogen pre-treatment in an antagonist protocol versus no estrogen pre-treatment in the antagonist protocol. That is the top part of the figure. And you can see the two studies that were pooled together in this comparison showed that there was no significant difference in the ongoing pregnancy live birth rate. And at the bottom is looking at estrogen in an antagonist versus the agonist protocol. Again, there was no significant difference in live birth rate. So that's estrogen. So estrogen, COCP, and then now let's see what the evidence was with progestogen. And here in the progestogen, again, very similar progestogen plus in a GnRH agonist protocol versus GnRH agonist without progestogen, there was no significant difference in the live birth rates and ongoing pregnancy. When we come to progestogen in the context of the antagonist protocol versus antagonist without the progestogen, there is only one small randomized controlled trial with 47 women, so there is insufficient data there, but this study showed that there was no difference. So what the recommendations or the conclusions were by ESHRE is with regards to pre-treatment therapies and the 3 pre-treatment therapies of combined oral contraceptive pill, estrogen or progesterone. And here we looked at pre-treatment therapies if they were to increase the efficacy or the safety of the treatment. And the recommendations are as follows. Pre-treatment with estrogen before ovarian stimulation using the antagonist protocol is not recommended for improving efficacy and safety. We mostly use pre-treatment therapies in the antagonist regimen, in the context of the antagonist regimen, and here we say that estrogen does not improve the efficacy and safety. The similar recommendation with the use of progesterone. Again, using progesterone as pre-treatment is not recommended because it does not improve efficacy and safety. As I said, this is in the context of safety and efficacy. We did not look at scheduling, whereby, for convenience purposes, most of us use these as pre-treatment because we want to program our cycles and our workload. So we acknowledge that, and we said that estrogen and progesterone are widely used for scheduling purposes. This is probably acceptable given that given the data on efficacy and safety. So because the data on efficacy and safety shows that they do not cause any detriment, they do not improve the efficacy or safety, but they don't cause any detriment, we said that it can be used for scheduling purposes for which they are most commonly used. With regards to the combined oral contraceptive pill, this is a very strong recommendation. As you can see, we said COCP pre-treatment is not recommended in the antagonist protocol because of reduced efficacy, and that should be clear to all of us now, and there is consistent theme and consistent evidence with regards to this. Now let's move on to adjuvant aspirin. Adjuvant aspirin is very commonly used. It's used in the context of ovarian stimulation. It's used in the context of implantation. As I'm focusing specifically on adjuvants during ovarian stimulation, I looked at the studies. I put down a list of studies that have used it in this context. And what you can see, and the outcome here is oocytes retrieved. And what you can see is that in those studies that use this in the context of ovarian stimulation, aspirin to improve ovarian response, you find that majority of the studies, the top 1, 2, 3, 4, 5 studies showed no difference in the number of oocytes retrieved. The last study showed that there was an increase in the number of oocytes with aspirin. However, when we looked at the clinical outcomes of clinical pregnancy and live birth rate in the few studies that reported, there was no difference in use of aspirin or no aspirin in terms of ongoing pregnancy live birth rates. So the ESHRE recommendation was strong in that use of aspirin before and or during ovarian stimulation is not recommended in the general IVF population and for poor responders. It's not going to improve your clinical outcomes. So then let's go to others which are used, a brief mention of the others which are used, indomethacin. The evidence on the use of indomethacin in the context of ovarian stimulation is limited. It's limited to 1 case reports. There are no controlled studies, no randomized controlled trials. So given all this, there is no evidence to recommend the use of indomethacin during ovarian stimulation. That is the stance by ESHRE in the ESHRE guideline. And sildenafil. Sildenafil is used for various purposes. For some reason, we as fertility specialists have got a strong affinity to use it in women. I don't know why, but there is some rationale perhaps why.
Ma'am, we are running out of time. Can you please wind up?
Yeah. So again, sildenafil, there is only 1 study here, and that is a pseudo-randomized study. Shows no significant difference in the clinical outcomes, and the recommendation from ESHRE is strong that there is no benefit in the use of sildenafil in the context of ovarian stimulation. So to finally conclude my talk, clinical adjuncts are a growing list, and that is a problem. But however, we should, as clinicians, we should make a balanced judgment whether we should be using them or not using them, as most adjuncts have been introduced into clinical practice based on initial poor qualitative studies or reports or anecdotal evidence. Favorable results were not replicated by subsequent RCTs, randomized controlled trials, And besides the cost and lack of effectiveness, we saw that there's very little data on safety. It is difficult to undertake randomized trials and come up with evidence, but at the same time, we should resist the temptation to introduce any adjuncts into clinical practice without rigorous evaluation. We should be able to make such judgments as clinicians. Thank you very much for your attention.
Thank you, Dr. Sankara. That was most informative. I would please stay on for the Q&A round, which will be starting by 4:45 after the next talk. May I now ask Dr. Gunashila to introduce the next speaker?
I thank the organizers for giving me the opportunity to introduce Dr. Professor Siladitya Bhattacharya, who I have heard many a time on his visits to India, and who is an excellent speaker. He's a subspecialist in reproductive medicine and an honorary consultant gynecologist. He's the editor-in-chief of the Human Reproduction Open, and he is also the head of school medicine, medical sciences and nutrition in the University of Aberdeen, UK. I invite you, sir, to deliver your lecture on making pregnancy predictable, the birth of active family planning. Over to you, sir.
Okay, can you hear me?
Yes, we can.
Okay, brilliant. Look, it's a great pleasure to be here with you today. I know you're running out of time, so I'm hoping to keep this talk short. I've deliberately chosen this title just to make us think a little bit, because of course, two discoveries have completely transformed our ability as a species to control our reproduction. The first is contraception, effective contraception, and the second is the advent of IVF. This has now led us to a point where I think people are seriously beginning to doubt their own ability to conceive without some kind of medical intervention, or at the very least an app. In reality, of course, there are chances of spontaneous conception which are measurable, even in populations we consider to be infertile, i.e., those who have tried unsuccessfully to conceive for a period of 12 months or so. And although the actual chance of conceiving and having a baby at 3 years post-diagnosis can vary substantially depending on the diagnosis, I want to draw your attention particularly to those we label as unexplained infertility, in whom there is a substantial chance of a treatment-independent pregnancy that actually leads to a live birth. That's very counterintuitive to us, because obviously in medicine, we believe in active treatment. We believe in using something rather than nothing. And of course, dare I say, that there is a profit motive attached to it, particularly in sectors where there is a fee for medicine. We've tried for 3 decades to use clomiphene successfully to improve the chances of live birth in couples with unexplained infertility. And whilst clomiphene is very effective as an ovulation induction agent, if used in safe doses, as this trial, and obviously this is not a meta-analysis, it's a single trial, in Cochrane suggests, it is unlikely to improve the chances of live birth in couples with unexplained infertility. When we move to intrauterine insemination with superovulation, the situation becomes a little bit more nuanced. So this is an older trial from 2006 from the Netherlands, which makes it clear that in couples with a predicted chance of live birth between 30 and 40%, we would consider this a reasonable prognosis, what they've called an intermediate prognosis. Active treatment using superov IUI does not increase the chances of live births. If you look at the 27% and compare that with the 32% in the expectant arm, there doesn't seem to be an advantage. However, if we look at a different population of unexplained infertility, and this is a recent trial from New Zealand 2 years ago, in a population of couples with unexplained infertility and a poorer prognosis, that is a predicted chance of live birth which is less than 30% over the next 12 months, we can see that there is a significant benefit of active treatment. When we come to IVF, unfortunately, the evidence trail fizzles out because despite everything that we stand for and everything that we do, we haven't been particularly good at comparing IVF with no treatment in couples with unexplained infertility. So the total number of couples ever randomized to this comparison is 86. And luckily for most of us attending this conference, our jobs are safe because the results of this meta-analysis suggests that IVF may just be more effective than no treatment. You can see that the lower limit of the confidence intervals is 1.07. We are lucky that it doesn't touch 1, so we're secure in our belief that IVF is an effective treatment. And I'm sure it is in some couples with unexplained infertility, and I'll begin to explain why. But before that, I think it's worth taking a step back, and it's particularly relevant in this session where we're talking about evidence from randomized trials and evidence from meta-analyses of randomized trials, where the previous speaker has already introduced a slight element of doubt, which is not every randomized trial gives you data that you can believe in. There is an element of quality associated with them. But if we assume that randomized trials are the best way of telling us which treatment is better when we are comparing treatments, it does so in the context of a population. What randomized trials do not do is address the issue that even within that population, some people respond better to a particular treatment, some less well, and actually some patients might do worse, even with a treatment that's deemed to be more effective. So what it doesn't do is identify the likely treatment outcome in the patient in front of us. And of course, the key question when we are consulting with our patients is, can we predict the outcome of alternative treatments in this patient, not in a population of patients, not in 100 patients out there, but in a particular patient? And in a sense, we're at a crossroads because we've always adopted a prognosis-based approach to infertility. We've just not been very conscious of it, because by definition, when we call people who've been trying for 12 months infertile, what we are accepting is that fertility or infertility is not sterility. There are, of course, some exceptions, but by and large, dichotomization of fertility into infertile and fertile is an oversimplification. We're merely calling people who've tried unsuccessfully for 12 months because we expect 80% of them to have pregnancy leading to live birth. And because they haven't done that, on the balance of probabilities, we say that they're in a poorer prognosis group, hence they're infertile. And of course, prognosis changes over time, which does two things. It extends the duration of infertility, which is a negative factor, and it increases female age, which is another negative factor. So this brings me to the concept of active family planning, which means from the point at which couples make an active decision to get pregnant, and with access to contraception, they have now the ability to do that. There is an element, there is a period during which they try for a treatment-independent pregnancy first, but then we are on hand to initiate active treatment when the prognosis worsens. And the philosophy behind it is no couple should wait more than 3 years without a resolution of their infertility in some shape or form. It's a little bit like our approach to active management of labor and the proposition that no woman should labor for more than 24 hours. And that was revolutionary when that was first proposed. Coming back to factors which we know are predictive of spontaneous pregnancy, this is not new. We've known this for a while. Age, duration, previous pregnancy, and of course, semen quality. All these factors are influential. And in fact, in the Netherlands, they still use this tool, which is an online tool, to classify couples into different categories of prognosis. And I've given you 2 examples from the 2 superovulation IUI trials. But this is where it stops. The rest of the world has gone chasing prognosis in IVF, and I'm equally guilty because we developed this this formula or a tool to predict outcomes after either ICSI or IVF in different populations of couples based on data from the UK, the Human Fertilization Embryology Authority data, and we converted that into an online tool which we now use with our patients in the clinic. The problem, of course, is, and this is something that the NICE guideline highlighted when it was published 7 years ago, is we have two separate models. One for predicting natural conception based on the Dutch model, and the other for predicting IVF success. But you can't use both of them to answer the question that your patient wants to get an answer to, which is it better for me to try on my own, or should I go for superovulation IUI, or should I go for IVF? And the reason we can't do that is because these tools were developed in different populations, and there isn't a mechanism to use both of them simultaneously in the same person. And very crucially, the Dutch tool or the Freya tool can only be used once. It can't be used repeatedly. So if we tell a couple, this is your prognosis today, go away and try on your own, come back in 6 months, and then we'll reassess the situation, you actually can't use the Huno model-based tool at that point. It just won't work. So this is what got us thinking into how can we resolve this issue. So we accept that there is a chance of spontaneous pregnancy in infertile couples, but this falls over time. The crucial question is, how long should couples try before treatment? The Huno model cannot be applied more than once, and we cannot use models which just predict IVF outcome, because of course they give us only half the picture. While they can tell us what the success rate would be with IVF, they can't tell us what might happen if we did nothing for 6 months or even 3 months. So what we needed, we felt, was a dynamic approach with the ability to constantly recalibrate the changed prognosis over time. And this is what it looks like graphically. So when somebody comes to us at the point of diagnosis, this is at stage 0, there's a particular probability of pregnancy that changes with each passing month. And the challenge for us is to look at the probability of treatment-independent pregnancy and see at which point the chance of pregnancy with treatment eclipses that, so that we can make a logical diagnosis in terms of when to initiate treatment. And that's what we tried to do in a very, very crude way. So this is very early work. This paper was published last year, and a question was, can we develop a prediction model that can estimate the chances of conception leading to a live birth with and without treatment at different points in time in couples with unexplained subfertility? And the answer is, yes, you can. And we were able to compare what the outcomes would be with no treatment, superovulation IUI, and IVF. It comes with health warnings at this time because we did it on a relatively small data set, because data on spontaneous conception on infertile couples is rare. Most clinics don't collect those data. We collect IVF data, but of course, when patients go home and conceive on their own, very little of that filters through to fertility clinics. So this is a kind of representation of two scenarios based on our prediction model. And you can see that it is dynamic because whether we're talking about this blue line, which is expectant management, the green line, which is superovulation IUI, or the red line, which represents IVF, and the shaded areas are confidence intervals around them, we can see how you can observe how these chances, which are predicted, change over time. And as you would expect, they get worse. And these are 2 monthly intervals since diagnosis. So look at the first scenario, couple A, where the woman is aged 30, short duration of infertility of 12 months, no previous pregnancy. If we want to plot what the predicted chance of conception is without any treatment at all at that point, it's 30% at the start, falling at 6 months to just over, say, 23, 24%, coming down to 20% at a year, and then falling even further. If you went for IVF straight away, you would get a higher chance, but of course, that would come at a cost in terms of invasiveness, in terms of complications, and in fee-paying medical systems, of course, hard cash. If you look at superovulation IUI, it is, as you would predict, somewhere in between, no treatment and IVF, but you can see there's quite an overlap in the confidence intervals there, suggesting that there isn't a clear point at which it overtakes IVF or IVF overtakes it in terms of success rates. Look next at this panel, which is couple B, where the woman is considerably older, longer duration of subfertility, and a previous pregnancy. What is immediately striking is how poor the chances of natural conception are and how much worse they get over time. So right at the point of diagnosis, the chances of spontaneous conception are barely 15%. So that would be a good point to have a conversation about whether IVF should be used sooner rather than later, especially because even IVF gives you very poor success rates if you delay the start of treatment. So I think this reinforces what I think most of us intuitively know and do, but it offers a tangible tool with which we can have these conversations with patients. And here it is. Time stops me from actually exploring this tool with you, but it is available on the internet and you can give it a go. So when you enter the characteristics of your patients, you will get a predicted outcome. And if you try that again over a period of time, so the next month and the next, you will see how that predicted chance changes over time. So at last, we're, I think, on the threshold of getting that elusive reproductive switch, the point at which we choose to switch between not doing something to going for active treatment. Although, as I've said before, our prediction model is at a very early stage and obviously needs more data, more validation attempts. So in conclusion, I think what I've shared with you is the conviction that a personalized prognosis-driven approach is possible in infertility. I've shown you an example of an alpha version of a prediction tool which can be used for the delivery of personalized medicine for the patient in front of you, not a fictional population of patients out there. This will meet the demands of our patients in their expectation of predictable conception on demand, which is, I'm sure, what you're asked for by all your patients at this point in time. And it gives us tools to decide when and how to treat. Which brings me back to the title of my talk. I think this is what positions us on the threshold of what I would call active family planning, which means planning for the family you wish to have, not just the family you wish to avoid having, whilst at the same time avoiding over-treatment by rushing into IVF or IUI too early. Thank you very much for your time.
Thank you very much, sir. That was an excellent lecture, very enlightening and very, very interesting. I think we're ready for the questions now. How do we get the questions, Dr.
There is a question in the chat box which just says, can you explain what a 10% increase in sperm motility would mean? In what baseline motility are we talking about?
I think this question is meant for me, and this refers to the HUNO model, which is represented in the FREA database, the web page that Dutch colleagues use to understand prognosis. And the 10% motility refers to a 10% increase in motility. So, for example, what they did was what you're seeing there, adjusted odds ratios. So for each 10% increase in motility, say from 40% to 50%, you get that predicted increase in chances of conception. So that's what this was about. It isn't an absolute figure.
May I ask a question to Dr. Shankara? So this follows your talk on different adjuvants used in ovarian stimulation. And you do talk about these 8 or 9 interventions that don't seem to work. We do see that most of these are introduced into practice based on certain biological plausibility, maybe some evidence that has been seen in animal studies. When introduced amongst humans and in clinical trials, we find that initially we find evidence for its use, and eventually they all seem to follow the same circle through larger randomized trials. It all comes to a knot. And of course, the evidence synthesis that says that this is not working. There are these questions to be asked each time. Are we introducing these interventions based on certain valid reason? Is there a biological plausibility to it? Is there a gut feel that this would work? Or eventually 5 years down the line, they all come to a knot? I mean, they all seem to be following the same trajectory. What do you have to say for that?
I think I have nothing to add to what you said because you said everything very well. I think most of these are introduced in the term you said, a gut feeling probably. And I think as clinicians, because we, to what we are at the stage, when dealing with patients, we shouldn't be going with that. And as difficult it is to bring out evidence, we shouldn't be rushing into things. And as Patty put in his very last statement, you plan active planning of families, but not over treatment. And over treatment, whether it is any intervention in terms of IVF or even adding on extras to IVF, we shouldn't be doing. And I think it's been very clear now with consistent evidence and consistent statements from professional bodies that most clinical adjuncts have not very much benefit. They add to cost with very little long-term safety data.
Right. There's just one more question, and this might sound silly, but from the point of view of, let's say, an aspiring researcher, this question is to, in fact, any one of you, is when you're looking at studies, how do you bring objectivity into study selection? What is it that you call a high quality study? When you identify biases, is it based on what is mentioned in the study? And if that is how we identify biases, what is the way of knowing that this is indeed, it's not falsification of data? So because everything seems to be incumbent on what is written. So yeah, that's a lot of questions, but I hope you could answer that.
Whom do you wish to address your question first?
I would be most delighted, sir, if you take this up.
Well, I can make a start. I mean, obviously, it could take a huge amount of time to answer your question because you touch on the very foundations of epistemology. In other words, what's the truth and where do we find it in science? But a specific answer to your question could be that when you're talking about how we objectify our assessment of studies on trials, when we do critical appraisals or systematic reviews, there are standard tools that we can use. And of course, both the previous speakers have mentioned how they've done that. And these are there, these are in the public domain. So they haven't made the rules up as they've gone along. So I can kind of reassure you on that. But you do also talk about falsification, and that's another big subject. And there are some statistical tools that can be used which give us a suspicion about whether a trial could be falsified or not. But I don't think we can go into the details there, but there are publications in the literature you can look at. And I'll give you one example. If you look at a baseline population in a trial, and they are very, very alike, then something tells you that the data could have been fabricated, because in reality, when you take a random sample and you divide them into two groups, purely by chance, you'll have subtle differences between the groups. It's very unlikely that they'll be absolutely identical, because to get that, you need a sample size close to infinity. I don't know if maybe Christos and Kamal want to come in.
Yeah, if I can add to that, I'm very similar to what you said, Prof. So with regards to the first question, there are tools out there. How do you assess the quality of the study? And Equity Network is one of the websites you could go into, and for each type of study, you can have an objective checklist of how to identify study quality objectively. With regards to the second one, again, very similar lines to what you said. If it is too good to be true, then there's something suspicious about that. And many a times we see studies that take everything in the checklist, and in fact, over than what is asked for in the checklist. Then there's a little bit of suspicion. For those who have done randomized controlled trials, properly, how difficult it is to get a randomized controlled trial, and everything, being so homogeneous. So that's another way probably which will raise an alarm.
Can I ask a question to Dr. Christos?
Yes.
There are some reports of using ANTAG on the second, third, fourth day on the simulation. What is your comment about that?
Thank you for the question. Look, these are interesting protocols, and there are some suggestions in some studies starting the antagonist even before the menses. All these are very interesting concepts, and the authors that have published these pilot studies, in most cases, have made quite a substantial effort to justify the physiological rationale on which they base them. In terms of, if you're asking, did we assess those studies in our network meta-analysis? No, we did not, because the evidence is not substantial. And whenever you're designing a network meta-analysis or any type of question, you need to make sure that you identify the key questions. Otherwise, you add a lot of noise without necessarily enhancing your signal. So these are interesting concepts. I remain unconvinced on whether everything that has been claimed to be, for these earlier introductions of antagonists to be able to achieve is truly valid. But as we've just now been discussing, anything can be, and I would be more than glad to be to stand corrected if proper randomized trials were to show that indeed there is some benefit in starting the antagonist earlier. But at this point in time, I would say this is not, we already, as I just demonstrated, we do not even have enough evidence on the basic variations of the antagonist protocol. So if someone wants to do a study, instead of studying day 2, day 3 antagonist, I would encourage them to study day 5, day 6 versus flexible, or fixed with a pretreatment versus no pretreatment, and try to identify why we are observing the phenomena we're observing. This is one of the major problems in research, that we tend to create new questions when we haven't even yet answers to the main questions.
There is a question from Dr. Neena Malhotra to Professor Bhattacharya. Has the prediction model been validated by units other than the UK?
We validated some of it in a Dutch cohort, but and we would love to validate it in data from other populations. So Nina, if you've got data on couples with infertility, just say so and we'll do it. The problem, as you know, is we are very good at collecting IVF data. We're not very good at collecting data on non-treatment related pregnancies in patients who have attended for general fertility clinics, because I don't know what your mechanisms of follow-up are, but usually they don't come back to the fertility clinic to tell people that they've got pregnant on their own. We are very lucky because we live in a part of the world where there's a single maternity unit. So everybody we've treated or not treated in a fertility clinic have only one place where they can deliver. So by doing data linkage, we can work out who's got pregnant through treatment and who hasn't. But most other places don't collect these data. But if you think you could prospectively collect data over a couple of years, let me know. I'd be delighted to work with you.
Thank you.
This is my question to Dr. Christos regarding fixed dose protocol. Yes, you told that we have more pregnancy, live birth rate, and less cycle cancellation. But what about your viewpoint about increased doses of gonadotropin for the fixed protocol? What do you say? What you comment on this? Dr. Christos, please.
Thank you. It is indeed true that, and we do know that from clinical experience, but from the individual RCTs as well, that sometimes starting the antagonist early might lead to a longer duration of stimulation and at the same time higher total doses of gonadotrophins. This is something that it is a side effect. However, at the same time, this does not change the main outcome. And the main outcome of whenever a patient comes to our clinic, they're not necessarily interested on whether they'll end up, spending another 200 units of FSH. They're interested in whether they have a higher chance of obtaining an ongoing pregnancy or even better, a live birth. And I think that if you discussed with any of your patients that by giving you this medication, we run a risk of prolonging your stimulation time by 1 day, 1.2, and also by adding another 200 to 300 units, international units of FSH, but will also give you potentially a 20% relative increase in your ongoing pregnancy rates, I think that most of your patients would be happy to have the fixed protocol.
You're right, but especially in hyper responder, we are more worried about higher dose, not in the normal responder.
Let me just clarify, and that is very correct. I did make a point at the end of my presentation that the evidence that we have from randomized controlled trials are not as strong for hyper or hypo responders, for poor responders or for PCOS women. We do need more evidence regarding the comparative efficacy and safety of these interventions in those populations and in these populations, and we do need more targeted research.
Thank you. Thanks a lot.
There's a question in the chat box for Dr. Sesh. This talks about it's out of what you spoke today. It's not from that topic, but the question is, what is your opinion regarding benefit of pre-IVF hysteroscopic scratching? Okay, so those are... Dr. Sesh, if you're there, could you take this question?
Thank you for the question. And so because I've alluded to stimulation in the context of stimulation, I didn't cover this one. There is a long list of add-ons, as we said. And with regards to the endometrial scratching, I think, we have had consistent evidence from very robust randomized controlled trials. One which was published in the NEJM, which came from New Zealand and involved centers in the UK as well by Sarah Lenson, which showed that there was no benefit with endometrial scratching pre-IVF treatment versus no scratching. So that study has shown. And there is another study which was published, which was presented at ESHRE this year, and that's from a large randomized controlled trial in the UK populations. And here is endometrial scratch pre-IVF before the first ever cycle, and that has shown again that there is no evidence of using endometrial scratch. So with that consistent evidence from very good randomized controlled trials, I think endometrial scratching should be locked up in a cupboard.
Right, that very beautifully answers the question and very definitively.
There's a question to Dr. Christo. Any subgroup analysis of benefits of fixed antag in women with high baseline LH?
Thank you. The short answer is unfortunately no. We do not have, we weren't able to identify randomized control trials that are eligible, where either have stratified on the basis of the baseline LH levels or have included exclusively women with high baseline LH levels so that we can perform valid comparisons. I do understand the potential physiological rationale behind the question, but as I said, the evidence is not there to properly inform clinical practice. And I do encourage Nina to potentially consider doing a study in these types of patients, because there might be actually the benefit or the potential harm could be different than what we're observing in the normal unselected population.
Christos, it's not an RCT, but this is our data, and we were kind of pulling out the data for the last 7 or 8 years, and we realized that when we tried to look at fixed and the flexible, we found that women who had high basal LH, and we don't give OCP pretreatments, and our unit doesn't believe in giving progesterone since we didn't really find it very, very fascinating. But what we got, and this anyway retrospective data, we found that the women who got a fixed antagonist, their live birth rates were definitely better when they had in the group when we saw. So perhaps it could be a food for thought for putting up a paper for an RCT. That's what I thought, if there's something like that.
I fully agree with you. I just wanted to base my answer, Nina, on what we have at hand and what we're publishing right now. Yeah, that's why I said I understand the rationale behind it. And yeah, I do agree with you. That would be a very interesting idea to explore in a more systematic way.
If I can ask Nina a question, if there is 1 second. Nina, do you give fixed antagonist routinely, or do you give flexible? Because we give fixed antagonist, day 6 start based on the convenience, and also, you don't have to bring the patients if they don't have to come back for other reasons.
We've been giving flexible until the last 2.5, 3 years, and we never believe in monitoring them with LH. So kind of move to a practice, not in some groups, but generally, because we were not like kind of being cherry picking some patients or something, but we just kind of moved to a practice where we said, let's try a fixed protocol. And then when we found, so it's like comparing our older data set with the recent, practice of moving to a fixed protocol.
All right. Dr. Christos, if I may be allowed to ask you this question, and this is again not on the talk you delivered, it's on the other paper, the landmark paper, which got us thinking about progesterone elevation and the value that you set. The fact is that we're talking less and less about progesterone elevation and those values. And I just wanted to know your opinion on how much of this, after those studies from Vietnam and different RCTs, which actually showed no difference in terms of live birth rates in normal responders when women underwent fresh versus frozen cycle. So I do wish to know what's your perspective on this problem as of now. Do we give it up completely?
Not directly relevant to the talk, but I'm very happy, exploring the effects of elevated progesterone at the end of the follicular phase and stimulated cycles has been my passion for more than 10 years now. And I'm now at a specific point in my career where I think that we have almost overwhelming evidence about its negative effect. And people that tend to ignore it, I am very, very open, and I welcome them to challenge me and show me the data, because I do think that in most cases, a very clear effect is there. And that is the good thing, and what has been the convincing for me is the fact that we essentially have the same hypothesis confirmed with so many different, through so many different sources. And one of those sources is exactly as you mentioned, the fact that in studies where potentially no difference was shown in freeze-all versus fresh, like in the study by Lan Vuong from Vietnam, when they stratified their group according to the, to the value of progesterone on the day of ACG, they showed actually that women that had higher progesterone were actually more likely to benefit from a frozen embryo transfer. At the same time, last year we published a meta-analysis analyzing all the data on freeze-all versus fresh. And there we were able to see and to show, based on the available evidence until that moment in time, that if there is a benefit in frozen, in freeze-all and in frozen embryo transfers, but no, the freeze-all as a strategy is in high responders. And I would just like to remind everyone that high responders are particularly the ones that will have higher chance of having progesterone elevation. Whereas in normal responders, that effect is not as strong, and it certainly wasn't significant. So these are just two sources that show us that the effect is there. In regards to the question you asked about the cutoff, I think the cutoff, I hate cutoffs. I think that the cutoff is very misleading, and that is probably the main source of our problems and why some people dispute and think that there is no effect. Yeah. I actually encourage people to look at the variable continuously, but that takes a lot of effort. You need to make sure you have a very good assay. You need to make sure you have a very good data analyst, someone that can help you properly plot the association and identify at what stage you need to start considering offering freeze-all to patients.
Right. Thank you. That pretty much settles that for me.
Do we have time? Because I just need to, do we have time?
We have 3 minutes, yes.
So Christos, we look, yeah, what you said is, data is backed up by data, fine. But are we just looking at progesterone itself? We can't just be looking at progesterone. In many of these women, you're talking about high responders and you're saying it's more relevant in high responders. It's the estradiol levels as well. And estradiol levels could be having a negative impact on the endometrium and implantation. So you can't just look at progesterone by itself. I think that we should be considering estradiol as well. And that could be not just by progesterone, but the elevated estradiol as well. I do not know what you have to say about that. And what's your thought on that?
In science, you never say never. And I could never dismiss any theory and any idea. What I do know is that from a physiological perspective, we do know what progesterone causes. And progesterone does cause essentially secretory transformation and initiates the process that will lead to the implantation window. So if that happens, then essentially you'll bring the implantation window earlier, and that's how the effect of progesterone is actually implemented. Estradiol, there might be indirect effects, but if you do, and I'm pretty sure we can sit and do that test at some point in time, if we do a direct acyclic graph, you'll see that estradiol is unlikely from epidemiological perspective to be involved in the causal association. And there are studies out there that have tried to adjust or to control for one or the other. And in most cases, I wouldn't say in all cases, because I know all the evidence, the progesterone came up significantly as a stronger predictor in terms of pregnancy rates. But as I said, I do not say that there is no way that your hypothesis is not correct.
Thank you.
We will be winding up the session because the oration is about to happen. I thank you all the chairpersons and the speakers for the excellent talk and excellent discussion. Thank you very much.
Good evening, everyone. Moving on to our next session, that is panel discussion on endometriosis. The controversy continues. I would like to invite my moderators, Dr. Kuldeep Jain sir, Director, KG IVF Center, Delhi, and Dr. Surveen Guman, Director and Head IVF Max Super Speciality Hospital, Saket, Delhi. I would also like to invite my panelists, Dr. Padma Rekha Jirge, Director, Sushrut Assisted Conception Clinic, Kolhapur, Dr. Neeti Tiwari, Senior Consultant from Sir Gangaram Hospital, Delhi, Dr. Lakshmi Chirumamilla, Senior Consultant at Nova IVF Center, Hyderabad, Dr. Monica Verma, Medical Director at Sadbhavna IVF Center, Patiala, Dr. Damodar Rao, Consultant at Rao Hospital, Coimbatore.
Good evening, everyone. I welcome all of you for this very interesting panel, which we are going to have for next 50 minutes. We are having a very highly esteemed, excellent faculty with us for today to discuss the problem we face in day-to-day life in managing the endometriosis. We are having a mix of infertility consultant as well as the endoscopic surgeons in our panel. So I hope that they will be able to solve many of your queries during coming discussion. It is a clinical based scenario panel, and we will try to have it interactive. We will be having their personal experience as well as the evidence-based discussion. So, Surveen, can you share your screen?
Yeah, is my screen not shared?
No, at present it is not shared.
1 second.
Yeah, so while we wait for Surveen to share her screen, as you all know that endometriosis is a disease which is really gives lot of dilemma in our clinical practice, whether it is etiopathogenesis or diagnosis, or for that matter, treatment of endometriosis. Whatever you do, it is a chronic disease, it is a progressive disease, it is a complex disease. It is not malignancy, but behaves like one. And when it comes to the diagnosis, if you see this slide, this is very, very important slide. When it comes to the diagnosis, usually 7 to 9 years gap is there from the onset of disease and diagnosis of disease. And most of the time, a person is looking for doctors, changing the doctors before the diagnosis is made. And this is very, very common phenomena in our practice. When you come to the management, like pain or infertility, it is again a dynamic condition. Even if the lady has conceived in her and finished her reproductive career, she will continue to suffer from pain, and they can present even in the perimenopausal age. And there are certain recommendations which we will discuss in coming discussion. So we move on to the next case. This is our first case. We are having a 38-year-old woman. She is para 2, 13 years, the last first child, and 10-year-old second child. She presents to you with history of severe dysmenorrhea since 20 years. Now, this dysmenorrhea is progressive. She has been taken a lot of medication for this pain. Now, she has developed dyspareunia also for 5 years. She is having constipation. She is having pain while passing stool and urine. And pain, of course, is worsening. On examination, bilateral adnexa tender, fullness in right phonesis, induration in post phonesis and tenderness. And there is a uterus which is having restricted mobility. Ultrasound shows this picture. Now, my question to Dr. Padma is, how will you proceed to investigate her? What are the possibilities in this case? And what you will be looking for before you make a diagnosis? Dr. Padma, please.
Yeah, I mean, she's a Paris woman who appears to have completed her family and incapacitated with severe pelvic pain. And the investigation so far, the ultrasound, the clinical picture and the ultrasound is very suggestive of pelvic, ovarian endometrioma. In addition to that, she has all the symptoms and signs suggestive of a rectovaginal septal involvement as well. So in this kind of scenario, one of the most important investigations would be an MRI to evaluate the extent of the disease. And one of the things we may have to bear in mind is any malignant transformation in the condition. But MRI is the investigation I would go for to start off with.
What do you want to see in the MRI?
The extent of the disease, mainly the extent of the disease and involvement of the surrounding structures, whether there is any rectovaginal septal involvement to actually basically decide how deep is the disease, how widespread is the disease, and whether we can surgically eradicate, that will help us to decide whether surgically we can eradicate the disease.
So when you are having this type of picture on ultrasound, will you like to see any other thing when you are doing ultrasound? That is my question number one. Because she is a case of 8 centimeter, I think 8 centimeter, and with a lot of pain and other thing. So even before moving on to the ultrasound, on examination, you will like to add something, because if you, Survin, if you can go back on to the examination, is it a complete? Yes, I think transrectal ultrasound also will give you a lot of information, because you are looking for a rectosigmoid. Anyone from my panel, apart from MRI, will you like to use any other modality when you are suspecting a rectosigmoid? Dr. Monica, you can answer this question.
I just want to know one thing before I answer that what is the treatment that she has taken for the last 5 years?
She has been taken a lot of NSAID, she has taken OCPs as well as Endoreg also, like Dynogest.
So the investigations which are coming up are these sonocavitary ultrasounds that can help for rectovaginal, doing a transrectal with transrectal ultrasound detail helps in it, and an MRI will help with it. And if she has symptoms relating specifically to the bowel, then specific investigations regarding a sigmoidoscopy to see for any penetration of the lesion over there.
So anyone will like to comment on sigmoidoscopy here?
Rectoscopy or...
Sir, recently there have been papers coming up regarding using ultrasound with gel inside the vaginal cavity. So they have made up a classification on this called ultrasound-based endometriosis classification, and they have correlated that with laparoscopy. And there was significant correlation, and we could even classify the staging according to this ultrasound. It is called U-based classification. So with ultrasound itself, we can identify the extent of the disease, whether the rectum and sigmoid is involved, if there are nodules in the bladder, all this could be identified just with an ultrasound. It's just we have to focus, and they said that at least 30 minutes we need to take, so that with the gel-filled vagina, with the vaginal scan probe only, we can identify all these as well.
Yeah, I think there are a lot of modalities which have been investigated and has been suggested, but till now the accepted modalities remains transvaginal sonography, transrectal sonography, and MRI.
Transvaginal sonography, the negative sliding sign is also something that is looked for.
Yeah, that is actually for the fixity and other things. So that will also help. But when we talk of what you call rectosigmoid, the sensitivity of transrectal ultrasound is supposed to be better than MRI. That is one thing which has been proved in many of the papers. And unfortunately, we are not we are not using transrectal ultrasound more in these situations. So that is one suggestion, and that is basically a recommendation also, that we should be using more and more transrectal ultrasound. Otherwise, the sensitivity of MRI and transrectal ultrasound is quite good in picking up rectosigmoid thing. Anyone for any biomarker? Anyone using biomarker for diagnosis or management of a follow-up of endometriosis? So nobody has given answer. So probably no one is using the biomarker, and that gives a very strong message to our audience that as far as the biomarker like CA125, etc. is concerned, they should not be used. They are not recommended. This is one paper, Cochrane 2016, SRA recommendation 2014, that at present we should have a biomarker, but unfortunately for endometriosis, we are not having a biomarker which can add to the present scenario in clinical diagnosis. What about laparoscopy? Like leave aside this case, when a patient comes to you with a 2 centimeter, 3 centimeter endometrioma, suspected endometrioma, how many people will go use diagnostic laparoscopy to diagnose? Anyone can take. Is it a prime? Yeah, Lakshmi.
When there is a clear-cut endometrioma on the scan, definitely there is no need. And most of the times endometrioma with a ground glass appearance, it just glares at us. And if you want to see if there are any adhesions, the ovary might be immobile, and all those additional features with the symptoms, most of the times will give us a diagnosis. And in fertility patients, definitely, nowadays they're saying that there is no need to do laparoscopy, just for diagnosis. If there is
So-
any additional point you want to know, then definitely it is recommended.
So when do you suggest laparoscopy in suspected cases of endometriosis?
Sir, it will depend upon the symptoms. It will depend upon the symptoms of patients. Suppose in infertility, there is a long period of infertility, and there is a cyst there which is looking like a 2 to 3 centimeter endometrioma. I would like to scope it indefinitely to know the tubo-ovarian relationship also, adhesions, to look for the adhesions and do an adhesiolysis. So it will be more of, therapeutic rather than diagnostic. I'm sure that it is endometriosis, but then it will take care of the tubo-ovarian relationship. I will come to know how, what will be my next course of action, whether IUI would help in her, or the tubo-ovarian relationship is so disturbed that I should go for IVF straight away. So in infertility, in such scenarios, I will think of doing a laparoscopy even with a 2 to 3 centimeter cyst.
I think there are very clear-cut indication of laparoscopy when we discuss the diagnosis point. Whenever you are in doubt, always put a laparoscope.
Yeah.
Okay. Second thing, when you are looking at the color Doppler, because we have not discussed role of color Doppler here. So whenever you are having a doubt and you are having a lot of differential in your mind, you can put color, and that will add to your diagnostic acumen. And if on color mapping, if you see some papillary projection with a high this what you call the blood flow, then certainly it is an indication for putting a laparoscope, because you need to rule out, though it is looking like endometrioma, but when you see a blood flow inside the endometrioma, you must put a laparoscope and send it for biopsy. Third thing, when your endometrioma is increasing in size and not responding to your routine treatment. So these are some of the points which should be taken into account, because laparoscopy remains the gold standard for the diagnosis. Can I have slide on laparoscopy? Yes. So this is a recent Cochrane. Can you go back? Yeah. So this is a recent Cochrane review, and there is basically a moderate quality evidence that laparoscopic surgery increases viable intrauterine pregnancy, but for diagnosis it is not a primary, though it is a gold standard. And whenever you are in doubt, one should use laparoscopy as confirmatory test. I think we can move on to the next question, because
So if
we
there
have
are solid areas also, solid areas or papillary.
yes. You should always confirm that whenever there is a doubt, if you are very sure that you are dealing with endometrioma, nothing else. One more thing I will like to say, in this type of patient, 38-year-old, 8 centimeter, before you put the scope or any medication, you should rule out this obstructive symptom, like in the ureters. You should rule out that any infiltration in the bladder, any infiltration in the rectum. Okay, so these are few things which will help you in managing these cases. So diagnosis will not be complete if you have not ruled out the obstructive uropathy and other problems. I think next case, Surveen,
I'll go to the next case. Case 3, sir, you will be screen sharing. So you can go on to case 3 on your laptop. Mrs. OL, 32 years, married life 8 years, male factors normal, laparoscopy done 15 days back, which showed small peritoneal endometriotic implants in POD lesion, which were coagulated. These are patently normal, no adhesions. AMH is 2.2. She is very keen to conceive and has been trying for 2 years. What will be your option of treatment? Expectant IUI, IVF? Are the results of IUI different from other patients without endometriosis? Patient is concerned about whether stimulation would cause recurrence. What is the evidence? What drugs would you use to stimulate? Clomiphene, letrozole, gonadotropins, and how many IUIs before IVF? Neeti?
So she is a young woman, 32-year-old, with a pretty good ovarian reserve and mild endometriosis. And though she's married for 8 years, you have written that she's only trying for 2 years. So we would I would definitely go for a COS and IUI. And as far as results are concerned, the results are similar to unexplained infertility. They in fact behave like unexplained infertility also only. Though it is written that clomiphene can easily be given in these patients, but if you ask me personally, in patients of endometriosis, I generally prefer gonadotropin, but yes, clomiphene can also be given.
Yeah,
And
so, expectant versus ovulation induction, you would not go for expectant. I think that is very clear.
I would not go for expectant, yeah.
And so there's no role for expectant.
Anyone will go for expectant in my panelist?
No, she has
No, no,
already
no.
tried for 2
Okay,
years.
so this is the second message coming from this panel. Post surgery, or once you have diagnosed endometrioma, the role of expectant management is very, very limited. One has to go ahead because it is a progressive disease. And if you wait for the conception, though some of the patient may conceive, but rest of will progress from grade 2 to grade 3 and grade 3 to grade 4. So yes, you can continue.
Lakshmi, does stimulation cause recurrence? Is there any high quality evidence of recurrence because of high levels? Because patient is concerned?
Recurrence is not affected by stimulation. Definitely, it is not affected. There is no strong evidence supporting this.
And in your clinical
recurrence,
anyone?
most of the times, what I see is because the recurrence is mainly because of inadequate removal at the time of surgery rather than because of the stimulation.
So, what would be your first choice of induction, Monica?
I'll prefer clomiphene when I'm inducing this patient, and along with gonadotropins. And IUI, the evidence is coming in, more evidence, whatever it is IUI has a lesser role in endometriosis now, and the results are lesser than compared to unexplained infertility. But it being a simple option, and we don't have much options, so if she hasn't had any treatment prior, we can do a stimulation, 2-3 cycles of clomiphene, gonadotropin, 2-3 cycles, and then add IUI also. But IUI per se for endometriosis, the evidence now is lesser for a benefit.
Yeah, so many people have been considering that maybe letrozole is a better drug because letrozole has an anti-endometriotic action which is coming up. But evidence does not suggest it, and neither does it suggest that the gonadotropins are better than either letrozole or clomiphene in cumulative pregnancy rate. So oral ovulagens would be the first choice, and there is no preference on that.
But I think I will like to add one point here. Even if it is not endometriosis, if you compare the pregnancy rate, clomiphene, letrozole, and gonadotropin, it is always better with gonadotropin. So same thing is applied here, whether it is endometriosis or not. So, so when we compare the fecundity, gonadotropin becomes the better drug as far as the fecundity rate is concerned, but certainly it is not a primary drug. That should be understood. Primary drug could be a oral therapy, whether letrozole or clomiphene. And if your patient not conceiving, then certainly you have to move on to the gonadotropin.
That will be more faster in
yes.
patients.
Yes, yes.
And one more thing I want to add here is, sir, that when we give gonadotropin, people think that if we give 75 unit, that is enough, because the idea of giving gonadotropins in IUI is to make 2 to 3 follicles. And that is my submission against letrozole also, because letrozole being a drug which only cause monofollicular, development. So a patient who is already ovulating, so to give letrozole, and the same way gonadotropin in a dose in which you only make 1 follicle, definitely no benefit. But if you are giving gonadotropin to make 2 to 3 follicles, then there will be a benefit of giving gonadotropin.
Anyone for combination? Anyone for combination of letrozole and gonadotropin?
I think the combination works as well as only pure FSH. I think there is good evidence to suggest that the combination.
Yes, I think that is very good point.
It's better than just pure. Sometimes it is better.
And it reduces the dose of
Reduces
gonadotropins
the
we have to
cost
use.
and the
Yeah.
dose. Yes,
Yeah.
absolutely.
Yeah, that's what I like to add. That's what we do, giving a clomiphene and gonadotropins combined. But 2020 evidence for IUI and unexplained infertility. So it's what has been proved is only an oral clomiphene or letrozole or versus gonadotropin, but they have specified that clomiphene and gonadotropins should not be added. And gonadotropins should not be used because of the multiple pregnancies. So it boils down to clomiphene with IUI for infertility.
No, I think this is a very debatable observation, and I don't agree with this observation. We need a little more evidence that clomiphene remains the drug for infertility. I think this should be thought of. What we are doing, what we are practicing, we need to publish the literature because whatever literature we are citing may not be applicable to our patient at present. I think the recommendation, most of the papers and most of the Cochrane review, they say that the fecundity is better with gonadotropin. There is no doubt. There are multiple papers, and gonadotropin has a place in your ovulation induction program, but you have to individualize.
Yeah. And if you read this paper also, sir, 2020, which she's quoting right now, Dr. Monica, they do not rule out gonadotropin altogether. They say that you have to give it in a dose that you make 2 or 3 follicles. The idea in unexplained or mild endometriosis is to make 2 or 3 follicles. That's it.
But it is very difficult to say what is the dose that will make 2 to 3 follicles.
Yeah.
For some women, 75 might make 4 or 5 follicles.
That's why
So we have to individualize it.
That's why
And we also have to
That's why the incidence of side effects, multiple pregnancy become more with gonadotropin. It's a drug which has to be handled very carefully. That's why.
Yeah, definitely. And we have to titrate the dose according to the body mass index of the patient, age of the patient, and the ovarian reserve. It's not just like whether we use clomiphene or gonadotropins.
Yeah. This is what Monica was saying. This chart is showing that yes, they do have a lower pregnancy rate than unexplained infertility.
Can't hear you too well.
Can you hear me?
Yeah.
Yeah. So they do have a lower pregnancy rate. So number of IUIs quickly, Padma, will you take that?
Yeah, I mean, I would say 3 maximum.
Anyone doing more than 3 in this patient?
Dr. Survin, it should be dependent on the stage of endometriosis. If you are dealing with a patient,
it's a mild endometriosis.
Yeah.
Oh, you have to screen share.
Yeah. Can you see my screen?
No.
Now?
No.
Yeah. So I think Survin, you can continue because here I can see my screen.
Over to you.
Yeah. So this is our next case. She is a 34-year-old lady, married for 4 years, has 8 centimeter endometrioma. She is trying to conceive for 4 years. She has taken few cycles of induction, but has not conceived. Male partner is just normal. Her AMH is 3.2. Next.
So tubal status?
Tubal status, HSG was done. It is showing a very not very confirmatory spill. There is a restricted spill.
Yeah,
so my question to Damodar, how will you manage this case? Medical, anyone for medical?
Medical, she's already tried. I mean,
medical means medical for endometriosis.
Hormone
infertility. Yeah.
No. There's no role for any medicines as such.
Anyone for IUI?
If her tubes are not that good, I think she shouldn't go in for IUI either. I think, and it's only unilateral endometrioma, so I think we could go in for surgery in this case. Her AMH is also not too bad.
Okay, so when Damodar, when you are doing surgery in this patient, what are the concerns as a infertility consultant? I am having a lot of concerns. What are
Yes.
your concern as a surgeon?
Yeah, the main concern is about loss of ovarian reserve while doing the surgery.
Okay, that is one. Any other concern?
The concerns would be, I mean, we're also able to at the same time, I think, evaluate the advantages would be you could evaluate the tubes at the same time, maybe do a tubal disconnection if required.
I agree with that. But because I am very concerned about 2-3 things. Can anyone else is having some concern when we are doing endometriosis surgery?
Recurrence, that it shouldn't
Yes,
recur.
I think recurrence is very important concern for all of us, because it is a progressive disease, and so that's why it has to be a very thorough surgery, whatever you are planning. And that is another concern. And third concern is complication, because she is having 8 centimeter endometrioma. I expect a lot of infiltration to the
bowel, ureter,
ureter.
bladder.
So we have to minimize the complications. So whenever we are putting a scope, we should have, as a surgeon, these 3 concerns in our mind and then proceed. So any role of Damodar pre-operative? Are you giving any pre-operative medical therapy?
No, there is no role for pre-operative therapy in infertility.
Anyone else?
We don't give any.
Anyone else is giving any pre-operative therapy?
In case of intractable pain, where she's not able to tolerate anything, at that time you can give something before.
No, you have decided. You have decided for surgery. Will you like to give any pre-operative?
No.
Not in this patient. She's
Okay,
34.
So I think this is the third message coming from my panelists, that there is no role of pre-operative medical therapy. This is Cochrane database 2020 also suggesting the same. So now coming back onto the surgery, move on. So coming back onto the surgery, Damodar, what is your preference when you are dealing with this? Are you fulgurating, or you are doing cystectomy, or you are combining?
It's only a unilateral. It's a unilateral cyst. Her AMH is good. I would prefer to go in for a cystectomy.
Okay.
Because the pregnancy rates are supposed to be better after a cystectomy, and again, your recurrence rates are lower. That's what I would prefer to do: vasopressin and cystectomy.
Okay. Any other precautions you are taking when you are doing the cystectomy to reduce the ovarian
when you reach the hilum of when you reach the hilum of the ovary, you can probably even leave a little bit of the cyst wall behind and not try and pull it out from there, because the blood supply comes from there. And we should not use any cautery at the hilum of the ovary, especially, and not use any cautery anywhere at all. If you're using vasopressin, the amount of bleeding will definitely be less. If at all required, you can give compression with the gauze for some time, look at other things, and come back. Many times the bleeding has stopped on its own. If at all, maybe some pinpoint coagulation here and there.
Any other trick to reduce the preserve the ovarian reserve? Because as a infertility consultant, I am really worried that
you can inject some vasopressin into the uterus also.
Yeah, so that is one. Any other trick? Anybody else? Yes, Damodar, continue.
Yeah, I mean, traction, counter traction, and stay as close to the ovarian cyst as possible.
Okay, I think one more thing I will like to convey, that we should use minimal cautery, because what happens when you are doing using excessive cautery, you are going to again compromise ovarian reserve. So minimal cautery, and Damodar has very nicely highlighted use of vasopressin to reduce the blood, because if there is a bleeding, then you are going to cauterize. You have to take care of that. And near hilum, when you are reaching near hilum, usually if you are not very careful, there will be a lot of bleeding, and in bargain you will be cauterizing, and you will be doing more harm. So you can always combine. That is called the dual technique, like cystectomy and the fulguration. So that is again a method to reduce the risk of ovarian reserve.
Sir, I want to add one thing here.
Yes.
We can give pressure with gauze also.
Yeah. I mentioned
That
is
was
already
highlighted, yeah.
told. That he has
It's already been
already told. Anybody else will like to add any point at this point of time regarding the surgery?
So also there is these something called snow, which can be applied. It's supposed to reduce bleeding intraoperatively. You apply it on the ovary, and then you do whatever is required, and then you have to take it out. It's like a hemostatic agent, basically.
Okay. And what is your aim actually when you are doing the endometriosis surgery? What is your aim?
One is to do the cystectomy and restore the anatomy. If her adnexa is good, if the tubes are good, then she should immediately try for pregnancy in the next cycle itself.
Yeah, so you have to do the cystectomy, you have to do extensive adhesiolysis to maintain tubo-ovarian relationship, and it is always better that you are thinking what you are going to do next, and for that you have to grade the disease, because grading is very, very important in the further management. Whatever you do, if you have not graded the disease properly, you will not be able to provide a better outcome. Now you have operated this patient. What next?
That's what I would probably use something like the endometriosis fertility index. That is basically you look at the function of the tube, the ovarian reserve, number of years of marriage, husband side. You look at all this, and that can give you a guideline. If it is 0 to 3, then directly for IVF. If it is 3 to 6 for IUI, and if it is 7 and above, then you can even ask to try naturally. So that could be a guideline that can be used. So basically, it's a function of the adnexa that is important.
How many people are using this fertility index? Dr. Monica?
I think
Dr. Niti, Dr. Lakshmi?
So not using calculating, but we use all these parameters. When we decide the further treatment, we definitely use all these parameters. The years of marriage, then what we find at the time of surgery, what is her ovarian reserve before the surgery, what do we find, how well are we able to establish the tubo-ovarian relationship at the end of surgery, how happy we are with that. All this will decide her
husband side also.
Yeah, I think the fertility index is very, very good if you can use, but the problem is it is little cumbersome.
Not
and yeah, it is a little cumbersome. So because there have been a lot of classification, in this fertility index is one of the best ones.
It can just be used as a guide, as a guideline, sir. I mean,
yes.
And if we are doing a surgery, a study, sir, if we are doing a study, it gives a very, objective way to tell us what was the score and how we proceeded. But in routine practice, clinical practice, we are not calculating as such.
Yeah, basically use these points to kind of decide how to go.
That we are already using in our clinical practice.
Yeah, we are using it, not calculating, but using all the parameters.
Score, but we are using
Yeah. Any role of anybody will like to give a post-surgical therapy before moving on to IUI or IVF in this patient?
Not at all.
I think it's no.
Okay.
Absolutely.
So again, there is not much role of post-operative treatment. Only role is when you are going for straightway for IVF. There is a role of ultra long protocol, so you can continue suppressing post surgery for 8 weeks to 12 weeks, and then if you plan, certainly that is one indication for post operative therapy. Otherwise,
but these days, I think even that people are not doing.
Yeah.
Because the surgery itself will bring down the reserve, and if after that we continue giving GnRH agonist, it will further pull down the reserve.
Niti, basically in this patient, like she was having a very good AMH. So in this patient, again, yeah, we will be coming back to the stimulation, what is stimulation. So we will discuss it there, whether you should go for agonist, ultra long or antagonist. So anyone from our panel wants to add anything? Otherwise, we move on to the case 4. Surveen.
So I'll move on to case 4.
Yes.
28-year-old woman married for 5 years, trying to conceive with a normal male factor, operated for endometriosis 2 years back, endometrioma removed from right ovary. After that has had 4 IUIs with controlled ovarian hyperstimulation with gonadotrophins. Now AMH is 2, antral follicle count 5 plus 7. Recent ultrasound shows bilateral endometriomas 1 into 1.5 on the left and 3 into 3 centimeters on the right. How would you manage her? Would the presence of the endometrioma affect IVF cycle results by impacting quality of oocytes, embryo, endometrium, and pregnancy rates? What is the evidence? And what impact can surgery have on outcome of IVF? How would you manage her?
Okay, because of the presence of endometriotic cells, I would definitely go for a long protocol and then go for IVF treatment for her.
Anybody will go for surgery? Let
No,
me
sir.
ask that question.
It's a recurrent second time surgery.
Recurrent.
It's a big no, sir.
Because bilateral, we don't need a surgery.
So between the surgery and IVF, it is an IVF definitely. And IVF, you could go in for a long protocol.
Yeah, this is a small endometrioma. Suppose it was a 5 centimeter endometrioma. Will you like to go for surgery or straightway IVF?
IVF.
Okay, so again, this is a fourth message coming from the panelist. In recurrent endometrioma, if your patient is looking for infertility treatment, please think 100 times before you put a laparoscope. Okay.
So what is the impact of this endometriosis on our IVF cycle? What have we found?
One is that it decreases the reserve as such, and there are chances of getting an equal number of eggs compared to another person with endometriosis is going to be less. Then the evidence for it is supposed to have like the inflammatory markers and in the granulosa cell, it should decrease the oocyte quality, but clinically it hasn't been seen to decrease the quality. It should have an impact on implantation considering that there is increased progesterone resistance and again those inflammatory markers. But again, the clinical evidence doesn't really go in favor of implantation decrease in it. And especially now of this GnRH being used and for FET cycles, there is more of literature showing that if you do the GnRH or using anti-inflammatory, it helps in the implantation. So for IVF, the GnRH works more that you do stimulate her without GnRH, take out her eggs, and then give her then give her 2 injections or 2 whatever you decide for GnRH to help for the endometrium, and then do a frozen embryo transfer. That's what's.
So are you doing that? Are you giving 2 GnRH analogs and then giving the ET frozen embryo transfer?
Yeah, that's it.
Is
The GnRH is helping at the endometrium level more than at the follicle level. And rather it's decreasing the chances of having a good follicle output.
Basically, the evidence has shown that although number of oocytes recovered is low, the pregnancy rate is similar with the disease or without the disease. So it really does not impact much. And what would the impact of the surgery be, or the previous surgery? How it would have impacted the cycle? Would there be
a cystectomy does not improve the chances in IVF outcomes? That is what is the recent evidence says.
Yeah.
So
they may require slightly higher dose of gonadotrophins.
The cycle outcome.
Yeah. So Padma, what have you noticed with your AMH levels after surgery?
I mean, it is expected to drop after post surgery in the case of an endometrioma, and consequently they may require higher than expected doses of gonadotrophins. And as you as you've highlighted, they may yield less number of oocytes, but the outcome doesn't seem to be affected by any of these factors of life.
And it's seen that bilateral, there is a further decrease of AMH is seen.
Yeah.
So this patient was taken up for IVF without surgery. What is the risk of not operating on the endometrioma, of taking it just as we have? And what is your preferred protocol? So 1 or 2 of us have said the protocol, but I'd like everybody to just highlight what is their protocol. Neeti, what do you people follow?
We usually go for antagonist protocol. We usually go for antagonist protocol and retrieve as many oocytes as possible, because that is the challenge in patients of endometriosis. And as Dr. Monica has said, in patients whom we feel, that suppose first transfer we can even do without giving a down regulation, but if she has failed in one transfer, we can think of, especially if there is a accompanying adenomyosis, we can think of giving a GnRH agonist depot 2 cycles and then think of doing a transfer. So segmentation approach in some patient, not in all, but we generally go for
usually do it in failed cycles. That's what you're saying.
Yeah, not as a first choice. Segmentation not as a first choice, but antagonists mostly we are doing. For
Lakshmi, what is your protocol?
Because of the CIS, I would definitely go for down regulation, long prolonged down regulation for 3 cycles and then start the stimulation. And I would transfer in the same cycle. I wouldn't wait for the frozen embryo transfer.
Damodar?
Same down regulation followed by stimulation.
Padma?
Yeah, I would purely go by the AMH levels, and if she has adequate ovarian reserve, I would go for long agonist protocol. Otherwise, I would go for antagonist protocol.
Monica's already answered that. So, what is the risk of not operating on this endometrioma?
Yeah,
So I think Surveen, there are 2 types of comments coming from our panelists, and that is very, very important. You have to individualize. You cannot just say that I am using long protocol, I am not using antagonist protocol, or I use FET only, because see, in these patients, if you go back to your paper, primary AMH is a deciding factor which protocol you are going to use, whether you are going to use a frozen embryo transfer, and of course that particular cycle. If you are having a very good endometrium, you are having 10 embryos, certainly you will use 3 embryos in that cycle, and 7 you will freeze for FET if patient doesn't conceive. So I think individualization is very, very important in all aspects of IVF, whether we are discussing endometriosis or poor ovarian reserve, or for that matter PCOS. So individualization is the key word in IVF nowadays.
And like Neeti said, that in failed cycles, they are going in for an agonist even before they do a frozen embryo transfer.
Yes, that is okay. That is okay.
You're doing it for all her cases, right, Monica? You're doing it for all your cases?
If we have enough good embryos, like if we have 3 embryos, then yes, we freeze them.
You freeze them and then go for a long
and then we give them 2 cycles of GnRH, 2 monthly doses, and then do a frozen embryo transfer. See, whatever the evidence we have, and it gives very good results. Like when we have compared donor oocytes with given to an endometriotic patient, the results have been good. So it's basically whenever a frozen embryo transfer and the progesterone resistance decreases if we give them estrogen and progesterone rather than a natural cycle or a stimulated cycle, that leads to more of an implantation problem, specifically in endometriosis. So if you have embryos, a good number of embryos, which you can freeze, if you just have 1 or 2 embryos, then of course the choice is not there. But if the embryo number is good, then GnRH in the cycle before transferring.
Okay, so what are the risks of leaving this endometrioma in and just going in for IVF? Lakshmi, would you like to answer that?
Yeah, it might come in the way, and the number of oocytes we retrieve might be less. And the other one is if we inadvertently puncture it, it may cause pelvic infection and abscess, which is very difficult to treat. So these are
How many
the 2
times
things.
have you punctured an endometrioma in your clinical
Yeah,
practice?
quite few times, I think, but never happened to have any pelvic abscess. That's what I think always.
Your case has very small endometriomas, Dr. Surveen, so
Yeah.
unlikely to get punctured. So we give pre-operative antibiotics to be, just for us.
And intraop also.
And intraoperatively, and after post-operatively also, we are giving in all cases of endometriosis, especially endometriomas who have, we give antibiotics for 3 days, oral antibiotics. One thing I just wanted to say here is that the recent studies have shown that antagonist protocol is as good as long protocol in endometriosis.
Yes.
Yeah. Okay, and if you do puncture, do you change the needle? Do you flush the needle? I'd like a take from everybody, starting with Neeti.
Yeah, if I puncture the follicle, I will take out the needle and I will just, flush it with a media and then take it in again. I will not, take another follicle in that needle. I will flush the follicle, not change the needle, but flush the needle with a media in.
Surveen, we are having 5 minutes, so should we continue discussion or we take one more case?
No, we'll take one more case.
Okay.
So this is just, I'll just cover this part. You might miss an occult malignancy, which is only when the tumor is high or the woman is older, and it may interfere with the responsiveness. Okay, coming to case 5. Over to you, sir.
Yeah. This is a young girl, 18-year-old, severe dysmenorrhea for 3 years, menstrual cycle regular. Ultrasound shows 1 into 1 centimeter endometrioma on left hand side. What is your diagnosis? How will you counsel her? And how will you manage? Very short answers, so we can have more discussion in 5 minutes. Very short answer. How will you counsel, Dr. Padma? How will you counsel this patient?
She's a young yeah, so she's an adolescent, symptomatic of dysmenorrhea and has a probable endometrioma. So we need to counsel her regarding the possibility of endometriosis and its impact short term and long term, and also symptomatic, how we should treat her symptoms. So because if it is, we should investigate further, confirm the diagnosis of endometrioma, and concentrate on counseling regarding symptom control, as it appears to be a very small endometrioma. So I would concentrate on managing her symptoms and preparing her mind.
How will you confirm the diagnosis?
In her case, I would, because she's very young and it's a small endometrioma, I would do an MRI to get further information and further affirmation of
So
diagnosis.
all this depends
So
probably
that,
on
we are
affordability.
very clear.
Also, sometimes you can just try a trial medical management and see, and if it
Yes,
settles with the medical
of course, that is
management
also
itself,
How
then
many?
you don't.
How many will go? How many will go for? How many will go for MRI in this case? Very important.
I would do, because she's very young and I need a definitive diagnosis so that I can
Whatever
counsel
it
her
is, I think
more,
you're finally you're going to come back to your medical management.
Yeah. So 1 into 1 centimeter endometrioma will not, bother me to do an MRI. 1 into 1 centimeter endometrioma.
No,
More important is that we can follow
There is a very small chance that there could be some peritoneal or deep infiltrative endometriosis, very, very rarely.
management. We can go on to medical management even without doing MRI.
Absolutely.
Because small endometrioma, she has severe dysmenorrhea. So there must be something more than that small endometrioma.
But your management is not going to change. That is what, management will
Absolutely.
remain same.
It is something I
There is
would
only one.
consider.
There is one reason why a MRI may help more is that these patients may be associated with some, anomaly in
Yes. I think that is very, very important. Why this patient is having so for MRI, when you are sending the patient to MRI, you should have in mind what all you are going to look into, and one is the uterine anomalies, which are very, very commonly associated with endometriosis. Second thing, of course, for the prognostication and for counseling. So that is the role of MRI in these patients. Otherwise, management will remain same. So next question is how you will manage. Anyone, one by one you can take. We are having very less time.
Trial of OC pills, sir.
OC
pills.
Okay. Anyone, any other drug, or all will start with OCP?
Dynogest.
Who will be giving Dynogest and who will be giving OCP?
If the patient can afford it, I would like to give Dynogest.
But Dynogest can have effect on the bone, so that is one thing which we need
studies
to
have been
look
there even for about 5 to 6 years. You can give it without any worries. There have been studies that have been done.
Especially in an adolescent girl where she won't want breakthrough bleeding in between, and OCPs have a very good role, and we are not even sure of the diagnosis as such. It could be a primary dysmenorrhea affecting in part of it.
Yeah.
So OCP is the best option for her, starting it with monthly, and if it decreases her pain or she still have it, we can make it a little prolonged cycle, 1.5 months, 2 months, giving her a breakthrough.
There is a paper which says that the
if she has not tried NSAIDs till now, why not try NSAIDs first? Why not give
But
her?
we
if
need to
she's not
suppress
tried
her
it.
progression of the disease also. We need to
I
suppress
think
the progression. NSAIDs will not help
confirm that it's
suppress
How
it.
long will you
endometriosis.
keep on giving it? No, how long will you keep on giving OC pills?
I think
It doesn't matter. We can give as
Think
long as
about the
they want.
trial. You know, like the
If,
question
if,
was whether
Damodar
we
is
would
trying to
like
say
to.
something.
if
Yes,
you
yes.
confirm that it's
Please,
endometriosis,
please, one by one, please, one by one.
yeah, can I?
Yes, yes, yes.
So if you've confirmed that it's endometriosis, I think we've decided that we're doing an MRI and we've confirmed that it's endometriosis.
Yeah.
There is a recent paper which says that if you give OCPs, even a small amount of estrogens present in OCPs can cause the progression of the disease. And this is probably one of the reasons for progression and formation of DIE. OCPs will only control the pain, but the disease will silently progress.
That's that's an opinion paper, and the evidence everywhere is OCP and Dynogest have equal effect, and then for the progression of the disease. If a patient, adolescent is not responding, then we switch over to progesterones in these cases.
To close this debate whether OCP or Dynogest, I think literature, there is a lot of literature now. OCP and as far as the efficacy is concerned, OCP and Dynogest, they are having equal efficacy. But when it comes to compliance is better with Dynogest. When it comes to the regular use, longer term, OCP can be taken, but the episodes of breakthrough bleeding are more with OCP, less with Dynogest. So these are some of the advantage of Dynogest. But you can very well give OCP for a very long time if the patient is compliant and there is no breakthrough bleeding. So I think that is the discussion as far as the pain is concerned. Last but not least, anyone will give GnRH analog in this patient? And if yes, then when?
Intractable pain.
Yes.
Intractable pain not resolving, and after 16 years of age. After
Yeah,
16
so
years of
she is
age.
already 18 years. She is already 18 years. So GnRH agonist is a better drug, but not a primary drug. If the patient is not responding to your OCP or Dynogest or having compliance issue, then one can give GnRH analog and then continue with Dynogest or OCP later on. So combining again reduces the chances of suppression, intense suppression. So 3 months instead of 6 months, you can give 3 months of GnRH agonist and then combine it with OCPs or anyone will give the cyclical here. Continuous or cyclical? OCP is continuous or cyclical?
Supposed to be continuous.
Initially it's a little prolonged cycle.
They say can give it for 3 months and then give a break.
Yeah, a little prolonged, continuous.
How much prolonged? How much prolonged?
It depends on the symptoms, how it's going, like a 2 months. You give it 2 months.
Are you expecting the relief of symptom in 2 months?
No.
It's a person to person. We really can't say. Each person is different.
Usually
Each
they say
patient
at
is
least about
different.
6 months is required to see some sort of.
Yeah. So I think again, I will differ here. When you have decided, you have made the diagnosis of endometriosis, it should be given for a prolonged period. If you want to have full effect of your drug. Otherwise, what will happen? The number of cycles in 1 year will be directly proportional to the progression of disease. So you should reduce the number of cycles in 1 year, and that's why it is to be given for a longer period, maybe not only 6 months, maybe depending on the symptom. If the initial symptom was intense, then you have to continue it for a very long period. Yeah. So last case, 1 minute, 27-year-old. Yes, Surbin.
Myoma, 14 weeks, uterus, AMH is normal, male factor normal, dysmenorrhea 5 years, infertility for 4 years.
1 minute only. 1 minute. Every person will.
How would you manage her?
Try and manage her conservatively rather than surgical management.
Yeah, adenomyosis, I would manage conservatively rather than surgical.
So what conservative management would you use, Damodar?
GnRH agonist and probably at the same time Mirena in situ.
Okay. She's infertile.
Yeah, and then take for the Mirena. Take for the minute. Wait for the size to come down. The Mirena can act as the add back progestin also with the GnRH. At least.
How long will you give the GnRH? How long? And how would you say your GnRH is working?
3 months, and then you repeat a scan and see if the size has come down.
So you are worried about the size, not about the infertility.
If the size comes down, then I think the infertility will improve.
I disagree. Anyone else?
I would definitely suggest IVF. Surgery can be done. It's an adenomyoma. We can remove the adenomyoma, and removal of adenomyoma does improve the outcomes in the infertility ART outcomes, because if it would have been diffuse adenomyosis, yes, surgery would have been difficult to reduce the size, but because you have mentioned adenomyoma, one can think of doing a conservative surgery, doing the adenomyoma resection.
Actually, this is a very important discussion, but unfortunately, we will have to close down because we have completed our time. But I will like to just highlight here, when the patient with adenomyosis comes and infertile, the primary aim remains the patient conceives faster. So expectant management out. You have to, depending on the size of the uterus and the tubal status and duration of what you call infertility, you will decide your management. Primary drug is GnRH agonist, whether you are going for IUI or IVF. So you have to combine, you have to suppress GnRH agonist, and most of the time these patients, they do land up in IVF and multiple IVF failures. And when your patient is failing IVF, in spite of giving GnRH agonist and other things, then surgery is the answer. So combining GnRH agonist, surgery and IVF is most of the time the treatment. But yes, surgery is not the primary treatment. GnRH agonist is not the only treatment. So you have to combine agonist along with some form of ART to give them better outcome. I think
give agonist for the first 3 months and see, and then
yeah. So I think I'm binding up this panel discussion. I thank everyone. My co-moderator Surveen, she has compiled it very nicely, and Dr. Lakshmi, Dr. Padma, Damodar, everyone has really given a very positive output as far as the endometriosis is concerned. Thank you very much. Thank you all.
Thank you.
Thank you very much.
Thank you.
I thank each and everyone, our moderators, panelists. It was an amazing panel discussion, plethora of knowledge, I must say. And so moving on to our next session, I would like to invite Dr. Sandeep.
Hello.
Over to you, Dr. Sandeep.
Good evening, everyone. After this interesting discussion, we move on to the next session. And for the chairpersons, I would like to invite Dr. Renu Mishra. She is Senior Consultant Obgyn Gynae and Head IVF Miracles Fertility IVF Center, Gurgaon, and Sitaram Bhatia Institute, Delhi. The second chairperson for the evening is Dr. Swati Verma. She is Senior Consultant IVF at Global IVF Center, Chandigarh. Evening is Dr. Ridham Ahuja. She is Consultant Reproductive Medicine and Surgery at Excel IVF Center and Fortis Hospital, Shalimar Bagh, Delhi. Welcome, chairpersons, and I would like you to start the session. Before we start, I would like to say that the question and answer sessions would be taken up after the talks of the three speakers. So, Dr. Renu Sharma, please invite the first speaker.
Thank you, Dr. Sandeep. It gives me great pleasure to invite and introduce Dr. Svetlana Dubrovina. She is Doctor of Medicine, working in the Department of Obgyn Gynae at Rostov State Medical University, Russia. She has 32 publications to her credit. And she is going to be speaking on endometriosis, personalized treatment, and the results of the Orchidia trial with dydrogesterone, which was an observational multi-center trial from Russia to evaluate the effect of dydrogesterone on endometriosis. Dr. Svetlana, the stage is all yours.
Yeah, thank you for your introduction. Hello, everybody. And I would like to start my presentation. Just a minute. Excuse me. I'm ready to start. And dear colleagues, before I start on my presentation, I would like to thank Congress Scientific Committee for inviting me to this Congress. And the aim of my presentation is the endometriosis personalized treatment. I would like to share with you the results of ORCID trial, which were performed in Russia. And before we start on my presentation, I would like to present myself. I am professor, medical doctor, philosophy doctor. I permanently have been working since 1992 in Rostov Scientific Research Institute of Obstetrics and Pediatrics, and in my clinic we pay a lot of attention just to patients with endometriosis. And as you know, the prevalence of endometriosis reached an unprecedented date, and in Russia we have more than 3 million women among the all reproductive women age. And is endometriosis more common and more severe than 30 years ago? We now arise this question in our mind, but we don't have any answer because we cannot compare two different clinics. Because in my clinic, we have a lot of endometriosis because we are not in first aid clinic, but the clinic of special help for the patient with infertility and endometriosis. And at the same time, in clinic with first aid, we could not expect a lot of patients with endometriosis. So we just I don't know now is it endometriosis more often or not. Anyway, pain is the most common symptom of endometriosis. At the same time, we expect among our patients also infertility. And treatment for endometriosis are not curative and may cause detrimental side effects. And at the same time, we have a big problem that not all treatment are appropriate for patients seeking treatment who has infertility and pain at the same time. So if we treat pain, we could not expect the health pregnancy, because a lot of drugs inhibit the ovulation. And among all estrogens, the dydrogesterone could be one of the most useful because it's useful in inhibit the pain, and at the same time it could be useful regarding the pregnancy. And this aim has also Neil Jones, the president of World International Society of Endometriosis, and he published at the beginning of this year with his offers that his opinion that using of dydrogesterone could improve the pregnancy rate among women with endometriosis associated pain. You know that endometriosis is impossible to cure, and when we stop the treatment, we could expect the recurrence, and the recurrence could be during the in one half cases, in each second cases after the surgery during the first 2 years after the first surgery. And we have two aims of the treatment of endometriosis: conservative treatment and symptomatic endometriosis cases as empirical treatment, and adjuvant treatment to prepare the patients for surgery and to suppress the chance of a recurrence after surgery. And at the same time, we have two clusters. One very expensive cluster, the cluster of very expensive drugs, including dienogest and agonist gonadotropin-releasing hormones, and at the same time quite cheap drugs as combined oral contraceptive and gestogens, cheap gestogens. So we should consider, regarding the opinion of Paola Vercellini, the low-dose contraceptive and low-cost progestagens as a first-line therapy. But at the same same time, combined oral contraceptive now is considered not as quite suitable for the treatment of endometriosis. First, this question was raised by Robert Kasper 3 years ago and created a lot of discussion around this question, because the combined oral contraceptive are associated with elevated risk of endometriosis, especially deep infiltrative endometriosis. They could be used among women with dysmenorrhea, but at the same time, it could lead to the development of endometriosis. And to treat endometriosis quite effectively, now we understand it's not, we don't need to suppress the ovulation, because according to the opinion of Santulli, the prevalences of oligonovulation among women with endometriosis is without endometriosis is the same. Until now, we don't have any kind of quite good examination of investigation of combined oral contraceptive efficacy in endometriosis. We don't have enough evidence for it. And where we are really badly the future therapy, but for us, for Russia, is now a nowadays therapy. This therapy should not inhibit ovulation. So we find the solution, and this solution is lies in dydrogesterone, because it could suppress their pain, but at the same time it could be quite useful for their treatment infertility among women with endometriosis. And if we compare the most widely useful use gestogens, we can find that the side effects, the dydrogesterone has the less side effects in comparison with non-testosterone acetate and the Dynagest. And because of a lot of side effects of Dynagest, sometimes and even quite often women usually stop to use the Dynagest and switch to another therapy. Moreover, dydrogesterone has no effect on hemostasis. That's why it is a good option among women who could face risk of thrombosis. It also, the efficacy of the dydrogesterone was proved in many investigations long time ago, maybe more than 10 years ago. I will very quickly show you the results of this investigation, which shows us the efficacy and at the same time safety of dydrogesterone. But all these investigations were performed quite a lot ago, and not a lot of women were involved in this investigation. But only one did not find us the efficacy of dydrogesterone in suppression of pain. It was in the work of Overton, which came from the 1994, but it was quoted in the Cochrane Laboratories, Cochrane Library, and the authors of this analysis stress that this work of Overton had the wide confidence interval that should not be interpreted with caution, and that's why the Overton his result could not be quite proved. And the last, only one nowadays work regarding the efficacy of endometriosis came from the Professor Liang from Hong Kong. He quite on a good level, incredible level, shows us that effect of dydrogesterone has the same effect in comparison with Dynagest. But he performed his investigation among mice. So we decided to make do this investigation in Russia, and I would like to switch to results just of this multicenter study of dydrogesterone. We named this study as ORCID appropriate study. And before us, we check the literature, scientific literature, mostly in English, and there were 17 clinical trials regarding the efficacy of dydrogesterone among women with endometriosis. Moreover, dydrogesterone is approved in over 100 countries, and we involved a lot of scientific centers, 38 scientific centers in Russia, which are located in 20 cities of Russia. You can see on these slides of a study of geography. And we involved 330 persons, so the really huge investigation. And we check them, they visit us 3 times, first and after 3 months of treatment, and after 6 months of treatment. Primary objective was assess of effects of dydrogesterone therapy on severity of pain, but we also try to achieve a secondary objective, quality of life, duration of menstruation, symptoms of dysmenorrhea, severity of chronic pelvic pain, effect of sexuality, and pregnancy rate. Because we explain the patient that dose which we use, 20 or 30 doses of milligrams, could not suppress the ovulation. So we explain our the patients that they could expect the pregnancy during the treatment. If they don't mind, they will not use their contraception. They would not use contraception, another kind of contraception, example, mechanical contraception. And we involve women age 18 to 39, and the main rule was that they all have their surgery operation, and during this surgery we check that all our patients had their endometriosis, external genital endometriosis. And what we found out, that we really found after the 6 months of therapy, that dydrogesterone could suppress in high level the pain, and it was our primary endpoint. At the same time, we compare the prolonged and continuous regime, and we found the same results. That's why you should you could prefer continuous or prolonged cycle regime, and it could be dependent on your opinion, your preference. And so we also check the severity of chronic pelvic pain, dysmenorrhea, as sexual well-being, and we found the same result when we use the 20 milligrams per day or 30 milligrams per day. Our patient during the treatment less and less used the analgesic, and aiming at to suppress the pain and improve. Regarding the improvement of quality of life during the therapy, you can see the same results after the at most after our third visits of among our patients, and we compare their prolonged and cycle regime and found the same results regarding the quality of life. And also we compare the different stage of endometriosis, because they involved the patient from the 1 to 4th stage, and we find also the same good results. And the last question which we raise, we try to compare the quality of life in different age, in early reproductive age and late reproductive age, and we also did not find any kind of difference in comparison of 2 different groups. At the end, we check the side effects of dydrogesterone and find only in 11% of mild side effects. So if I compare the efficacy, safety, and adverse event of dydrogesterone therapy among women with endometriosis, we can see that we have a special good drug which started to use long time ago, but at the same time we for a long time forgot about these drugs, and now we rethink about this drug, and we decided that it has a good efficacy, at the same time good safety and less adverse effect. And the second point on our investigation, and the last second point, was the pregnancy rates. And we had during our investigation the ongoing pregnancy among in 2 women, and delivery after the end of investigation on 1 woman. So in summary, I would like to stress that endometriosis is chronic condition, and so it required long time, maybe during the whole life. Adgestogens is considered now widely in countries as first-line drugs, and dydrogesterone is a gestogen which could be very useful because of its efficacy and safety and not a lot of side effects. ORCID Russian study is a large multi-center clinical study which also proved the results which performed before us, but not involve a lot of patients like in our study. And also we can consider a dydrogesterone as quite effective during the second second phase of menstrual cycle, because it could support their pregnancy. And also we can continue to use dydrogesterone if our patient get pregnancy, and it could be very useful during the pregnancy. And at the end of my presentation, I would like to quote the words of Sidney Burwell. He said it a long time ago, but it's very useful, just it supports our opinion regarding the thinking of dydrogesterone in the field of treatment of endometriosis. Half of what you are taught as a medical students will in 10 years have been shown to be wrong, but the trouble is none of our teachers know which half. Thank you for your attention.
Thank you, Dr. Svetlana, for introducing dydrogesterone for endometriosis, which we have used for many other indications, but yet not a standard of care for endometriosis. So please stay on, because the questions we will be taking at the end. I hand over to the next chairperson. Thank you.
Yeah, thank you. Thank you. I will online. Thank you.
Good evening, everybody. So moving on to the next speaker, Dr. Sergio Haimovic, Head of Hysteroscopic Unit Del Mar University Hospital, Barcelona, Director of International School of Laser in Gynecology, Spain, and Chairman of Global Congress in Hysteroscopy. I welcome you, sir, and looking forward to hear from you about the role of myoma in IVF in hysteroscopy. So please.
Thank you very much. Good evening. First of all, I would like to thank the Indian Fertility Society for this kind invitation for their first virtual Congress. It's an honor to be here with you. The topic you asked me to talk about, and I will share now, it's about the role of myoma in fertility. Okay, I have it now. First, I want to declare that I do not have any conflict of interest regarding this presentation. Regarding the fibroids, we know some facts, and we know that there is a role in IVF, in fertility, both for achieving a pregnancy and for maintaining a pregnancy. So when we check all the evidence published, and we look especially for the systematic reviews of the meta-analysis, we know for certain some facts about the fibroids, and that's what I want to summarize here, what we really know based on the evidence. So we know some facts. First, subserosal fibroids do not appear to have an impact on fertility. Those who grow outside the uterus, they don't have any influence on the fertility. Regarding submucosal fibroids, we know that they show on all the papers, except one I will refer later, that they have a negative impact in implantation, clinical pregnancies, etc. But we have another kind of fibroid, is the intramural fibroid, and this is the big controversial fact here. We what's the real role of the intramural myomas, because we know the two facts that just explained. Subserosal, no, they don't affect green light. Submucosal affect red light regarding IVF. But what about the intramural? So there's another a lot of evidence regarding them, but nothing clear. So after checking everything, I can tell you that there are two facts. One, that any fiber intramural that make a distortion of the cavity, they compress the wall of the cavity, they have certain effect on fertility. Second, when you have myomas that are 4 or more centimeters inside the uterine wall, they may affect, this is based on the evidence, they may affect the fertility. So whenever we find fibers that they are more than 4 centimeters, we should advise the patient that, that there is some evidence that removing them will increase their probability of becoming pregnant. That's are the facts. And I say that I will refer to one paper that shows that it's not like this. And this was published this last year in the Cochrane Library, that there is no, it's written here, there is a limited evidence to determine the role of myomectomy for fertility in women. And it is based only in one paper. And why? Because there aren't any randomized papers regarding fibroids with fertility. When we see a submucosal fibroid, we cannot tell the woman, you are going to go to the control group, we are not going to do anything. It's not ethical. And that's why we don't have any evidence showing really that it's positive for the patient. But from what we have and from our experience, and I work closely with my IVF unit in my hospital, and my area of expertise is reproductive surgery. We know that the moment we take out those fibers I mentioned before, we increase the rate of success in those women. But when we talk about fibroids and about techniques regarding fertility, not all the techniques are the same. So I want to make an approach to myoma and explain that there is a myoma, it's not simply a myoma, there is also some plane around the myoma. It's called the pseudocapsule. It's between the myoma and the myometrium. The pseudocapsule is an entity by itself. There is a lot of connective tissue bridges over there, very lax, very easy to dissect, but altogether they anchor the myoma to the wall. In this area also we can see small blood vessels that they give the blood supply to the myoma. When we perform a color Doppler, we can see it's described as the ring of fire surrounding the myoma, all these small black blood vessels. So this pseudocapsule is essential for the dissection of the myoma. And whenever we see an open myomectomy, and you can see it here in the video, it's an open myomectomy, we look for this cleavage plane, and we performed the dissection. The same laparoscopy, we just performed the dissection, finding the dissection plane, the pseudocapsule, and we take the whole myoma. And we don't damage the myometrium. And we try all the time to minimize our damage on the myometrium. But as you know, in hysteroscopy, the technique that it's most used, and it's still the gold standard in most of the countries of the world, is the resection of the myoma. They use a small loop with monopolar or bipolar energy, and they take chips of the myoma until they resect the myoma. This resectoscope, it's something we got from urology in 1976. And no changes seen there, no evolution. It remained the same. We just passed from monopolar to bipolar energy, but the device is just the same. And the thing is that we use energy, and when we cut, we might damage the myometrium and create myometrial scars. Something that we don't do during open myomectomy, even laparoscopic myomectomy or robotic myomectomy. So for hysteroscopy approach, reaching the pseudocapsule is what you see here between the myoma and in this case on the endometrium. This pseudocapsule is basic because we can dissect dissect and free the myoma without creating any kind of damage. And when you perform hysteroscopy, that's how you see this Kliblets plane. It's at down in the lower part, you see the myoma, and we are now between the myoma. Myoma is in the right side, left side, the myometrium, and we go with a small grasper, is 1.5 millimeters, and we just dissect, the same like in laparoscopy. We dissect and we alleviate, enucleate the fibroid, the myoma. And look how lax are these fibers and how easy they are to dissect when you find the right Kliblets plane. The same like in the open when we do it with our finger. And then you alleviate the myoma without damaging the myometrium. And it's important for fertility. When we treat myomas in hysteroscopy, we treat these three kind of type of myoma. G0, grade 0, it means that the whole myoma 100% is inside the cavity, and only there is a pedicle that connects the myoma to the uterine wall. Type 2, most of it is inside the cavity, and only a small part, less than 50%, is inside the wall. And type 2, most of the myoma is still intramural, and just a small part, less than 50%, is inside the cavity. These are the three types of fibers we treat by hysteroscopy. So we have different approach. One is the tissue removal systems. You know, they were talking a lot about the tissue removal systems in the last years. And when we talk about tissue removal systems, it's the morcellators, but don't make the mistake to think about morcellation inside the abdominal cavity. That we know there is a lot of polemic, a lot of controversy about this thing, and the FDA they don't recommend in the abdominal cavity. And a very different thing is to do it inside the uterine cavity, a closed cavity. So we can use this kind of tissue removal systems to remove the myomas, but the myomas that are inside the cavity, as you see here. So these systems, you just put them touching the myoma. They have a small window, and there is a suction system, and they suck and cut until they remove the myoma. It's very easy. The learning curve is very easy also, and you can remove very fast small myomas. But again, we're dealing with myomas that are inside the cavity. There are limitations, and this is from the same device you saw before, the MyoSure. This is the brochure published by the company, and you can see that for myomas that they are type 2, most of them intramural, they only succeed to remove 50% of the tissue. So these systems are very good for the myomas that are inside the cavity, but they are not good for the myomas that are still inside the wall. Then we have different kind of approach. It's the same. The one is the mini receptoscope. We talk about the big receptoscope, and now we have for office approach, the mini receptoscope. As you are going to see now, this is a loop with bipolar energy, and it removes chips of the tissue. Chips and chips and chips. In this case, they find the myoma, but this doctor, Dr. Ferro from IVI Valencia, he is a very expert surgeon, and he goes and he tries to find the Kliblets plane. You are going to see it now. He's removing all the time the tissue. You see, this is down in the back part. He's removing the myoma from the wall, because he doesn't want to damage the wall. He doesn't want to damage the myometrium to avoid myometrial scars and to avoid adhesions. That's why he's all the time pulling the myoma and performing the cutting when the myoma is far from the wall until he removes all the myoma. The same in a resectoscopy that we know from operating room. This one is just a small one for office procedures. And we have different approaches. This approach was published by Ivan Mazzon from Italy. It's very interesting. Ivan Mazzon, he understood the pseudocapsule. He understood the importance of the enucleation of the myoma. So what he did, he performed it using two different tools. He said, okay, let's use the resectoscope as we know it, taking chips, just for the part of the myoma that's inside the cavity until it's flat. And then I have the remaining second part of the myoma that it is still inside the wall. So for that, he designed these tools, no energy use. It's called, the name of it is the cold loop. And with these very robust tools, what he did is to remove, we're going to see it later in the video, to remove the myoma from the wall without damaging, no energy, no damage to the wall, no damage to the myometrium. Inspired on that, Stefano Bettocchi, he published this OPIUM technique. OPIUM stands for Office Preparation for Partially Intramural Myomas. What he did in the first step, he performed in office. Office, it means without anesthesia, outside the operating room. He cut with the bipolar energy with the Versa point, a crown around the myoma, limiting the myoma. And what he saw is that the myoma has behavior, natural behavior, it was to migrate into the cavity. So this myoma that was inside the wall started in the same step, in the same setup to move to the cavity. And what he did, he sent those fibroids to a second step in operating room to do the resection. So a G2 myoma that was inside the wall became a G1, and then he was resected in operating room by the same resectoscope we talk about. And his paper was published with fibroids with a mean size of 29 millimeters. It's not small, and the success rate was high, 93%. In spite of that, in our hospital in Barcelona, we thought, why not to perform two steps in office, outside operating room? And we started to do that. We opened the myoma and started to do the enucleation, going through the dissection plane, the pseudocapsule, and we just enucleated the myoma just the same as in open myomectomy or laparoscopy myomectomy. And we saw that for myomas until 80 millimeters, 100% success. Myomas between 19 and 30 millimeters, we succeed in 85% of the cases. But myoma that there were 3 or more centimeters, 0 success. And the reason of that is very logical. Why? Why it happened like that? Why myoma from more than 3 centimeters was impossible? Because whenever the room is smaller than the myoma, the cavity is smaller than the myoma, you cannot put it inside the myoma, you cannot enucleate. So, and I can come to another thing that we have to take into account. Remember that all the classification systems, like this one here, or the STEP W from Ricardo Lasmar from Brazil, they all are based on the myoma characteristics, how big it is, how deep inside the wall, in which wall. All of them are myoma characteristics. And I believe that there is another factor, and we started to talk about it years ago. The ratio factor is the relation between the container and the content. Look at these two uterus. One is a multiparous uterus and the second a nulliparous uterus, but the fibroid inside is the same size, even that it looks smaller in the big uterus. The size of the fibroid is the same, but it's much more easier to do surgery, to perform surgery in a big cavity because we have more space. Technically, it's easier. So we have to take into account not only the myoma, but also where it's the place we are walking in, the cavity. It's very important. And there is this is a graph published by Mark-Hans Emanuel, is from Holland, some years ago, and he showed us the relation between the size of the myoma and resection time. And look how for 3 centimeters myoma, we need 30 minutes. It's logical, it's not much, but when we increase from 3 centimeters to 4 centimeters, just 1 centimeter more, instead of 30 minutes, we need 70 minutes. So increasing 1 centimeter in the myoma diameter, it multiplies per 2 surgery time. So this brings us to another point, that reducing the size of the myoma, it will increase the success rate and it will reduce operating room time. What about G0 myoma? Those myoma that they are only connected to the wall by a pedicle. So we show, and this last paper, one was published 5 years ago in the Hospital del Mar, but this last one was published 2 weeks ago in the European Journal, and the first signer is Tanbir from your country. We performed a multi-center study in 9 centers, cutting the pedicle and leaving the myoma free inside the cavity. We don't need to remove the tissue. So what we saw in the first study, in the second study, that the moment you cut the pedicle or you release the myoma inside the cavity, you can leave it free there. Always take some sample for histology, but when you leave it there, it disappears. There is a necrosis of the myoma, no more blood supply, and with demonstration, it disappeared. In the first study, in the follow-up, after 2 months, 100% of the myoma weren't there. In the second study, in the non-centers, we did it until 90 days, but most of them were disappeared before. Some of them, I can tell you from my practice, when we release just small myomas, remember that I work with a 4 millimeters optic in office hysteroscopy, and 1.5 centimeter myoma, it's big for taking it out. It's small in the cavity, but it's big. But when it's a small myoma, when the patient stands up again and she goes to change their clothes and to dress, and sometimes she tells, oh, something fell down, and there's the small myoma falling from the uterus after the collapse of the cavity. So we don't need to spend time taking small chips outside from the uterus. You can leave it there inside in a safe way without being afraid, because there are no complications, no pain, no infections, no bleeding. So what are the advantages of preserving the pseudocapsule? Look, all of them are for reproduction. Preserving the myometrium integrity is very important because we reduce the thermal injury of the myometrium. And we prevent myometrium scars, and we prevent adhesions. So we all, from the last year, are saying that any technique you use, if you patients and you want your patients to preserve fertility, you must preserve the pseudocapsule. That should be your first choice technique during surgery. Now I'm going to show you that the idea of the enucleating the myoma, it's not new. I thought we were just very original about it, but I found this book. It was in Spanish, like translated from French, from 1894, 125 years ago. And when I went to see the surgery of the myoma of the cavity, I saw that what they did with sponges the dilation of the cervix, and when they went in with 1 or 2 fingers, they touched the myoma, and they introduced a small scalpel and cut around the myoma, and with the fingers they enucleated the myoma. So that's quite the same that we are doing today, but we are doing not with our nail or our finger, we're doing it with our devices. And I want to show you now, this is the last thing, a video that summarizes all the techniques we saw. The first technique is Ivan Mazon. He performed a resectoscopy of the part inside cavity. And then this is the cold tool, called loop tool, this robust tool for the enucleation. And he performed an enucleation preserving the myometrium without damaging the myometrium. And that is very important. He has a lot of experience. He published more than 1,400 myomas, no adhesions, no complications. This technique now, it's our technique. It's performed in office without anesthesia. Look, this myoma is very flat. It's inside the wall almost completely. It's very small, but it's a G2 myoma. And we cut here with the scissors, small scissors. This is the myoma you should start with. And we go and try to find this cleavage plane, this dissection plane, the pseudocapsule. Look, this is the plane between the myometrium and the myoma. And this thing that was flat, it's becoming a small ball inside the cavity. It's almost free. And then with the grasper, we just finish releasing it easily. This next video is quite the same, but for a bigger myoma, you can do the same, cutting with the scissor, go for finding the pseudocapsule plane, do the dissection. Look how the myoma is moving inside this pseudocapsule, because all the fibers there are very lax, connective tissue. And slowly it becomes endocavitarian myoma. We are trying to make the luxation of the myoma. And in a moment, you're going to see the myoma just inside the cavity. Look, this is the luxation of the myoma, and you're going to see the fovea where the myoma was placed in. This is the fovea, the myometrium pink, without any scar, without any damage. And this is the technique or the enucleation of the myoma. This one is performed with laser. We work with laser. Laser cuts and coagulates with no far away damage. It's a dispersion of heat 0.5 to 1 millimeter. Look how it coagulates the blood vessels at the same time it cuts. So we do the same. And then we go to find this dissection plane. Look how fast it is the moment you have the plane. It's very easy to do the dissection with a small grasper. And this is a 1.5 centimeter myoma, and fast you do dissection. The same with the mineral stethoscope. They designed these cold loop tools for the mineral stethoscope to do the enucleation. As you can see, the main technique today, the first choice should be the enucleation, and all the techniques are based on using the tools for doing the enucleation and preserving the pseudocapsule. The thing is, this phobia you see behind, you must remember that we are dealing with very elastic fibers, myometrial fibers that are compressed. The moment the compression disappears, there is a contraction of the fibers, and very fast the wall becomes normal without any difference with the surrounding wall. So I wish you never stop learning, and I thank you very much for your attention.
Thank you, Dr. Sergio. That was really very informative and systematic detail of hysteroscopic myomectomy. So now I request Dr. Rhythm to invite our next speaker.
I would like to invite our next speaker for the day, Dr. Bala Bhagwat. He is Professor Obstetrics and Gynecology, Medical Director at Generations Fertility Care, Wisconsin Medicine, USA. And he'll be talking about handling the nuances of myoma by laparoscopy. Welcome, Dr. Bala Bhagwat.
Thank you so much. I really appreciate that introduction. Let me share my screen. Here it is. Okay, am I sharing it? Probably not. Okay, let me go back. Sorry about that. Let me try to find the right, there you go. Okay, can you see the title slide?
Yes, sir, it is visible.
Put it on. First of all, let me thank the organizers for inviting me to be part of this Congress, virtual for the first time. It's always a pleasure to be at the Fertivision. I always learn so much, and much more international panel than I ever see in other Congresses. So I appreciate that invitation every time. Let's see. Okay. So the topic was nuances of myomas and infertility and how and when to tackle at laparoscopy. I think Dr. Haimovich has beautifully laid out the basis for me, so I don't have to go deeper into it. With submucosal myomas, it is clear that we need to tackle them, and with intramural myomas, it's a little bit controversial. ASRM and other and Cochrane databases as well have really highlighted that that the evidence is very poor. And as he pointed out, I don't know if we ever are going to have an evidence-based approach to this problem. But we all, I think, in practice, know and agree that when fibroids get to a certain size, either 4 or 5, whatever we feel is appropriate, we decide to tackle them. And certainly submucosal myomas, even submucosal myomas, as you pointed out, the moment it moves from 3 to 4 centimeters, 4 to 5 centimeters, it becomes really hard and prolonged surgery to tackle it hysteroscopically. So one may choose to do take that out laparoscopically. I wanted to divide the talk into, even though it's about nuances at laparoscopy, I think all the battle is half won when you plan it appropriately. And so the nuances start preoperatively in the proper selection of cases and the selection of your approach to the same problem depending upon the nuances. Followed by positioning very quickly, port placement, minimizing blood loss, which is the biggest thing, and the plane that Dr. Haimovich talked about as well. So important, cannot emphasize enough about that. Time and again, I see people floundering because they are not in the right plane. And then suturing, which is the biggest thing when we talk about laparoscopic approach, and then tracking the fibroids as we remove them. And now, of course, since the 2014 controversy, mosylation and how to take those fibers out. And finally, postoperative planning. This is an age-old puzzle. Many people still, when I present this, don't know how to solve it. The puzzle is, or the challenge is, to connect all the 9 dots with 4 straight lines without taking your hand off the paper. And interestingly, many people find it difficult to solve the problem. And the reason is they do not think outside the box. The box being the 9 dots, and when you're looking at the 9 dots, you think that you have to confine yourself within those 9 dots, the little square or box that mentally we visualize. But all the space outside those 9 dots are there, and you can utilize that. And if when you do that, you can connect those 9 dots with just 4 straight lines without taking your hand off the paper. So thinking outside the box is true for the laparoscopic approach to myomectomy as well, just as it is with hysteroscopy. As Sergio demonstrated very beautifully, there are so many different approaches, and the importance is to understand the principle and stick to the principle. One of my former colleagues, when I was at Brown University, as I walked into the OR suite, there is a central corridor where all the scrub stations are, and the ORs were on either side. Famously announced as I walked into the OR with my residents and fellows, that, here's Dr. Bhagwat, the one-trick pony, because I was doing a lot of myomectomies. And so, and my response to him was, absolutely, Richard, same trick, but different pony each time. And that's the importance of it, is that we do have, every case is different. And even though it is myomectomy, you have to think carefully about the approach, and planning is really, really, really important. If you have good ultrasound images and you know exactly how many fibroids there are and position, that is okay. I would go with those images. But very often I deal with multiple fibroids. Most of the myomectomies I do are at the level of the umbilicus. And so an MRI is very helpful, even though expensive. It's very helpful to carefully plan, and sometimes actually decide that a laparoscopic approach is not feasible and that you have to go for a old-fashioned laparotomy. And for example, in this particular case, looking at it, you can see it's a fundal fibroid, but you can't really see the cavity very well. And I would plan on not having a manipulator in at least the beginning part of the case until I get that big myoma out. And then midway between during the surgery, I would actually go in and try to put the manipulator in to help me with the suturing. So that's, again, preoperative planning, deciding and knowing what you can and cannot accomplish. If you look at the smaller fibroid, most likely I would be able to identify it, especially after removing the bigger fibroid. But sometimes as the large fibroid is taken out, suddenly the myometrium sort of coalesces around, and this fibroid that looks fairly subserosal can disappear into the myometrium. And having an intraoperative laparoscopic probe, ultrasound probe, laparoscopic ultrasound probe would be very helpful to identify that fibroid and remove that as well. And positioning is very important. Interestingly, even though the vast majority would use a lithotomy position, I've had people try to do laparoscopic myomectomy in the supine position. To me, it's really important to have that manipulator in place. It does give you greater ease of movement, accessibility, and more importantly, especially during suturing, allow you to have the right angle to approach. Port placement is very important as well. Again, the novices tend to stick with the same old formula of having the camera port sited at the umbilicus and having the lateral ports, and then having suprapubic ports, and then try to struggle during surgery. So this is really artificial. We are true for the most part. We could accomplish most of our pelvic surgeries with those port placements, but it is important to change that. So I go anywhere. I very frequently cite my camera port at the subxiphoid area, almost at the xiphoid, to be honest. If the fibroid is a little bit above the umbilicus, my dictum is I need at least 5 centimeters above the fundus for the camera port in order to have reasonable visualization. And then I would automatically move the assistant ports to towards the causal margin as well. So you don't always have to have the assistant port between the camera port, and if you're using robot, you can move the assistant port to different sides. I personally do it with a subumbilical inverted omega incision. I'll show a small video when we come to oscillation as to how that works. That way it allows me to have 3 8mm ports if I'm using the robot, or smaller ports, and then the subumbilical port is a single port configuration that I use that allows me to oscillate afterwards. But I also use the suprapubic incision. The reason I avoid that, even though cosmetically it's very nice, is because the assistant has to operate against the camera, which is a real problem. And can delay surgery, especially if the assistant is not very comfortable with operating against the camera, which many of us are not anyway. So I try to avoid that. But yesterday I did a 10 centimeter adenomyomectomy, which on MRI was not very clear. The signal intensity was very indicative of the fact that it is probably adenomyosis, but the usual blurring of the junction zone that you see was not present. So it was possible that it was adenomyosis. There were other indications. The ovaries were behind the uterus. They appear to be stuck. So again, there was a possibility it was a endometriosis associated with the adenomyosis. So I was mentally prepared. And although I do not like to use the suprapubic incision, I made a 6 centimeter suprapubic incision as I approached it. And sure enough, it turned out to be adenomyoma, no plane. We dissected almost 3/4 of it out using the robot. And then I went over, undocked the robot, used the suprapubic incision to complete the adenomyomectomy and close it right there, and then tackle the endometriosis, which was very posterior and had obliterated the cul-de-sac. So I could complete the excision of all the endometriosis and treat the patient appropriately. So again, planning, so important. If I had used the subumbilical incision that's normed for me, I would have been really stuck, because either I had to open up, do one more incision. So it would have definitely affected the flow of the surgery, in addition to giving the patient unnecessarily more scars. This is a single port configuration. There are so many of them around. Anything that is appropriate and available in your OR suite you can use. I'm not wed to a particular model. We'll move on to minimizing the blood loss, which is the most important critical part of the surgery. There is excellent evidence that misoprostol tablets placed intravaginally 400 micrograms an hour before surgery is very helpful. I use that in addition to the use of vasopressin. I know that many of the countries do not allow that. I use a very dilute 20 units in 200 mils of normal saline, but I have heard of people using it as dilute as 20 units and 500 cc's of normal saline as well. I totally do believe that it works. It gives you about 10 to 15 minutes of lead time, that's all, and then the effect wears off. So you have to be cognizant of that. But even 10 to 15 minutes is a good lead time to minimize blood loss. I rarely have patients who need blood transfusion. My average blood loss is about 50 cc's for most of my surgeries. So, and I do attribute that to the combination of these medications. One has to be aware of the side effects of bradycardia, cardiovascular collapse, and death, which have all been reported. So definitely it's important to make sure that you're not intravascular. I've heard of surgeons using it after starting the myomectomy when the effect wears off, and they apparently inject more. I'm very leery of that. Now the vessels are all open. When I inject, I make sure that it is in a pseudocapsule. It is, if anybody has done anesthesia, I did anesthesia for a year before I became OBGYN. If you've ever done an epidural, the concept is very easy to understand. You go in and then you start applying pressure with the syringe. And when you lose the pressure as you're withdrawing the needle, you are in the right place, the epidural space, and you insert the catheter or inject the lidocaine. So similarly here, you go in and then you start withdrawing as you inject. Keep a steady pressure on the syringe, and when you're in the pseudocapsule, you will be able to inject the full volume. I would inject even 60 cc's depending upon the size of the fibroid. And I've also seen people inject along the line of the incision. So this is not like injecting or incising the skin and injecting local in the skin. This is really, the concept is to spread it in the pseudocapsular plane. And if you're in the right plane, you need to inject it only one spot. The whole volume will just spread out and you can see the whole fibroid blanching. So that's another trick that's very, very important to adhere to. People have looked at many different other techniques, tourniquets, bulldog clamps, and in the very few cases I wish I had blocked the uterine artery, I can tell you I would not have been able to do it. I would have taken a long time to gain access when the fibroids are so big and the uterus is really hard to manage. So I am personally not a big fan of these techniques. And looking at the Cochrane review, the evidence is really for misoprostol. Even for the vasopressin, there is really nothing because there's only one study, unfortunately. And again, as Sergio pointed out, some of these things you just can't do the studies. So we do not have the study for vasopressin except for the 1994 study. So that's not even included in the Cochrane review. But as you can see, the low quality evidence for all the other techniques and no evidence for temporary clipping of the uterine artery, even though there are quite a few studies that have come out, but they do not make the cut to be included as of great evidence. And more importantly than anything else is the plane that Sergio talked about, to be in that appropriate plane. If you're not in the plane, then you're going to have bleeding. This is perfect. This is a little bit okay. You can see those pink fibers. They're not in the exact plane. And here is the worst case where there's so much blood. If you're seeing a myomectomy like this one, that is not at all good technique. And I would advise that surgeon to keep cutting into the myoma. It's okay, the myoma is going to be discarded anyway. You can keep cutting into it until you are sure. And even if you go, the only time cutting into the myoma is a problem is if it's degenerated. Then cutting off that little capsule that's surrounding it will make it just come out, and it can be quite messy trying to apply traction to try and get the fibroid out. But otherwise, in general, cutting into the fibroid is okay. It allows you to find the right plane. Another criticism about this particular image is the vertical incision that was made. I always make a transverse incision, whether it is laparoscopic or robot assisted, because closing a vertical incision can be really challenging. If I have to, then I would do an oblique incision and try to position the uterus during surgery so that it's as transverse as possible, because your suturing abilities are so much better than to have attempting the closure of a vertical incision. Finally, suturing, that is a perfect segue. Oh gosh, I wish I had Bob suture ever in my life. Around 2008-9, I discovered Bob suture, and I have been using Bob suture since that time. It is more expensive, I admit, but it saves so much over time. It is actually a time saving for the patient, in addition to the fact that you lose less blood. So I almost exclusively use Bob suture. I have been using Bob suture for closure for the last 12 years. and I would highly recommend the use of that. And finally, keeping track. I can tell you in 2009-10, I famously lost a 5-centimeter fibroid between the diaphragm and the liver. I was not keeping track at that time. I would just take it out. We would just know how many fibroids we had, but I wouldn't string them up. And what happened was this particular fibroid just disappeared. It was embarrassing to call the colorectal surgeon to come and help run the bowel for me because I couldn't find it. He couldn't find it, and finally found it between the liver and the diaphragm, which was terrible. And since that time, I make sure that not only do I keep track of how many fibers we're taking out, but I actually string it up with a single suture with the needle inside the abdomen. I safely tuck it away. I actually put the needle, I bury the needle tip inside the fibroid itself, so it will not inadvertently harm the patient. So that is another critical part of doing the myomectomy. And finally, the removal of the fibroid. Since 2014, when we could not, or at least here in the US, the vast majority do not use the mechanical maculator. We have all adapted different things, in-bag macellation using the pneumoliner bag, or cold knife macellation with the fibroid in the bag. And I certainly moved on to that. I feel today, if I were to be given the macellator, I would rather use the inverted omega incision in the umbilicus and remove the fibroid that way, because it's so much faster. I'm not chasing after small pieces of the fibroid that are all over the bowel, which I would meticulously remove in the past for avoiding any disseminated myomatosis. So for that reason, I have clearly become a big fan of in-bag macellation with a knife using a 2.5 centimeter incision. The incision site could be subumbilical, suprapubic, or even vaginal. I have attempted that. I can tell you, when the BMI goes up, your vaginal dystocia goes up, and the problem of removing the fibroid vaginally becomes more acute. So in order to be consistent and be educational for the residents and the fellows as well, I have now almost exclusively become a fan of just subumbilical or suprapubic, as I pointed out. So here's a video, and I think we are coming to the end of the presentation. So I do not have any volume here. So this is a inverted omega subumbilical incision. The head end of the patient is at the top of the screen. So I try to confine my incision to within the umbilical pit, and then dissect the stalk. Make sure that you recognize where the stalk is, so that you are not cutting into the stalk. And then make a small incision on the rectus sheath. You can see the belly of the rectus muscle, and it is very simple. It's not hard at all to make this incision. And then using just the S retractors, widen the incision to allow the single port to be placed. So I do this at the very beginning of the case, so I can use this as the assistant port, and then it is at the end of the case, the fibroid is within the bag, and I use the technique where you literally peel it like an orange rather than coring it like an apple. So thyroid clamps work very well for this. They have 3-tooth rather than a single-tooth tenaculum, or a drape clip, because that also is single tooth. So the triple tooth thyroid clamp, or Leahy's clamp as they call it, is very helpful. The technique here, and this is the one thing that I find it very challenging to teach the residents and fellows, is to peel the orange. Imagine this as an orange, and you have to peel the orange. They all would start cutting deep in, and also the importance of keeping that a line, as a parallel line on either side, so that the fibroid will keep coming out. So when you widen towards the side, the deep inside, the tendency is to widen that strip, and then it'll stop coming out because the incision is only 1 inch long. So it's very important to keep that. And once you master the technique, it's so fast. It's really, really satisfying to take it out. Cosmetically, yes, initially it looks like that, but then when they come back about 4 weeks after surgery, it seems to heal well. I apply a pressure dressing to ensure that there is no, especially with a large BMI patient, that they don't have any collection inside. And finally, post-operative planning, I discharge 98% of my patients post-operatively same day, no matter how big the fibroid. The largest fibroid I have removed laparoscopically is 2.8 kilograms, and she still managed to go home the same day. Ibuprofen around the clock. I tried gabapentin. The only problem is it has to be started the night before the surgery. And I personally feel that ibuprofen around the clock for 5 days with paracetamol to be given as needed works very well, and we very sparingly use any narcotic medications for these patients. 2 weeks after surgery, most of my patients are going home, going back to work, driving themselves to work, etc. So they become very independent. So in conclusion, it's all in the planning and then sticking to the plan. I hope between Sergio and myself, we have emphasized the absolute importance of maintaining the plan, not only to not damage the healthy myometrium, but also to minimize your blood loss. And a mini laparotomy, wherever you can site it, can be very, very helpful. And it's important to track and string the fibroids and use the Bob suture to help yourself and make your surgery faster. And the apposition of the tissue is so much better as well. Thank you so much for your attention.
Thank you, Dr. Bhagwat. That was indeed a great presentation, and you have truly talked about all the tips and tricks that one needs to know while doing a laparoscopic myomectomy surgery. Thank you so much. We will now take up the questions from the audience and the chairpersons. So for the first speaker, Dr. Renu ma'am, can you please take up the questions?
Please unmute yourself.
Sorry. Yeah, so I would like to ask a few questions from Dr. Svetlana. That was very interesting. Like I said before, that we've been using dihydrogesterone for a number of things. And I was looking that there is an article in 1976 where they have talked about dihydrogesterone for endometriosis. And then, but then after that, we haven't been really using in clinical practice. So number one, I wanted to ask you that your results were similar, whether you gave it cyclical or you gave it continuous, which
I stressed in my presentation that previously we have a lot of publication, but the last one was in 2009, I think, regarding the clinical investigation, clinical trials. But I think that our own presentation, our own investigation is one of the largest on the nowadays, and we got the same results in continuous and cycle regime. But I've read maybe 1-2 weeks ago one article which came from the Switzerland, and the authors analyzed the results of using of Dynagest in Switzerland, and they stress that maybe it's necessary to use the continuous regime when the patient suffer from the dysmenorrhea, primary dysmenorrhea, as the first feature of endometriosis in continuous regime, not cycle regime. Maybe now I can think that it could be suitable for our patient regarding the using of dydrogesterone. We can use the prolonged regime among the women which suffer from pain since menarche, and for the cycle regime among women who started to suffer from endometriosis associated pain maybe 20 or later later year age.
Yeah, because
yes, but anyway, we got the same results. And the prevalence of the using of different kind of doses and regime was dependent only on the decision of each investigator.
Right, because we have, I mean, there is quite a lot of literature, and we've also grown up with the fact that endometriosis, if it needs to be treated, you need to stop the menstruation, because that is sort of, if you look at the Samson theory, that's probably feeding in more and more sort of glands and keeps the maybe alive or maybe regenerating more endometriosis. So that's why we'd like to give more of continuous, whether it is progesterone or OC pills. The other thing, are you aware of any study where they have compared dydrogesterone to Dynogest head to head?
No. Oh, we only compare in my own clinical practice, and I've got the same results. That's why I persuade the company, the Abbott company, to create such kind of investigation. And so, aiming at to widely use of dydrogesterone in Russia. And I would like to add some words to your speech that, yes, we previously thought that it's necessary to use the continuous aiming at to suppress the ovulation and to avoid any kind of menstruation. But now we know that even pregnancy sometimes could not inhibit the endometriotic lesion. And maybe 6 months ago, I published in Russia my own results of one case. I operate the women who suffered from the two benign tumors before the pregnancy, before the first pregnancy. I operate her. The size of tumors, they were not endometriotic cyst, but another kind, teratomes. And 6 months later, she got pregnancy, and since the 6th week of pregnancy, she checked that she suffered from the pain. And then at 9th week of pregnancy, we found the endometriotic cyst, and I operate because of stroke pain by laparoscopy at the 14th week of pregnancy with cyst, and the size of the cyst was 8 centimeters. So it's now we understand that pregnancy, sometimes we cannot expect that pregnancy could inhibit the endometriosis. That's why I think that it's not necessary to inhibit the menstruation and inhibit the ovulation when we treat the pain associated with endometriosis. I think so.
Okay, one last question. How many women got pregnant in your study who were wanting to get pregnant?
3 patients got pregnancy, and we have absolute...
Out of how many?
3 patients.
The 3 patients out of how many which wanted to get pregnant got pregnant while they were on?
I think that we don't check. We did not check how many women wanted to be pregnant, but which patient which got pregnancy, they aimed to be pregnant. They desire to be pregnant.
Thank you. Thank you very much.
Thank you.
Dr. Sergio, as we all are doing hysteroscopic myomectomies and being IVF specialists, we are always concerned about endometrial damage during the surgery. So I would like you to comment upon some strategies to minimize the endometrial damage during hysteroscopic myomectomy.
Actually, the damage to the endometrium is minimal. The only concern is when you have 2 myomas confronting each other from different walls, the anterior wall and posterior wall, because in that case, you're going to have adhesions. But as I said before, we don't damage myometrium. Myometrium, they becomes normal because of the contraction of the myometrial fibers. And endometrium, there is the basal layer with the stem cells. Endometrium grows fast, and there is no irreversible damage to that endometrium. That's what happens in all the hysteroscopic surgeries, unless, for example, when you treat T-shaped uterus or you perform metroplasty for a big septum, there is a huge area without endometrium after you finish the surgery. But after you give them treatment, 3 months after, everything looks normal and they can become pregnant. So I'm not concerned about endometrial damage during myomectomy.
Okay, one more thing, Dr. Sergio, do you recommend the use of GnRH analogs before surgery in case of a very big myoma?
No, the thing is that GnRH analogs, they reduce the myoma volume, but the problem here is that they reduce the whole uterus volume. We have a low level of estrogen or no estrogens, though everything is reduced. The thing is, it compact all the tissues and it compact even the plane between the myometrium and the myoma, and it's very difficult to perform good dissection and nucleating the myoma, as you saw, or even in laparoscopy technique or hysteroscopy technique. So I prefer not to use that. As you heard before, myomas, where they are big, you try to find different ways, as Dr. Bhagavat said, to take them out. So I don't use GnRH analogs for many years. The only patients I choose to give them GnRH analogs, there are patients, no reproduction, patients that they are near to the menopause and they have heavy menstrual bleeding due to the fibroids and they don't want to go through surgery. So you give them 3 months of the pot of GnRH analogs, and probably the the hypophysis over an age won't wake up again and she will go into menopause at the same moment. That's the only patients that use GnRH analogs.
One more thing, Dr. Sergio, do you recommend use of misoprostol as Dr. Bhargav has mentioned in his talk? So do you also recommend to reduce the blood supply, to reduce the blood loss during myomectomy? Misoprostol is actually helpful?
What we are now using is something completely different. We make a dilution with the cell line with tranexamic acid. So we put 3 ampoules of tranexamic acid inside 3 liters cell line in order to make a reduction of the bleeding. When you have the reduction of the bleeding, you can work with lower pressure. Lower pressure means less fluid and less risk of overload. That's what we use. Misoprostol we use especially in office procedure in nulliparous or postmenopausal woman in order to repairing the cervix and making it easier to go in, but no doing myomectomy surgery.
One more thing, Dr. Sergio, as sometimes there is difficulty in localization of the myoma. So do you recommend sonosalpingography or just a good ultrasound is enough to localize the myoma? So what is your take on that?
The ultrasound gives you a quite good relation with myoma. The limitation of the ultrasound is when you have multiple myomas. So there is a shade. One myoma the big myomas that make shade and you cannot see exactly all the myomas. In those cases, what we recommend is an MRI. That's the way you can see all the myomas in the uterus. But hysterosapingography doesn't give as good information. The same information from hysterosapingography you can get from 3D ultrasound or for 2D ultrasound.
Can I just ask something, Dr. Sergio?
Yes.
Where are you putting the tranexamic acid? Into the irrigating fluid?
Yes, inside the bag of 3 liters of cell line.
So how does it? I mean, you mean there is a local effect of tranexamic acid?
It goes into the blood vessels. You know, part of the cell line goes into the blood vessel. That's what you have overload. So this there are beautiful works made at the beginning with orthopedic surgery, doing endoscopy for reducing the bleeding. And there is also there are two papers published in hysteroscopy. The fact that this tranexamic acid with the saline that goes into the open blood vessels around the myoma, it reduces the bleeding.
So you mean it is more effective than parenteral if you give it intravenous?
It goes into the blood vessels the same like when you give it parenteral, but in low quantities and more localized.
Any particular recommendations regarding the pressure while you are using tranexamic acid?
No, I always start with the same pressure. I always start with very low pressure. I start with 80 millimeters of mercury. That's my pressure. I usually increase my pressure depending on the bleeding, because that's the only factor that limits my surgery. I walk inside cell lines, so the bleeding, the moment we are bleeding, you cannot see anything. The only factor that limits me is the bleeding, so I have to increase the pressure. The fact that you use this tranexamic acid inside the cell line, it makes me it allows me to work with lower pressure, so I don't have to increase so much the quantity of cell line used by this surgery. The most difficult cases I saw, we have one patient, a young patient with pulmonary edema after 2 liters, and according to the guidelines, you can have a negative balance until 2.5 liters. But after 2 liters of negative balance, she was very hard to waken up. There was a foam coming from her mouth, and she had a pulmonary edema that after 24 hours she was okay. But overload during hysteroscopy with big myomas is something you must be aware of and be very careful. So we have to find a way to reduce the quantity of saline in those myomas. Time it's cell line. So the moment less bleeding, less pressure, less time.
Very correctly said, Dr. Sergio. So here, one more thing is important that I would like to take your take on that. In case of type 2 or type 3 myoma, so do you recommend a 2-stage surgery or just to proceed in a one sitting?
I always explain my patients with big myoma, type 2 and even type 3, that sometimes because of the limitation of time due to the overload, sometimes I will stop and we will have to do a second step. So the only limiting factor is what the nurse is telling me. You have 1 liter negative, you have 1.5 liter, you have 2 liters. So the moment I reach that, I tell 1.5 liters, I tell the anesthesiologist, please give furosemide 20 milligrams IV, and remember that there's 1.5 liters already negative. And when I reach 2 liters, I stop. I don't want to get into complications. And even if I still need to work, I explained before procedure that sometimes it happens, and two steps are going to be needed.
Thank you, Dr. Sergio.
So my question for Dr. Bhagwat is, any tips on suturing when there is inadvertent opening of the endometrial cavity? So please unmute yourself.
Thank you. That's an excellent question. I did not address that in my talk. One thing is I do not use any antibiotics for myomectomies, but when I enter the cavity, I do cover them with the antibiotics. With very little evidence for that, but just general principles, I guess, because now we have encroached on a potentially contaminated space. But in addition to that, in terms of suturing, I try to avoid placing the suture through the endometrium. I use a 3-0 V-lock, and I would go myometrium just, sub-mucosal, into the concept, if you can imagine it. So I would take the suture through submucosal to submucosal on the myometrium, just approximating the cavity rather than going through the cavity. Occasionally, you have to go through the cavity because you're not getting a good bite. That's okay once in a while. But for the most part, I try to avoid placing the suture in the cavity, obviously to avoid any adhesion formation afterwards. But otherwise, I do manage to take that separately. I don't like to just take a full length myometrial apposition, hoping that the endometrial defect will be closed. I make sure that I close that separately, paying attention that it is approximated properly before moving on to the apposition of the myometrial layer.
Dr. Bhagwat, the mechanical morcellation in bag which you showed was really very, very interesting. So do you, when you create that port, do you put the bag which we otherwise use for in-bag morcellation, you put it inside, put all the myomas in, and then pull it out?
That is correct. And I do that at the very end. So I don't have the bag in there when I'm operating on the myomas. But once I'm ready to do at the end of the case, all the myometrial closures occurred, and I'm ready to start the marceline. At that point, we'd open the cap, of the single port, put the bag in, close that, and then I gather. Now that they're all stringed up, it's easy. You just grab the string, you hold it up, and get the myoma bag in the bag underneath, and get the myomas in, and then you pull the mouth of the bag out. That is correct.
And I'm sure it saves a lot of time compared to electrical morcellation because you're just picking up little myomas.
Sure, if they are smaller than, yeah. But even the 3
ones, of
centimeter
course.
myoma, you need to marcellate just a couple of cuts at least to get it out.
Yeah.
But the larger the myomas, the longer it takes to get them out. But it certainly saves a lot.
And still quicker than the electrical morcellation.
Without doubt, because just before I stopped doing electrical morcellation, I used 1.5 centimeter morcellator. So I had moved from 10 millimeter to 1.5 centimeter. So now we had to close that port because the bigger incision, it was on the side. Sometimes they would get ilioinguinal nerve entrapment and pain from that. So it had its own problems. And when it was banned, it was initially a big angst. Oh my God, they banned this, crazy people. But in effect, actually, the subumbilical morcellation, now I wouldn't go back, even if they allowed me to do it. I wouldn't go back because it's so much faster to take it out. Plus, I'm not picking up all those tiny pieces from within the bowel. Inevitably, there are tiny pieces that you have to chase after. So you don't have to do that. At the end of the morcellation, take the bag out, all these tiny pieces are there in there. There are not that many of them anyway when you're using the knife to morcellate.
It's worth trying.
Oh, not trying, you can do it. It's definitely worth adopting.
So do you think there's some category of patient wherein LDH should be done and would give a pre-op idea apart from the MRI imaging?
Yes.
About the nature
Excellent
of
question. I just published a paper on that in FNS, the latest, I think. I don't know if it's in print or not. So we looked at that. This LDH idea came originally from Japan, and then the Spanish group that published a beautiful thing. They created this index they call the Magna Carta Index, or UMG, University Magna Carta Index, because that's the university name, which was intriguing and very exciting. But when we applied it to our patient group, that was definitely the same index was not helpful. So I still do it. I actually do it because if there is an excessive increase, I would like to know. But thankfully, to date, I have not come across a single patient with sarcoma, leiomyosarcoma. So I've been lucky. For the number of myomectomies I do, I have been very lucky. I am sure one day I'm going to be hit by that train wreck. But the whole thing is in the counseling of the patients. I spend a considerable amount of time telling them about the controversy, telling them about their options. The only way they can, you see, the moment you do a myomectomy, it doesn't matter. If they don't want to.
Renu, we need to wind up, please.
Sure. So the answer is, if they are doing a myomectomy, they are taking a risk. Even if you do an open myomectomy, they are taking a risk if it's a leiomyosarcoma. So their risk is there anyway. So I do counsel them about that ahead of time.
So with this, we come to the end of the session. And I thank the esteemed chairpersons and the speakers for a very interesting session. Thank you so much.
Thank you very much.
Thank you.
Thank you all. Nice meeting everybody on virtual.
Thank you. Thank you. And bye-bye.
Bye-bye.